Can we?
Hello.
Hello.
Five,
Hello.
4, 3, 2, 1, start.
Very good morning, all of you. A warm welcome from Sun Pharma, the number one pharmaceutical company in India and fourth largest pharmaceutical company in the entire world. And today we have fifth of its series from Dr. Satish Jain and Dr. Rajeev Pachauri, and where we have been conducting our webinar.
Check kar lo.
And today we have Galaxy of Stars, star speakers today, Dr. Samir Bhargav, and we have Dr. Prabhakaran Narayanan as our guest faculty, and also Dr. Muaz Ribichi from in from the world. So this today again, again it is a dedication to Professor Ain Stamberger. So over to Dr. Rajeev Pachauri for the program. Thank you.
Good morning, dear friends from India, abroad. And I think you have enjoyed our previous workshops, previous webinars. And today is the fifth one of the series of Explore the Legends. And our legend is Dr. Satish Jain. I think you must have enjoyed all our previous 4 webinars. And those, I think all of us have seen it. Those who have missed it, they can go to the YouTube and they can just write down Dr. Satish Jain, Dr. Rajeev Pachauri, and they can find out all the recordings. And all the recordings are wonderful and 5 or 6 hours recording. So you will not miss anything in future also. And already more than 3,000 people already logged in, and more than 100 questions are on the screen. And today being the one more day is that is Father's Day, and I think all the best wishes for all of you. And being the Father's Day, this is the best day for us to remember our Professor Stamberger. He is known as the father of endoscopic sinus surgery, though he is not physically with us, but his soul, his guidance, his enjoy the webinar today, the 6-7 hours Cadaveric dissection by Dr. Satish Jain. And any questions, anything you can ask, you are free to ask any question to Dr. Paramita, and she will share all the points. Anything from Dr. Paramita from your side, any suggestion?
I think good morning, one and all. Welcome once again to our webinar. We have all legends today with us to share their expertise in this field. And we are really, really thankful to Dr. Satish Jain and Dr. Rajeev Pachauri sir for organizing this huge event, this huge event for all of us in this COVID-19 pandemic situation. As we all know, it is so difficult. But we are really thankful to them for organizing this for us so that we can learn more and more. And you can ask any questions to us. We will take it ahead. If you want to ask any specific questions to any of these legends, you can also mention that. We can ask them individually as well.
Good. So over to Dr. Satish. And now, thank you.
Thank you, boss. So good morning, everyone. For this, I would say a big day for us for many reasons today. The reason we all know from the invite in remembrance to someone who is considered to be the father of this endoscopic sinus surgery, who has actually revolutionized the concept, and why we are gathered together to learn the science of endoscopic sinus surgery is only because of him. So it's all because of Professor Stamberger, and we'll have a short 10 minutes break around 12:30 for a small program to remember him with some legends in the world joining us today. Thank you for that. And another reason for the big day is our guest. And it gives me immense pleasure to introduce someone who is so close to my heart, Professor Prabhakaran Narayan from Malaysia. He is amongst the few persons I told you is so close to heart for many reasons, for his humbleness, for his knowledge, for his work, what he has committed to and what he has given to the society. Believe me, if I introduce him through his CV, this 7 hours today will fall short. This much of work this man has done in his life. He is presently the professor and head of department at the University of Malaya in Malaysia, and has worked in almost all premier institutes of the world. He has to have his credit of so many publications, so many teaching courses. He's been invited more than 300 times to various international courses. You can imagine how much experience he has, and he is amongst the few who is a complete 360-degree skull-based surgeon. And this is very important. Now we'll discuss in the dissection as well, who is equally good in endoscopic, lateral, open approaches, transcranial, everywhere. And I have several times attended his courses, his lectures, and he's amazing. Every time is a new experience we get out of his wisdom. Thank you, Prabha, for being with us. And thank you so much for sparing your valuable time. And next is to introduce our dear friend, our brother, Dr. Sameer Bhargav. We all know he doesn't need any introduction. He's our own from Mumbai, and he's been attached to the various prestigious medical colleges and institutions in Mumbai, particularly to the HBT Medical College, Cooper's Hospital, Hinduja Center, and many more premier institutes, and involved in teaching and training for years together. And for that, for the clinicians, he has authored a book as well, which is a very popular book in the ENT circuit. And presently, he is something you all know, he is the president of our Association of Otolaryngologists of India. Thank you, Sameer, for sparing your valuable time in spite of your busy schedule today. We know you had a lot of hang-ups today. Thank you for being with us. And I assure audience, these are the people who will enlighten us with their knowledge and will be surely benefited out of their presence here today. So, Prepa, feel free to interrupt me anytime. Feel free to comment, and I request audience to ask these luminaries any question they have in their mind. And this is something not books, this is something out of their experience. We all are going to be benefited. So, regarding today's program, before we start, I would like to acknowledge certain people who have been the backbone in organizing this fresh frozen cadaver today. And I'm indeed grateful to, how we get cadaver in Jaipur. And this I've been having for several years. We are grateful to our Commissioner of Police here, who has been kind enough to provide us cadavers, unclaimed bodies, after the necessary formalities before they dispose of the body for the cadaveric, for the teaching and training purpose they give us. And that is how we get a cadaver. And this is the best, something I would say, the best way to learn the surgical steps. So indeed, I am grateful to our Commissioner of Police here, Mr. Anand Srivastav and Mr. Yogesh Dadij, for extending this big help. And the second, thanks to our leaders in our community, in Jain community in Jaipur, we have been persuading for years all Jain people to donate their body for the teaching and training purpose. And this is the 116th body which I am dissecting today, which is a donated one from this community. So I am grateful to those people who have been persuading all this, and that's how we are getting these bodies. So this body, the man who died yesterday, and it's ultra fresh. If you get the endoscopic picture, can you give a glimpse of it? You'll be amazed to see like a live surgery going on. So this is ultra fresh, you can say. And the plans for today, our plan is, as we said, we'll start with the basics with the endonasal anatomy, dissection of paranasal sinuses. We have discussed a lot in the previous webinars and the live surgical sessions, but cadaver is something special where you can show more and more procedure in a less period of time. So we'll be showing all the approaches to each and every sinus, not only endoscopic, but whenever required, the open and the extended approaches as well, particularly the maxillary sinus. We'll discuss all extended approaches to the frontal sinus, as many as 5 types of draft or modified Lothrop's procedures, along with the open procedures like osteoplastic flap, cranialization of the frontal sinus, facialization, orbital transposition to go far laterally into the frontal and all that. After that, we'll move on to the various intranasal flaps, which are very important. When we think of endoscopy skull-based surgery, how this science has, lifted up the science of endoscopic skull-base surgery is because of the availability of better reconstructions materials, and particularly the vascularized flap now. Ever since the Haddad and Basagestgi gifted this world that flap, which revolutionized the endoscopic sinus surgery, endoscopic skull-base surgery, there are so many flaps which have been introduced more and more now to reconstruct the skull base in different situations. So we'll be demonstrating all those flaps, intranasal as well as extranasal, which can be used for the reconstruction of the skull base in particular conditions. And after that, we will move to the surrounding areas like anatomy of the orbit in detail from inside the orbital approaches, as well as from the transcranial side, each and every fine structure in the orbit, neurovascular structures, particularly how they are coming inside the orbit from the optic canal and superior orbital fissure to go to their destination, to the various parts of the orbit, and the various highways to enter into the orbit. And after that, we'll go to the surrounding areas. We'll discuss about something about the nasolacrimal system, the Denker's approach, then the pterygopalatine fossa, infratemporal fossa, sphenoid, skull base, cavernous sinus, orbital apex, and then move on further to the other advanced skull base approaches. So let's see how much we can do today. Otherwise, we'll carry on further. And as you all know, we have already announced our webinars on Sundays and Thursday. So this Thursday again is always dedicated to the live surgical session. So this Thursday again, we are coming back with the advanced skull base cases, live surgical demonstration from basic to advanced. And the next Sunday again with the cadaver and other advanced things. So thank you very much once again for joining us. And please feel free to ask questions, to send questions. Your questions are benefiting everyone. So it's I would say, obligation to us if you send questions so that we can discuss and everyone can be benefited. So, Dr. Prabhakaran, can we go ahead?
Yes, please, please.
Anything you want to comment or you want to suggest before we start, please?
I think it's fine. It's perfect.
Great.
Let's start. Yes.
Thank you. So, friends, this is the left side of the nasal cavity. I hope the picture is good. Or let me do a white balance. Just a minute to begin with. This laboratory at this prestigious institute, I introduced last time the chairman of this institute who has been kind enough in such academic activities. He is allowing us, and he is an amazing person with a open mind person who is inclined towards propagating the academic concepts. So I am really grateful to him, Mr. Sandeep Bakshi, for giving this opportunity again. So this is the left nasal cavity. Can you see this?
Yeah, very clearly.
Okay, so this side is the nasal septum. As I mentioned, we'll dissect this later with the flap, the Haddad flap later. On the right side, for the sinus surgeon, the key area of interest is in the lateral wall of the nose. This lateral wall anatomy is important to understand for every sinus surgeon. And to begin with, on this endoscopy, I'll just enumerate certain landmarks. So in the lateral wall, there are certain protuberances, certain depressions you can see all over. So this first structure in the lateral nasal wall, inferiorly, to begin with, is the inferior turbinate. You know, there are certain turbinates, prominences in the lateral wall. This is inferior turbinate, this is middle turbinate, and above that is the superior turbinate. You know, so these are the turbinates which are prominences or protuberances in the lateral wall, which leads to certain recesses underneath them. So this is the inferior turbinate. We'll discuss later in detail how important this is to us. So this is covered by a special tissue which is important in regulating the airflow and mediating certain reflexes. As we go behind this, we enter into a space, and that is known as choana. That is known as choana. This is a very important area. This space is choana, And as we go further, we see certain protuberance behind in the choana. And these are on either side the protuberance of the cartilage of the eustachian tube. Can you see this?
Yeah, very clearly.
Cartilage of the eustachian tube on either side, covering the eustachian tube orifice, which is leading laterally towards the middle ear. And there is another space behind this, for the skull-based surgeon, it is very, very important. We'll see the importance later on, how important as a landmark it is. See, as I go behind, there is a cleft which is enclosed behind the eustachian tube far laterally. That is the fossa of Rosenmuller, which is a very important landmark for the skull-based surgeons to pointing towards the parapharyngeal carotid artery. Now, underneath this inferior turbinate is an important area. See, this is inferior meatus. This area is inferior meatus. It hardly contains any important structure except in the anterior part in the roof. See, I am coming there. Except in the anterior part of the roof, there is, see this? When I press on the medial angle of the orbit, see this? There is a lower opening of a duct which opens through a wall in the inferior meatus known as valve of Hassner's. So it opens in the anterior part of the inferior meatus in the roof, and it delivers the transport of the tears into the nose from the eye. And the malfunction of this system results into epiphora, which requires a formal procedure of cystorhinostomy. We'll show this entire anatomy of this system as well today. So now, coming from this inferior meatus above, this is a flat area in the medial wall of the maxilla, or the lateral wall of the nose, with relatively no neurovascular structures over here, known as atrium. And behind are the important areas the protuberance starts. So the first protuberance belongs again to the nasolacrimal duct, which comes from above and open here in the inferior meatus, which we have seen just now. Behind this protuberance, this another protuberance. Can you see this mobile structure?
Yeah.
Yes.
That's the only mobile structure in the entire lateral nasal wall. That is known as uncinate process, and it has a huge bearing on the drainage flow or the outflow of the frontal sinus. We'll see. We have discussed in the radiology also. So it has two parts, the upper vertical part and the lower horizontal part going behind, if you follow this, to a variable distance. Sometime it ends here into the inferior turbinate only, and sometime it goes beyond up to the perpendicular plate of the palatine bone. Here is the palatine bone perpendicular plate behind the maxilla, and here is the horizontal plate of the palatine bone completing the hard palate. So it is horizontal plate, and this is the perpendicular plate, and the anatomy of the perpendicular plate is very important to understand for the sinus surgeons. Now, so this is uncinate process, which is generally considered to be the first step in sinus surgery. And as we all know, the well begun is half done. So a good uncinectomy is always a very important step for the sinus surgeon to accomplish a good sinus surgery. Now, moving behind the uncinate is a narrow cleft. This is a two-dimensional cleft where I am insinuating my ball probe. This is known as hiatus semilunaris inferioris. This is hiatus. It is a semilunar shaped hiatus between this prominence and the next prominence behind, that is bulla ethmoidalis. That is the anterior ethmoidal cell. And this hiatus, will see once I remove the uncinate, how it leads laterally into a three-dimensional space that is known as infundibulum. So once I open this space, this step is known as infundibulotomy if I remove this uncinate to uncover the infundibulum, which is actually a three-dimensional space into which the maxillary sinus ostium opens. So this is bulla ethmoidalis. Now going behind the bulla is again a recess. See this? This is a retrobullar recess. And how it is completed? This is the bulla behind this recess, and behind this a part of middle turbinate. So now, coming to the most important anatomy for the sinus surgeon, which remains all the way and which is required to be understood and respected and maintained, is the middle turbinate. So this middle turbinate is one of the most important structure you can see in this part of the nose. So it has practically three parts in three different planes contributing to its stability. This is the most important structures which orients us throughout the sinus surgery, And stability of this step is very important. And here I welcome our colleague, neurosurgeon friend and the boss, Dr. Pankaj Gupta, who has joined us. And he has been our part of our skull-based team for years when we started together. So welcome, boss. So this is the middle turbinate. It, as I mentioned, it has three parts. The anterior-most part lying in the sagittal plane, going up anteriorly, inserting onto this frontonasal process, and the posterior part going high up to insert onto the cribriform plate, a very important area at the junction of horizontal and lateral lamella. That's why this turbinate has to be gently handled as you go up towards the cribriform so as not to give a damage to the cribriform and get a distant CSF leak. So this is one first important part lying in the sagittal plane. Then this turbinate, as you go behind, turns laterally in the coronal plane to insert onto the lamina papyracea. That is the second part of the turbinate lying in the coronal plane. And this space anterior to this and behind the bulla is the retrobular recess. Okay? And the third part, this sagittal part of the turbinate, continuing behind in the axial plane, lying, see, almost going to the roof of the nasopharynx, or sometime to the medial pterygoid plate, or the perpendicular plate of the palatine bone. And this goes like this in the axial plane, known as the third part of the turbinate. So all these parts together in different planes contribute to the stability of the turbinate. This is a very important structure anatomically as well as functionally. The reason is all the cells which open anterior to the turbinate, they drain anterior to it, like all sinuses, maxillary, the frontal to the frontal outflow tract here, and the anterethmoids, all staying anterior to the ground lamella, they drain anterior to it. And all cells like posterior-ethmoidal and sphenoid, which are behind the ground lamella, they drain behind it through the sphenoethmoidal recess. So this is important anatomically as well as functionally as we deal with a surgery known as functional endoscopic sinus surgery. So we have to all the time respect anything which has a bearing on the function of the nose overall. Now, going behind, if I medialize this turbinate a little bit here to show you something, going behind, there is another turbinate. See this? There is another turbinate there. That is superior turbinate. The superior turbinate and medial to the superior turbinate, this is the posterior part of the nasal septum, is an opening known as sphenoid sinus osti. Right in the midline. Medial to the superior turbinate, and as I told you, behind this ground lamella is the posterior ethmoid sinus. So posterior ethmoid sinus and the sphenoid sinus, they drain behind the ground lamella, and that region is known as sphenoethmoidal recess. This sphenoid sinus is considered, for the skull-based surgeon, is considered to be the center of universe. We all know the sphenoid bone, which is centered in the center part of the skull, is so complex a bone and has amazing relationship with the surrounding neurovascular structures. The science of skull-based surgery is standing or based on this fact that this particular bone is pneumatized, and that gives us access, this gives us space to address the surrounding neurovascular structures directly without mobilizing the cerebral and other structures, and we can address them directly through this pneumatized space. And that is the basis of endoscopic skull-based surgery. So we'll move on to the skull-based later. So first, this is important for the junior colleagues, for the skull-based surgeon, for the team of skull-based surgeon, maybe neurosurgeon, to understand this endonasal anatomy. It's not important for ENT surgeons only. Those wish to pursue their career in endoscopic skull-based surgery must be well versed with the anatomy of the paranasal sinuses, nose and paranasal sinuses, and the surroundings in detail. So this is about the initial, description of the endoscopic picture. Prabhakaran, anything you would like to comment or you do differently, please.
No, it's fine. It's very thorough. I like the way you correlated the soft tissue and the bony landmarks together. So that's a very nice overview before we start. Very nice, lovely.
Thank you. Samir, do we go ahead?
Yeah, please. The only thing is in a live surgery, if that inferior turbinate, sometimes we tend to outfracture it to get access posteriorly. So that helps in a little cramped up and narrow space.
Yes, that's a very important point elaborated. See this, what he's trying to say is sometimes this is over projecting, the bony projection, and what you can do simply by means of the back end of your curate, you can out fracture it to enlarge the space, the working space, and the area overall. And this, lot of studies have been, go to the literature. Now they say this works for at least 6 months. It may come back, but at least 6 months it works very well. And until then, if the surrounding inflammation goes down, it may not swell up and may not give the same problem again. So it's always a advantageous procedure if you do this, in case it is too hypertrophied or projecting medially and blocking the airway. So it is always good. Thank you, Samir, for pointing out. So now, coming to the sinus surgery part. Paramita, you can interrupt me anytime with question.
Yes, sir.
So now,
Sir, there are almost initially only at this stage, there are almost more than 3,000 people are watching you, and I'm getting messages from Pakistan, Afghanistan, Bangladesh, everywhere that out of which, sir, I would just like to point out this Dr. Riaz Afridi from Pakistan. He sent you a message that, sir, I'm COVID positive.
I know. I am praying God for last 4 days.
So he is watching. So our prayers and wishes are with him for the early recovery.
He's very good friend of all of us. He's very regular in.
And I'm praying God for his fast recovery. And he was treating COVID patient there and finally turned out to acquiring the infection. So pray God, everyone, I'll request for his faster recovery.
Yes, sir.
So now coming to the yes.
Dr. Satish, you just showed us the nasolateral duct opening. What is the exact anatomy? Means where exactly in the lateral wall and that?
Yes. So in the inferior meatus, this is important when sometime you do a inferior antrostomy, inferior meatal antrostomy, so as not to damage the orifice. So this lower end of the nasolacrimal duct actually opens. See, this is the anterior head of the middle turbinate.
Yeah.
Exactly 1 centimeter behind in the roof of the inferior meatus. See, in the roof.
Yeah.
In the roof it opens from here 1 centimeter behind. So when you carry out the inferior meatal antrostomy, though nowadays it is almost obsolete to do inferior meatal antrostomy, so not to run towards the roof of the attachment of the middle turbinate, rather stay in the floor and little behind, so as to avoid injury to the nasolacrimal duct. And in these days, though it was earlier, considered for the drainage of the sinus, and after the Messer-Kliner and Stamberger revolutionized the concept of drainage pathway of the paranasal sinuses and sinus surgery came in, this procedure remained obsolete. But now, as more and more advanced lesions of the paramedian plane are being addressed through the endoscope, this again a lot of people use as another avenue for the instrumentation inside the maxillary sinus. But believe me, I will my message to them today, once they see the advanced procedures of the maxillary sinus, this no longer to be a beneficial procedure in the present context for any indication, this inferior mesial antrostomy, and for me, this is as good as obsolete for any purpose. Now, coming to the steps of the sinus surgery, as I mentioned, we'll start with the steps of the basics of the sinus surgery on both sides, and then we'll go to the advanced sinus surgery maneuvers, advanced maneuvers to the maxillary sinus, frontal sinus, and all sinuses for that matter, including open approaches. So for the basics, the first step, as I said, is uncinectomy. And as I said, the well begun is half done, so a good uncinectomy is important. You know, when this surgery burst in 70s, this uncinectomy would be done by using a sickle knife all along its attachment to the lateral nasal wall, all the way till the horizontal segment is going. This used to be a popular step to begin with. But the only concern to me with this, still a lot of people are doing, is I will show exactly once I remove this, how close this upper part of the uncinate to the lateral nasal wall. And sometimes when it is too close and if you are not careful, you can get an accidental entry into the orbit. That too at the beginning of the procedures, which is counterproductive to the surgeon, to the attitude, to the temperament of the surgeon, and that is something to be avoided. Particularly if a junior colleague is doing, this is detrimental for him. May not be detrimental to the patient, this small complication, but this is something to be avoided. So what we propagate, this is like we discussed last time when Professor Sethi was there, we use the reverse biting. See this reverse biting? One word for the instrumentation for the junior colleagues. See this, I am in the left side of the nose. Take the advantage of this columella to park your endoscope, to take the help of the endoscope stability to park along the columella, and then introduce your instrument along the lateral nasal wall. Whenever you go in, your instrument along with telescope should go in. Whenever you come out, they should come out together. You want to show through the see through the external camera?
Yes, sir. Many are requesting you to.
Can you put a PIP? PIP jayega?
So also, Dr. Vinay Kule from Navi Mumbai wants to know the exact location for maxillary ostium and accessory ostium and the mucosal fold over it. So can you just show it once again?
Yeah, I will show if there are accessory ostium and show the importance of it.
Clinically, what is the occurrence of accessory ostium in your practice, in surgical practice?
It's variable. But yes, in 20 to 30% of the patient you can get. But the importance is once it is, you have to communicate to the natural ostium is always better. So what I'm trying to show, are you getting the external camera picture?
Yeah.
See my hands. My telescope is going along the columella, pressing on the columella, and my instrument is going along the lateral nasal wall. So instruments are converging. Keep your instrument ahead and navigate with your telescope behind. See this? As you go in, bring out together, introduce together. So you don't traumatize the surrounding mucosal areas, which is important for function preservation point of view. So what we are using here is a reverse biting. Engage your reverse biting in the hiatus semilunaris inferioris, like this. We advocate to turn it little down to stay away from the nasolacrimal system, as it is farther as you go down, and bite through it. Bite through it. Advance further anteriorly until you come across the hard bone. See this. The moment you come across the hard bone, you have to step, otherwise you may bite through the nasolacrimal system. See this, what I have opened. Yes. This is the three-dimensional infundibulum, can you see? And into which this is the ostium of the maxillary sinus. Can you see laterally?
Yes.
This far laterally is the ostium. So whatever defects you may find in the lateral nasal wall looking like ostium are never natural osteums. Okay? What are those? Like Paramita mentioned just now, those are accessory ostium. If you find some opening in this region, maybe anterior or posterior to uncinate, looking like ostium, they are never natural ostium. They are always accessory ostium or fontanelle, where the bone is deficient and only 2 layers of mucosa on the other side forming the walls of the fontanelle. So those are punched out defects. They are never seen through 0 degree. And what I can do now, I can debride this redundant mucosa and this portion of the uncinate to open it further. So this is a sort of middle meatal enterostomy. See, the same thing is done by various people by various means. You can carry out. The important thing to carry out is not to peel off the mucosa to bare the area. At the same time, you can evert a little bit of mucosa and communicate if any accessory ostium there to the natural ostium. These are the important things to carry out. I'm carrying out this middle meatal enterostomy. Anything differently you do, Prabha? It looks like you want to comment something.
No, it's nice. I like the way you explain the whole thing. What I usually do, technique is a retrograde uncinectomy. You come from the back to the front. I usually do antegrade, like what was traditionally taught, but I don't use a sickle knife. I use a Freer's elevator. If you touch
elevator.
the process,
Okay.
You see it swing, you will know exactly the location of the lateral attachment of the answer process.
Yes.
If you put a Frears elevator into that location and you only remove the answer and you go downwards, you take away the tail. The most important part of ansonectomy is to remove the tail, which Satish has showed beautifully. But not often, if you do a retrograde with a backbiter, will the tail go away. If you do not remove the tail of the ansonec process, the maxillary ostia is never fully open.
Yes.
So that is a different way of doing things, but the aim is the same. But the most important thing, I think, as what Satish has showed beautifully, is we need to preserve the mucosa all around the maxillary ostia. There's no point making a large opening if the mucosa is damaged and your mucociliary clearance is gone. One of the commonest mistakes that people do is they make a very large opening, but in the process of doing so, the mucociliary clearance is damaged because all the mucosa circumferentially along the maxillary sinus is damaged as well.
Yes, yes. That's a very important point you have highlighted. And that is something, a message to the colleagues, everyone, that preserve the mucosa. That is most important.
It's not the size that matters. The size doesn't matter. For function.
Function matters. That is the take-home message. It is the size which doesn't matter that much as compared to the function preservation by means of preserving the mucosa. That is most important. Now, coming to the point you have made about the size.
Satish, two more points.
Yes, please.
That when you go in with your, whether it is your backbiter or whether it is the microdebrider blade, make sure that it goes in closed, because if you're opening the instrument and going in, you're creating too much of trauma. And the same holds good for the microdebrider blade. And not to create both anterior and posterior raw area in the maxillary sinus opening when you're trying to widen, because that's where you will finally then land up with a circumferential reduction in the size. So either we go posterior, which most of the time we do, or sometimes a little anterior.
Yeah, and that will affect the mucociliary clearance as well.
Yes, yes.
So that's an important point in introduction of the instrument, like Samir has mentioned. See, if we traumatize the opposing mucosas in the nasal cavity, what will happen ultimately, leading to too much of crusting and synechias. And you know, in the sinus surgery we discussed in the first webinar, the concept, the goal of sinus surgery nowadays more and more is to introduce post-operatively steroid solution. And if you get a lot of synechia, that defeats the entire purpose. So as a small step, what Samir has mentioned to prevent synechia formation is the introduction and bringing out the instrument how you do, it matters. And that is something important as an important point in our practice.
So which degree endoscope are you using right now?
Right now, wide angle 0 degree. But I tell you, for this question, I use only two telescopes, 0 and 70. And that for that matter, how I'm used to, I find 70 degree to be more versatile for the reasons I'll tell you. And my message is, we must get used to the angle telescope to carry out some, the visualization of certain different difficult areas, making them under vision to carry out the work without giving complication. So now, this size, like Dr. Prabhakaran mentioned, doesn't matter much. Yes, agree to him. And this is an adequate size for a regular sinus surgery. But, and as we all know now, the indications are expanding and we are doing for much more indications than only the inflammatory diseases of the paranasal sinuses. Why we are gathered here from understanding the anatomy of nose to the skull base. You know why? In 70s, when this science of endoscopic sinus surgery burst, because of this phenomenal work by Messer-Klinger and Stemberger, it revolutionized the concept of endoscopic sinus surgery. It revolutionized the concept of treating the chronic rhinosinusitis. But as it came into the practice, the applications kept on expanding. Now, in the present context, this is not only the preferred treatment for the chronic inflammatory disease of the paranasal sinuses, but other non-inflammatory lesions of the paranasal sinuses, like even tumors of the paranasal sinuses, not only benign, even malignant tumors. Again, not only paranasal sinuses, but beyond the surrounding areas, like I mentioned, we'll show the anatomy, like pterygopalatine fossa, infratemporal fossa, parapharyngeal, all the lesions, de novo lesions of their area or the lesions extending to those areas, the preferred technique approach is endoscopic with certain advantages we'll enumerate. Lesions of the orbit, particularly the medial lesions, the best approach is endoscopy in the present context with minimum morbidity. And not only that, the skull base. Not only lesions of the skull base, benign or malignant, whatever, but it has become a preferred approach for many of the intracranial lesions now. With more and more advancement in the surgical technique, in the instrumentation, in the equipment, image-guided surgery, radiology, and this, I can attribute this advancement to so many things which had made possible now this endoscopic approach to be the preferred approach for addressing so many things. So we need to understand the three-dimensional anatomy of the entire region. And that's why I believe this science of endoscopic surgery is the fastest growing subspecialty in the entire medical science now, as more and more indications and applications are expanding. So nowadays, for different indications, we need to enlarge and give a mega middle meatal antrostomy. So like I have extensive fungus which requires a long-term surveillance. I need to enlarge this, not only for surveillance, but for introduction of my steroid solution or other solutions in the post-op period. So we create a mega middle meatal antrostomy. How can you enlarge this? See what is there in the posterior wall, medially here. This is perpendicular plate of the palatine bone. So I can enlarge it at the expense of the perpendicular plate of the palatine bone, posteriorly till the posterior wall. See this? Acha de, through cut de. Acha. Give me a good through cut. दूसरा दे. नहीं, टेढ़ा. ये दे. So I can enlarge this medial wall posteriorly and flush this till the posterior wall to give a mega middle meatal antrostomy, you know. So that is horizontally a mega middle meatal antrostomy. If I want further with more gravitational drainage, I can flush it till the floor of the nose.
Yeah.
Or if you want further surveillance, gravitational drainage, like many a times we do for tumors, we can do a complete, medial maxillectomy so that the entire maxillary sinus can be marsupialized to the floor of the nose or nasal cavity. So the variety of middle meatal antrostomies can be accomplished according to the need for the indications you are doing for, and that's how we should be able to do all this. So you can enlarge according to the need. Here, at this point, we must be careful about certain things. Though I will come later in detail about the anatomy in this region, but here I need to point out certain issues. See this? The posterior part of this bone. This is the palatine bone. Can you see this?
Yeah.
This is the palatine bone, and see posteriorly the attachment of the middle turbinate.
Yeah.
See this? And see something coming out.
Yeah.
From behind the posterior wall of the maxilla. And that is the something, if you follow. See a lot of nerve fibers which I have severed. Can you see these nerve fibers?
Very clearly.
These are the posterior nasal nerve fibers coming through this pterygoid bone into this flap. See this? And this crest of the bone. See this crest of the bone? If I punch out this bone,
yes, sir,
immediately behind that is the sphenopalatine artery. So we'll come to that anatomy a lot later, but see how this is in close proximity to where we are working. Yes.
Satish sir, can you show us the blocks then? The blocks that we give.
What?
Blocks? You're not giving now.
The block. Do you
local blocks?
The sphenopalatine artery, local blocks.
Local blocks, I told you during live surgery, in any nasal or the skull-based procedures, we are not infiltrating at all. We are solely relying on the pre-operative preparation, intraoperative preparation, including topical saline adrenaline, And the anesthesia help from the anesthetist by means of reducing the cardiac output, by means of reducing the heart rate. All those things together, along with doing all these procedures in the reverse Trendelenburg position, we're able to get a good optimized field rather than infiltrating and giving unnecessarily an opportunity for the adrenaline to spread in the systemic circulation and give complications. So we don't infiltrate for that matter.
Okay, sir.
Yes, for the reason you asked, few years back, Professor P.J. Wormwold publicized and propagated the concept of infiltration in the, the Greater Palatine Canal. And he published a paper sounding a huge benefit when you infiltrate the Greater Palatine Canal in the surgical field, overall surgical field. So, I can show that you have to infiltrate through the, oral cavity anterior to the 1 centimeter anterior to the palate and go in the Greater Palatine Canal and inject so that it gives a spasm in the vessel overall, that is sphenopalatine artery. So that has an impact. You can use it in tumors, but now with the overall preparation, like I said, you don't feel like doing it. A lot of people are not doing it for that matter. Prabhakaran, are you using any time?
No, I don't infiltrate either. I do the same way, just the packs. Because I usually pack the nose before I scrub. So by the time I scrub and come back and get everything ready, it's almost 10 to 15 minutes. That gives more than adequate chance for the vasoconstriction. So I don't infiltrate either.
Oh, great. So we belong to the same philosophy, not infiltrating. And unnecessarily, I believe it's a good way of preventing unnecessarily complications of the infiltration.
So Satish is very good point for PG. They maybe query for them. Said what is the technique that master technique from anterior to posterior or Bormal technique from posterior to anterior? What exactly it is from where we move and where we come out from the nose?
Yeah, we'll discuss all that. For that matter, see, this science is evolving. I'm removing the upper part of the uncinate, with a red 40 debrider.
And here you tell us the upper limit till where you will have to remove the uncinate.
Yeah, that's what I'm coming to the very important part. Now see what I'm trying to say here, like I mentioned to Professor Prabhakaran, why we use this reverse biting for the uncinate and not the sickle. See this, as I remove the upper part of the uncinate, how close this is to the medial orbital wall. This is medial orbital wall where this bulla ethmoidalis is attached to. And many a times we have seen this is even more closer to this uncinate, and the moment you stab your sickle knife, you are in the orbit. So you have to be very good at the radiology if it is so close to, and avoid that. And Professor Prabhakaran is so experienced. He can blindedly do all this. But for the junior colleagues, always go to the radiology, see if it is very close to, then you have to stay more careful. That is the bottom line. And see, this is the medial wall of the orbit. At the first step of the uncinectomy, we reach the lateral wall of our limit of the entire paranasal sinus dissection. What's my point? So that's the lateral wall of our corridor. That too at the beginning of the surgery, at the first step of uncinectomy, when you remove the upper part of the uncinate. Okay? Now, coming to the Paramita's question, that's very relevant. How to go up and how far to go up to remove the upper part of the uncinate. I mentioned in the beginning, this upper, I have changed to 70 degree for everyone.
Yes, sir. Yes, sir.
Is the picture good?
No,
yes,
not
it
very good. Clean the lens, I think, or endoscope.
Okay. Okay. So now, see now with the 70 degree, let us first orient you.
Yeah.
This is the middle meatal antrostomy you saw.
Yeah.
And if I go inside and rotate, you see the interior of the maxillary sinus. And what I can show you, what is the no? See the prominence in the roof. Can you see that neurovascular bundle?
Yes.
That is the infraorbital neurovascular bundle in the roof. And we'll dissect it when I come to the maxillary sinus, later expanded approaches, I will show how important a landmark it is. The infraorbital neurovascular bundle, how important a landmark it is, and we'll show a technique nowadays. Even you can go beyond that endoscopically by means of transposing this entire neurovascular bundle. See that is the interior, and if you rotate, if I rotate further, you can see even the anterior wall, you can see now. So this is the interior of the maxillary sinus, and this is 70 degree. I told you this is so versatile, I can make it 0 degree. Which degree telescope is this now?
70.
70.
Looks like 0 degree.
Looks like 0.
See?
Yes, sir.
The same picture, Prepa. The same picture like you see with the 0 degree. The reason is I made it more vertical. And I can work it like 0 degree. Now when I make it horizontal, I can work it like any degree I want to. This is 70 degree now. If I want to work further in the interior part of the roof, I will make it more horizontal and make it even up to 120 degrees. See this?
Yes.
So this 70 degrees, such a versatile telescope. With one telescope, you can do the entire surgery without changing the scope again and again. And for that matter, you need to get used to. And here, the most important thing why I've changed to the 70 is to show something. And this is considered to be one of the most challenging areas for the sinus surgeon to understand the frontal sinus anatomy and dissection and surgery onto the frontal sinus. And for that reason, we need to understand certain anatomy. Number one, see why we are so frightened with the frontal sinus work. We are frightened because of certain possibility of complications. Frontal sinus is so close to skull base, we are always scared of giving a CSF leak. We are always scared of injuring the orbit as it is in close proximity there, in close vicinity, and injuring the anterethmoidal artery sometimes. So, all these fears make the surgeon frightened. If you use a 70 degree, believe me, I'll tell you the landmark, you can easily access the frontal sinus without any problem. The only thing is visualization, landmarks. So, the landmarks for the frontal sinus, what I believe, this is the medial orbital wall we have seen. Yeah. Now with 70 degree telescope keeping in view all the time, if I keep my medial wall all the time in view with the 70 degree, wherever up I go, and don't cross this limit, I will never damage the orbit, as simple as that. This is one. Secondly, we all know, this middle turbinate goes up. See this, how it goes up to insert onto the cribriform plate. As long as we stay lateral to the middle turbinate, there is no fear of damaging the skull base. So again, keeping with the 70 degree in view, see why this 70 degree is keeping both the medial and lateral limit in view. Lateral limit orbit, if I don't cross laterally, I will no fear of injuring the orbit. If I don't cross it medially, I have no fear of injuring the skull base. So that is fear number 2, you can avoid using the 70 degree as you go up. Third is, I'll show you some landmark which God has given us, and I believe that is the most important landmark. Give me. And that is your beak. This frontal beak is one thing which has made our life difficult by means of making this frontal sinus access so difficult, as beak always comes in the way, and made the frontal sinus so high up strategically located. So this beak now, if you follow, this frontal sinus drains from behind. All anteriorly it is flowed by the beak. So as long as you follow the beak behind, and where the beak ends is your frontal sinus. So now, see now, this is your medial limit, this is your lateral limit, and this recess with a 70 degree, if I go inside, can you see the frontal?
Yeah, very clear.
See, so simple this is, such a favorable situation. Most favorable, like child's play now, if you have a 70 degree in hand. In any given difficult situation, because this area is not always so straightforward. There are so many cells which complicate your life, particularly in the presence of the disease. There are certain group of cells I mentioned in the first lecture, second webinar on the radiology, are the first group of cells which are lying anterior to this. See this cell lying anterior to the, this is my access to the frontal sinus. See now, how it is narrowed? By this cell. What is this? Aganese. So there are certain cells which are lying anterior to the frontal drainage pathway. And for them, the simplest is Aganese. If there are more pneumatization of the frontal bone, this is frontal bone above. More pneumatization of the frontal bone above, which is described by the Kuhns as a Kuhns classification, type 1, 2, 3, showing the degree of difficulty which these frontal cells can pose to the surgeon. Type 1, one cell above it, you can go behind that cell and come out. Type 2 is one more cell above it, or tier of cells above it, you have to go all the way above them to get them out. So for any cells which are in the anterior wall, which are in the anterior wall of the frontal recess, the basic fundamental to the surgeries go behind them. See this? They like this Aganese. I am going behind that and fracturing it out. Can you see this?
Yes, sir. Sir, when you're in this region and when you're using the 70 degree, I would request if they can also show the PIP of all your external maneuver that you're doing with the 70 degree scope. That will be very helpful for everyone.
My scope is parked close to the columella, pressed to the columella. So my left hand is almost immobilized. You may find that my hands are so stable. It's not like my hands are like you only. It's not like hands are stable. I have stabilized them, taking the help of columella where I parked my endoscope. And the right hand, through the right hand, I'm using my dissecting instrument like the microdevibrator this time. See now, yes, I've removed this Aganese and flushed with the lamina peparia again. See this? And this has opened the frontal sinus pathway. Now, any cells lying anterior to the frontal recess are to be addressed like this. Go behind and fracture them out. The reason is the direction is away from the skull base. Now imagine there are cells on the posterior wall. Where in the posterior wall? Like, give me this thing. Let me show you. Had I been having, this was the cell here anterior to it. Had I been having cells over here on the posterior table, I would not afford to go behind it and fracture it out anteriorly. Otherwise, I would end up entering the skull base. So in those cells which are on the posterior wall of the frontal sinus outflow, they need to be opened from anteriorly and flush with the posterior wall rather than going behind them. And this discrimination, you have to plan. You cannot know unless you have a good understanding of the CT scan, which you can do yourself by means of a 3-dimensional CT scan on a DVD. And in that situation, you can get to know very easily that which cells are anterior, which cells are posterior, and you can literally get them out. So, by means of this, what I am trying to achieve, first of all, what I am showing is impossible if I am not using the 70 degree, number one. The reason is the visualization. At every point of time, I am looking at my limits. See this? My medial limit all the way, this turbinate, and lateral limit all the way so that I don't cross my limits. I remember this was 2006 when our dear friend Ashish Bhumkar presented in the international workshop in Jaipur. His concept of, box. The frontal sinus outflow passes through a box, the fixed anatomy that is box of bones all around. We need to take just advantage of that anatomy. See, I have not changed the anatomy. Whatsoever the cellularity is here in between, your limits are same. Your lateral limit, the orbit is going to remain same. Your medial limit, turbinate is going to remain same. Beak going to remain same. Even in the extreme revision patients, extreme revision or number of surgeries done earlier, these three landmarks are almost always prepared. Even if the middle turbinate chopped, you may find the upper part intact, and that may serve you as a good landmark to prevent skull base entry. Orbit is always preserved, and this frontonasal recess is the most reliable landmark in multiple revision surgeries, which is never touched even. So taking the advantage of these fixed landmark, we can make our entry into the frontal sinus simplified. Okay? Now, the cells behind are, for that matter, to enumerate, these are the cells anterior, which I mentioned, the Agarnagi and the Kuhn cells. Behind are the bular cell, suprabular cell, frontobular cell going into the frontal sinus, and so on. And supraorbital cell is a lateral cell pressing from lateral side and narrowing the drainage from lateral side. Similarly, a cell, here most anteriorly, is the intersinus septal cell, which narrows the drainage from medially. So all this cellularity we must sit with the CT scan at least for half an hour and run in three-dimensional plane to understand what area we are operating upon. We need to be well versed with the three-dimensional anatomy of that region so that we don't commit any mistakes, complication, to cross our limits and give complications to the patient. Prabhakaran, anything to add on? We need your comments.
Beautifully done. I think the only other thing that we need to preserve as much mucosa as possible, because if we leave bare bone exposed,
absolutely,
then we get fibrosis. But I agree with what you said. As long as you know where your enemies are. So in this case, your enemies are the orbit, the skull base, or the brain, and the enteroethmoidal artery. As long as you know where they are, you can remove everything in between. As long as you preserve the mucosa. Very nicely done.
That's important. So that's, I would say, that is a take-home message from the master. Preserve mucosa. See, in the recent classification from the American Society of Rhinology, the most difficult of the frontal sinuses are those wherein the previous surgery has given fibrosis and neo-osteogenesis. And those are the most difficult to treat situations. And that is only and only because of leaving the raw areas, by extirpating mucosas and allowing the granulations to form a neo-osteogenesis and ultimately narrowing of that region. And that is most difficult to treat. So we should be very, very careful in working in the frontal recess, and like you can see here, preserve mucosa like Professor Prabhakaran said. This microdebrider is a mucosa preserving tool. It cuts sharp, it doesn't pull. We can use through biting, sharp instruments, microdebrider, all these help in preserving the mucosa rather than peeling them off. Now,
in a difficult scenario,
pardon?
In a difficult scenario, if we hug the frontal beak with an instrument and then slide the instrument just along that beak, the place where it will give way will be going into your frontal recess area. So do you think in difficult cases that will be an approach?
Absolutely. That's what I'm coming to show, that what Samir is saying. That is the bottom line of our philosophy. Out of these three landmarks, the beak is the most reliable one. The reason it makes the floor of the frontal sinus. And as you follow the floor behind, follow the beak behind where it ends, it has to be frontal sinus. Whatsoever the cellularity is, it can never change. So in multiple revision, most difficult when you are disoriented, you are completely lost. Forget everything and just follow the beak. And that's what I'm going to show next. So that you will never miss the frontal sinus in place. That's a very important point, Samir.
Yes, sir. So will you also tell us the axillary flap approach to the frontal recess?
Yes, I can show that. And that is a concept propagated by a genius, none other than Professor P.J. Wormold. You know, we all know Professor Wormold.
Yes.
Is phenomenal, for that matter.
You have shown this intact bulla technique. What is the indication of doing this intact bulla technique in surgical practice? Dr. Prakash Mukha is asking.
Yes. Convey my regards to sir. Prakash Mukha sir. His questions are always, he's a genius. Sir, I am coming to it because I have not touched the third part, the enteroethmoidal artery. See, my bulla is intact. And I'm still not worried about any other complication like anthrhythmoid so far. I'll tell you the reason, sir. I'm coming to it. I'll definitely address this. So now, what Samir was saying, this you follow the beak. You follow the beak where it ends has to be frontal. Believe me, in any given situation of the frontal sinus you're operating, that patient may be the most difficult anatomy might be having, may have been operated earlier several times, but what he has mentioned, Samir, exactly this is, I'm trying to show what you have mentioned. This is my lateral wall, this is my medial limit, and this is my beak. Just follow the beak, staying between the lateral and the medial limits. Staying between. Follow the beak, and wherever the beak ends, it has to be frontal. Because this is not what we have devised. This is God's given anatomy, which we are taking the advantage of. That this beak forms the floor of the frontal sinus, and where it ends posteriorly, the frontal drains. So we are just taking the advantage of it, but it has a huge implication in simplifying our approach. Number 2, Paramita, the axillary flap approach, right angle, as propagated by Professor Womold, what I believe initially, probably 2 decades back, right angle, 2 decades back, when the 70 was not in use. So his concept was to remove the part of the axillary bone to facilitate entry into the frontal even with a 30 degree. See, he is so perfect in doing that still, that without giving any complication, which is other, right angle, ye dena. Okay, ye wala. So, he is so perfect, he still does it without giving any complication. So what exactly does it? He raises a flap of this region like this. I raise a flap here. I am not raising, just to show you. Elevate it towards the turbinate, and then take away this bone of the axilla. So that hindrance to the frontal entry is gone, and you can enter into the frontal little easier than otherwise is. So that the fundamental is behind that approach is to facilitate your entry into the frontal much better, but still it cannot beat 70 degree. If you have 70 degree, you don't need to do all that. Okay. Now the second question is how big this opening should be. I have been asked several times this question, what size opening one should leave or give at the end of the frontal sinus? What size entry? So, to me, there is no fixed size. We cannot determine a particular patient's anatomy. Some patients have a huge pneumatized frontal sinus, and some have a small frontal sinus. Still patients do well as long as their mucociliary clearance is good and the sinus outflow is maintained. So size doesn't matter. But once you are operating, our fundamental is, if you are operating on the frontal sinus, do a complete job. Complete job means flush the frontal sinus to the limits. So like, I flush this to the lateral limit. See this? No septa is overhanging. Overhanging septa may bridge the mucosa and can lead to stenosis. So our principle is follow the limits. See my medial limit, flush with the turbinate. Lateral limit, flush with the lateral wall. Posterior limit, flush with the skull base. And anterior limit to the beak. That is the final size one can give. There is no question of discussion regarding size in centimeters or so. No point. As long as you flush to the limits with, like Professor Prabhakaran said, keeping the mucosa intact, it is good enough. Maybe it is 7 millimeter, maybe 2 centimeters, doesn't make any difference for that particular patient. Now, having done this wall, I just said you, this is important that you can't go beyond the orbit is there. This you can't transgress, the skull base is there. Behind this is posterior table, where the skull base is there behind. In the extended approaches to the sinuses, now you know, as I mentioned earlier, the applications have been expanding. And Professor Wolfgang Graf had described, he revolutionized the concept of frontal sinus surgery again, the endoscopic concepts, by introducing certain approaches known as Graf approaches, expanded approaches to the frontal sinus to address difficult areas of the frontal sinus, extensive lesions of the frontal sinus, and those he described for that matter, now the applications have expanded for other regions. Not only for the sinusitis.
How do I put my name in? This is showing as iPhone.
Not only for the sinusitis now, this approach is being more and more used for the other skull-based pathologies to deal with the CSF leaks. Some mic is on in between.
I think Dr. Milind Kirtane sir is joining us.
Welcome, sir.
Yeah,
Yes, sir.
my connectivity is very poor, so I hope it remains like this. So
No, sir, we can see you and we can hear you as well.
We can hear you, sir. Welcome.
Okay, fine.
And I know sir is in Lonavala. So I understand the connectivity issue there. You are at the hill station, sir.
Emergency because of
And
I am not able to enjoy the hill station.
you know, we are so grateful to sir for his presence today. And he is always involved like anything. And today he was quite excited for this occasion of Remembrance Day for Stamberger. He said, I would definitely make it. He is at Lonavala presently at the hill station and still he made it. Thank you, sir. So what I was saying, for the expanded indications of the frontal sinus, what Raf had described, the only area which we can expand or where the entry of the frontal sinus can be enlarged is the anterior wall. See, there are no critical structures onto the anterior wall. An anterior wall, you can go right up to the external skin. There is no neurovascular structure to damage. So, this frontal sinus is above, this is floor. So the draft had described variety of procedures to marsupialize the frontal sinus in the nasal cavity to prevent the future obstruction to the ventilation and drainage, and we'll discuss those in detail today. So that is when you expand the anterior wall, and this anterior wall is a thick bone. See, from here to here, it is almost a 1.5 centimeter thick bone. You can see this. This thick bone is obstructing our visualization of the interior of the frontal. If I remove this thick bone, the entire frontal will be marsupialized, and his technique of draft, which he has classified into type 1, 2A, 2B, 3, we'll discuss in detail, and a lot of other modifications to the draft procedures. And these drafts are the endoscopic version of what Lothrop described more than 100 years ago. The same marsupialization of the frontal sinus, but from outside, which now we can do endoscopically. That's why we call it as an endoscopic modified Lothrop's procedure as a draft 3, which Lothrop had described more than 100 years ago from outside, the same procedure. So we'll discuss that in detail. The only thing what I wanted to point out at this point of time articulating, the only anterior wall can be expanded safely. And that is how we expand our entry into the anterior wall. Now, I'm showing you one tool. I call it as an articulated punch. See this? If you really want to punch little bit of the beak to enlarge further entry here, not much, a little bit of the beak. See this? I can take away this mucosa. This is a punch. We call it as an articulated punch. See this? And see our entry has improved.
Yes,
can you see this?
Yes, sir.
This is articulated punch, which can help you sometime in improving your frontal sinus.
Can you show us this instrument?
Yes, this is 9 articulations. There are other available with even 16 articulations. You can see this. This is from Karl Storz, the articulated punch, and it's an amazing tool. Our frontal sinus tool are altogether different. They are long angled instruments, and there are more than 30 instruments we use at different processes of different sizes into the frontal sinus for required reason. Okay? Paramita, do we go ahead? Any questions?
Yes, sir. Yes, sir. Sir, can you show us the supraorbital cell? Can you tell us more about?
Yes, that's what I was coming to. In this patient, probably, fortunately, I mentioned, he has the most favorable anatomy. There is no much of cellularity behind to obstruct the frontal drainage pathway, and one of them is the suprabular cell. Even this bulla, see this bulla? This bulla is not extending to the skull base. This can be dangerous sometimes. Why I am saying this? This bulla normally in over 95% of the situation go up to the skull base there. And in that situation, it covers the anterethmoidal artery on its own. Coming to the Prakash Mukha sir's question, that is very, very valid. Why we kept the bulla intact? See, our bulla is intact here. The reason is, we expect this bulla when reaching through the pre-op radiology, reaching to the skull base, we keep this intact so it automatically protects our anterethmoidal artery.
So, sir, can you show us the landmark now for the anterethmoidal artery?
Yeah, you can see the artery itself there now. It is uncovered. I told you, once this bulla is not reaching to the skull base, this can be dangerous sometime if you are not aware of it. And this artery, see this, it is not covered by any bulla or anything. Your instrumentation can damage it. So, the pre-op radiology is so important, you need to see whether bulla is reaching to the skull base or not. And in that situation, your intact bulla technique preserves your anterethmoidal artery behind from damaging by the surgeon. And these concepts were very well propagated long back by our own Professor Sethi. We discussed in the last webinar, and Professor Sethi was there, this concept of intact bulla technique. So thank you, Prakash Mukha sir, for this interesting discussion. So this was about the, the bulla, which was very rudimentary in this case. See this, only a small one. It was not protecting right up to the skull base. It was not going up to cover the anterethmoidal artery. Now, another advantage of 70 degree. When we use 70 degree directing to the anterior, to the beak. See this? Our direction with the 70 degree and instrumentation are towards the beak. We are always away from the territory of the anterethmoidal artery. So we automatically are directed away from the anterethmoidal artery to damage it. So once you are using 70 degree, you need not to be so terrified with the anterethmoidal artery as long as you are directed anteriorly, as long as your bulla is intact. In this patient, the bulla is so rudimentary, you can see. Now I am removing this. So rudimentary.
Sir, Dr. Sanjeev Golhar from Nagpur is asking, can we drill beak, the frontal beak?
Yes.
And if yes, then which situations can
Yes, Dr. Sanjay, I will totally show. We are here today for all those extended procedures of the frontal sinus. I will show you all 5 types of the draft procedures today. Not 5, 8 types of the draft procedure. What we have done already, according to the draft, when you go to the level of the frontal sinus ostium, it is a draft 1. So you have already done a draft 1. I will show what is 2A, 2B and 3. What is subtotal Lothrops, what is hemilothrops, what is mini Lothrops, what is central Lothrops, and they have their own indications now. We have huge number of cases doing all these variations for particular indications, which I am going to share with you.
Dr. Sandeep from Bareilly, I want to know regarding frontal osteotomy, types of frontal osteotomy.
Yes, that's what I am saying, boss. Sandeep, boss, I will show all the varieties of frontal sinus, these procedures, which can be very, very helpful in our clinical practice, and that will shatter everyone's fear regarding the frontal sinus. See, when we discuss sinus surgery at any platform, most of the audience have fear or the, some sort of inhibition regarding the frontal sinus work. And it is only because of, I tell you, the number one reason is the inability to use 70 degree widely. And number 2, the fear of complication. And to shatter those fear, I am here today to apprise you of all those fine details by means of which you can carry out this work very, very safely. So this is about the frontal sinus in this situation, in a regular one when you do a sinus surgery. Now I'll go back to 0 degree.
Dr. Kusum Patidar is asking, you have not used debrider till now. So in practice also, can we go up to...
I've been using debrider, madam. All the way I am using debrider.
In frontal sinus, how much we can go with the debrider? Up to what level?
I have already mentioned, madam, in frontal sinus or anywhere. See how I am able to preserve this all mucosa everywhere. Can you see this?
Yeah. Yeah.
All credit goes to debrider. The debrider is the tool which cuts the mucosa sharp and you can really preserve it so well. Had I been using my forceps or anything, I would keep pulling the mucosa and would have left a lot of raw areas. If you leave a lot of raw areas, I always mention, bare areas for the mucosalization later, that bare area may acquire infection, a lot of crusting, granulation, fibrosis, scarring, and that ends up with total mess, not fess. So believe me, it is the mucosal preservation which actually holds the concept of functional surgery. And for that, this debrider is key tool state. Now,
she's also mentioning that this presentation is very good for the PG student who have not could not read because of the COVID duties. So I think they can go through with this demonstration in the exam.
Thank you, madam. And madam has always been in the front runner of our academic activities. She has been always part of that. Thank you. Now, coming to this is all about the anterior group of sinuses. What we have done so far, those who have joined late, we did first endoscopic anatomy, then this middle meatal enterostomy after uncinectomy, then we went up with a 70-degree to do the frontal sinus work and the anterior ethmoidal skull base work. You can see the anterior ethmoidal artery there with 0° now. We'll see the anatomy, we'll see the implications. Why surgeons are so terrified this vessel? What is the implication of injuring this vessel? Though we discussed during our complication talk as well. But again, this is the time in cadaver to discuss certain issues. Now, to finish off this sinus surgery on this side, what is left behind? What is left behind? The thing which is left behind is the posterior ethmoidal work, sinus work, and the sphenoid sinus work. Now the issue is 12:30. बताना मेरे को.
7 minutes left. 7 minutes left.
एक बार में नहीं सुनता क्या? 12:30 हो जो बताना है यार. It's useless.
7 minutes left. No problem.
Yeah.
So still 5-6 minutes left for 12:30.
So what are we left with on the sinus surgery on this side? The post-ethmoidectomy and sphenoidotomy. I can go on through this ground lamella. This is ground lamella. See this? This is ground lamella. If I go behind this, the post-ethmoids are supposed to be there. And behind that are supposed to be sphenoid sinus. But it's not always like that. If I go behind like this to the post-ethmoid, keep doing post-ethmoidectomy, I may accidentally enter into the sphenoid sinus if I am not very oriented. And in that situation, I may damage the important neurovascular structure in the posterolateral wall. So, my fear is, during this posterior work behind the ground lamella, I need to develop certain landmarks to prevent the possibility of complications. Okay? So the number one landmark we utilize in our practice, this is purely for the junior colleagues to bring something into the practice by default. The first landmark is the maxillary line, the roof of maxilla or the floor of the orbit. This we call it as a life-saving line, life-saving landmark. See, draw a line parallel to the floor of the orbit, medially. This is the first part of the turbinate, this is the second part of the turbinate. In the second part of the turbinate, close to the first part, this is the point of entry into the ground lamella. Yeah, this is to answer where to enter into the ground lamella safely. I'll tell you the reason. See this? My point of entry into the ground lamella, and that is so clear. And as I enter, I stay more and more medially. I don't intend to do this post-ethmoidectomy here at this point of time for the reason I need to have certain landmark to define that I don't go accidentally into the sphenoid and damage everything behind. So what I did this opening in the medial part of the ground lamella here. At what level? At the level of the floor of the orbit. And this is, believe me, you go to that landmark publication from Richard Harvey. Is another genius from Australia. That man has, has published a book on sinus surgery, which I believe is one of the best so far, the concepts. He has been to Jaipur to our workshop earlier, and Gaurav Medicary, our dear friend, he invited him in Bangalore a few years back. He's an amazing sinus surgeon in Australia, near Sydney, and he revolutionized. He had this landmark publication of emphasizing the importance of the floor of the orbit. As long as you stick to it, you never transgress the skull base. Such an important observation. I tell you the reason why he's saying so. So, I went medially through this opening into this medial part of this region. Can you see this? Now let me go more medially. I don't intend to do any sinus surgery or the posterior thoracotomy at this point unless I find some landmark. See this. For you, I am broadening this approach to show you. Can you see this superior turbinate behind? See this opening. I enlarged so that you can see it better. This is your superior turbinate behind. Before doing this posterior thoracotomy, I need to develop a landmark of the sphenoid sinus ostium, which you can see here. Why so? Now keeping this in this mind, this sphenoid sinus ostium, as a posterior limit of posterior thoracotomy, I would never enter into the sphenoid beyond the limit of the sphenoid ostium to damage anything. In any given situation of the anomalous carotid artery or optic nerve or whatsoever in sphenoid sinus, they would never come anterior to the sphenoid ostium. So, as long as you stay anterior to the sphenoid ostium, you never damage anything. So, take the advantage of this line, number one, to enter here safely. The another advantage of this line is now, this sphenoid ostium is so favorable, you could see it early. Sometimes you're not able to see it. What we do then, what I'm doing is, I am removing the lower 1/3 of the superior turbinate. This you can do safely without any complication. And what you can do here for the junior colleagues at this point of time, take this line into consideration again. Take this line into consideration here again. When you look for the sphenoid ostium, never go above this line too much. See, this is the level of the orbital roof, orbital floor. Most of the time, this ostium is in the line of this floor. So the bottom line is to stay on the safer side, never to go above it, number one. And go close flush to the septum, not to go flush to the turbinate. Again, you may be pushed into any cell if you go flush to the turbinate. Go flush to the septum, that will always take you in the sphenoid sinus, number one. Why not to go above this line? Because this ostium is never at the level of the floor of the sphenoid sinus. This is high up. This is close to the roof many a times. So if I don't take into consideration this line, and if I am not able to see the sphenoid ostium and look for the sphenoid ostium somewhere above, I may breach the skull base. And that is a disaster. So, this is such a great landmark, this life-saving line. At this point of line, you enter into the this ground lamella, and taking this line into consideration again along the septum, you look for the sphenoid. Sphenoid in any given situation, whether it is a onody or whatever, this entry into the sphenoid close to the septum is always safe. Now, having seen this sphenoid sinus, I will carry out my posterior thoracotomy. See this? Again, I reiterate the same words I still remember from Dr. Ashish Bhumkar, 2006. This is again like a box. This posterior thoracoid is again like a box. See this? The lateral limit is lamina. See here? The medial limit is superior turbinate. And my posterior limit here for the posterior thoracotomy would be the sphenoid sinus. So now, as long as I stay anterior to the sphenoid, I have no issues, no fear in dissecting the posterior thoracoids at all.
Can you show us the frontoethmoidal crest, where exactly it is?
Pardon?
Frontoethmoidal crest in this specimen.
Frontoethmoid. What is this terminology, boss? Can you elaborate?
Yeah, Dr. Udbhav is asking, please ask her show frontoethmoidal crest.
Okay, let's discuss that. So what I am doing that is a post-ethmoidectomy. Now see the clinical relevance of what I was saying. First of all, I welcome Professor Muaz Tarabichi, who has joined us as our guest of honor today. And this is a very important emotional moment for us to remember someone who is father figure to us, the father of endoscopic sinus surgery, Professor Stemberger, whom for which we'll take a 5-10 minutes break, like I told you earlier, to remember that great man. So after this, so now, why I was saying this is a life-saving movement for all sinus surgeons. Believe me, take this sphenoid sinus as a landmark. See what can happen. What can happen? This I was doing this post-ethmoidectomy. See this? If I don't consider this as my posterior limit, if while doing post-ethmoidectomy I am carried away posteriorly, see Dick, what is there? This is optic nerve. This is optic nerve. See the post-ethmoidal cell taking directly to the optic nerve. And without knowing the sphenoid ostium and my posterior limit, if I go behind and look for my sphenoid sinus behind, it would be a disaster. I will end up making patient blind. That would be a disaster. And what simply can avoid this is, at this point of time, hello, what is there on the screen?
We can see your screen.
See now, what can simply prevent this is, before doing a post-ethmoidectomy, go medially and find this sphenoid sinus ostium. And taking as a posterior limit, now you carry out your post-ethmoidal work, not going behind this. And see, you can simply prevent this onody situation. Here, this is onody. And what you see here, the optic nerve, not running through the sphenoid sinus. See this? The optic nerve running through this post-ethmoidal cell known as onody cell. This was described by onody. And this I have seen several times. This is like we discussed last time when Professor Sethi was here. This is more prevalent among the Chinese population. They have almost every other patient have onody. Not in India. India up to 20 to 30% situation we have seen. But see, this approach of going and seeing the sphenoid ostium first and then staying anterior to it can certainly avoid this mishap. Now, having seen this, now what I am doing is, I am enlarging this sphenoid sinus ostium under vision, staying close to the anterior wall, not doing any sharp instrumentation inside, just enlarging the anterior wall to see the interior of the sphenoid. And this is again a very, very important dictum by Professor Stemberger. Always I have attended his courses, not to use any sharp instrument inside the sphenoid sinus. And reason is, you can see what is there, the tiger behind the internal carotid artery. See the carotid artery, the optic nerve, the sphenoid sinus. The bottom line is, while doing a post-ethmoidectomy work, you have to stay extra careful. Go to the medial side, look at the sphenoid sinus, make it as a posterior limit of post-ethmoidectomy, define that, and then go for a sphenoidotomy and widening the sphenoid to carry out a safe sinus surgery. And this is what important, because remember, the same words from Moshe 100 years back, the easiest way to kill a person is post-ethmoidectomy, and if you do like that, you can easily injure the internal carotid artery, which is there. There are a lot of reports published where people have done it. So this is a submission to use this approach. Before doing a post-ethmoidectomy, go medially and see the sphenoid sinus, making it your posterior limit, then do post-ethmoidectomy, and then go ahead with the sphenoid widening to prevent injury. So now is the time to take a 10 minutes break for the great man. Believe me, it will be by watch 10 minutes. We'll get back to the dissection 10 minutes after to remember this man who is the father of endoscopic sinus surgery. And for this special opportunity, for this special program, I invite a master, none other than Ashish Bhumkar, to initiate this 10 minutes program. To introduce everyone, this master was actually created a sensation in the world in the microtia and the external ear surgery, wherein earlier the plastic surgeon would do the external ear correction, and he's probably the only one in the world now who is doing, along with the external ear, the hearing correction as well. And that's why he's most sought after person in many parts of the world for this spatial surgery, the microtia along with the hearing correction. And for this, in my practice, because I've been associated with him, this particular part of the field I have left for Ashish only, and I'm really blessed this, otherwise I would do injustice to my patients had I been referring to the plastic surgeon for the external ear work, not the hearing correction at the same time. So Ashish, the great job and the great master, and I invite you to initiate this job for next 10 minutes, please.
Dr.
Thanks,
Satish also joined. Yeah.
Hello, can you hear me?
Yeah, Ashish, we have, for your information, we have Professor Tarabichi who has just joined us.
Yes,
we have already Professor Prabhakaran. We have Professor Sethi with us from Singapore. And you can see Professor Kirtane with us. So all these people, in spite of their busy schedule today,
I'm working through my phone. Doesn't matter. First thing, I'll take 2 or 3 minutes, not more. First thing, I think that technique that Satish showed about identifying the sphenoid ostium and keeping that as the posterior landmark and doing the posterior sphenoidectomy, I think that brilliant idea should simply go by the Satish Jain technique. I think history should record it because it has made life so much easy for everybody, and the fear and phobia of the Onodis cells has completely gone away. I think we have to give this to Satish Jain and start calling it like the Satish Jain technique. I'll come to the, today happens to be the solar eclipse. So even the sun god in nature has an eclipse, but Sun Pharma, who's been supporting this great endeavor, has no eclipse. And if at all, Sun Pharma has eclipsed all other events which all other pharma guys are going to be doing and have been doing, because they have the master, the one and only Satish Jain, supporting both each other. So brilliant work, Satish. Brilliant work, Rajiv, for the initiative that you have taken and made it so successful. We tried to do this as an India group in a very small way. We were having 250 or 300 people physically present, but you have been the right man at the right time at the right place, and you have taken it globally. I'm shocked that there are 12,000 people, and at any given time, 6,000 people perpetually hooked on. Naidu had just sent me a message. Somebody who's COVID positive, he's actually admitted in a hospital, but still watching the master. I mean, he's getting his oxygen from what the brilliance of this great man Satish Jain is. This is something. You also have, Rajiv, a very able partner, your Sahara, the Miss Sahara, the Miss Saha, who is the Sahara. I am going to play a little bit with her. She is conducting the paranasal sinuses with the paramita. As a paramita as she is. And in the true sense, Paramita Saha, and she's not Saha anymore, she's Sahi. She's Sahi for Rajiv for conducting all these brilliant courses. So now I will say a few words about my association with Stemberger. He was, of course, completely blown away. I mean, Sethi got him to come to India in 2008. And before that, the prelude to that, I want to say that Sethi made a comment about Satish Jain in early 2008. When he said, boss, I go all over the world, conduct courses, and some other people start also operating after me. And he says, I generally walk out in the first 15 minutes. The moment somebody starts, Sethi, I'm sorry, I'm sharing a confidential talk between us. And he says, Satish Jain is the only person that I not just tolerate, but I enjoy watching. This I'm talking 2008, 12 years before this. And when this was a comment and a compliment to the young man at that time, who very few people knew, Satish. And then he says, okay, we'll do, and something happened, and we did the Stemberger course. Stemberger, of course, came here He was completely impressed by what Satish had to say and had to talk about, because we had a lot of private moments with him. Then we took him to Jaisalmer. And in Jaisalmer, we were sitting in the desert and we just asked him, and Satish and me and Ashim Sethi, we were there. So what is the advice? He says, you guys have a bright future. You guys obviously are, you know your craft. The only message to you is stay modest. And that was a very important message coming from such a great master. And I was very happy to hear that he said, stay modest and not be modest. Because he had already seen this. And the greatness of Satish Jain, honestly, and I'm a little emotional on this, he is truly modesty epitomized, I mean, he is really an epitome of modesty. At a different level, this man simply wants to just impart his knowledge. At no point is he trying to say, I'm the greatest, I'm the best, I'm the this. Never ever. I mean, these were the prophetic words from Stemberger. They have remained with us. And for Satish, it's very, very natural to be modest. This was something very important about him. In Dubai, Stemberger happened to attend one of my talks. At that time, I did not know him. And this was the talk about the frontal sinus which Satish referred to. And I had the way of showing Marilyn Monroe with her hourglass figure in that. After the talk, actually, Stemberger reached to me and he said, now I know you have saved and answered a question that has haunted me for a long time. I said, what is the question, sir? He says, I was wondering, what is it that people find so attractive about the frontal sinus? Now that you have shown Marilyn Monroe, I know where the attraction to the frontal recess is. And then he said, boss, I have to compliment you. You have guts. In Dubai, you are showing a semi-clad picture of Marilyn Monroe. This was my brief interaction with the great master. And then, of course, with Moaz Tarabici, I've had the privilege of having dinner with him. I'm going to allow Moaz to say a few words about the brilliant dream project that he and Heinz Stemberger have conceived together and he's implementing. And I think we are on the verge of this great institute over, I think, close to 100,000 square feet of a pure ENT center in Dubai called as the Stemberger, Tarabici Stemberger Ear and Sinus Surgery Center. That dream Moaz will share with us. Two other points a bit about Satish. One was this, I said, and his unconditional thing to give the knowledge. In the same 2008, and I want to bring this. Thank you. I think we're going to light a lamp in just a little bit of a time. Somebody had asked me, why, when there is a Stemberger and a Sethi, why are you giving this unknown young man in 2008 so much space on the stage? And there was somebody, very politely, nobody was rude, in a very, why are we here to hear Stemberger? And I said, just wait and watch what this man is capable of. And today we are here, and there is nobody in my books to pay a homage to this great man Stemberger other than Satish Jain. And a very appropriate, through the dissection, Stemberger actually loved life. He only lived it through the paranasal sinuses. I've had a glimpse into the man. We've spent 2-3 days on a holiday. He genuinely loved life, and Moaz will say a lot about him. His bandwidth of living the life was a lot. People only knew him. He was the man who, in fact, today I don't know whether to say whether we are paying homage, because he really still is there, because he insisted that it is the message and not the messenger that are important. In fact, he refused to get photographed because he says, I'm irrelevant. It's only my message and my teachings. And really what Satish is showing is the teachings as the base, the Heinz teachings as the base from where Satish has made them into such a gigantic pool of knowledge. A short saying before I say bye. A master points a finger to the moon. Most of the people keep watching the finger and miss the moon. Heinz Stemberger tried a lot in his life to make sure that his finger did not occlude the moon, and he was the man who brought the moon to the general ENT, to the rhinologist. That is my way of saluting this man. If I could in my style say, he was the Heinz the ketchup and sinus burger, the most delicious way in which he introduced us to the art and science of sinus surgery. Moaz, I give it to you. Please take over from here and then we will have Kirtane sir and Sethi speak a few words. Moaz, take over, please.
Thanks very much. Thank you, Ashish, and thank you, Satish, for doing this for Heinz. I think, again, we all recognize that Heinz is a special person, as a friend, as a teacher. I've met him actually when I was a resident, and this was long time ago. This is like 30-some years ago. And at that time, he had come to Montreal to talk about his technique, and somehow we got a good connection since then. He was interested in something that I had presented, and so we went back and forth. And then when I started doing my endoscopic ear surgery, he was source of support. Whenever I complained to him about the backlash that I was getting, he said, "Well, this comes with the territory." What I find most interesting about Heinz is his international perspective. He really felt, for the younger otolaryngologists everywhere. He felt, he did not feel more committed to a fellow Austrian or German otolaryngologist than to a fellow Indian otolaryngologist. He felt that we're all on this planet together. We actually were together at one time in Indonesia, and the relationship between different nationalities and Heinz is a special one. Again, he doesn't view the world in terms of countries and stuff. He views all people as the same, and he tried to reach out to everybody, and has tremendous respect for all cultures. And our sort of common theme for the project that we're doing is really, we believe there's tremendous amount of talent in the developing world. And a great example of that is India. You get incredible amount of energy. Every time I'm in India and I'm meeting our colleagues and friends, I'm really impressed by the drive for learning. And we're hoping that with this institute, we would provide a platform or an opportunity for this to happen. We're focused on I don't straddle the fence. I'm on the side of the developing world, and we're hoping that Dubai and again, as you know, I'm from Syria. I'm not from Dubai. And but Dubai for me is just a very convenient sort of area or place to do what we need to do. And our objective, and this was Heinz's dream, and we talked about it so many times, is to really service the younger otolaryngologists of the developing world and try to meet their drive for further training and further education. So thank you again for inviting me, and thanks Satish for providing that also free online. I think this is the future, is that we all have to accept the idea that open access, that we're lucky to have learned some skills, and we should be very happy to teach the younger otolaryngologists those skills that we've learned with time. Thank you.
Yeah, thank you, Moaz. I remember talking to Moaz, and we spoke about the House Ear Institute many years. This is more than 10 or 12 years ago, and he said, why should there be only that? And now here we have the Tarabichi Houseful Ear and Sinus Institute, and for sure it's going to be the epicenter of knowledge. Between Jaipur and Dubai, there's going to be this hotline, and I think it's going to be the new epicenter of education global for ENT.
Ashish, I'm very mindful sitting here in Dubai of the fact that the greatest source of talent that we have close to us is India. And so I have tremendous respect again for what you guys are doing and the level of expertise. And again, I go back to the level of drive of the Indian otolaryngologist. And we're hoping that, you could be the sort of the motor that pushes this forward. And And I have to say that I have two patients waiting. So
okay, no problem.
They're knocking on my door.
When is the institute going to be ready? When is it going to be operational?
Basically, it's ready. It really is. It's finished. And
when are you calling us to do surgeries?
Well, anytime. But the problem, now, and I don't know if you had a similar experience in India, but like our practice here is down like 70 or 80%. So for economic reasons, we decided to delay a bit the actual functioning of the institute. It does require like
sometime soon. So maybe Satish will come there for the inauguration of with a skull-based surgery, something like that.
All of our Indian brothers and friends would love to have him with us. Yeah. Thank you, guys.
Thank you, Moaz. Thank you for everything. Just for the record, Moaz, I think through you we approached Mrs. Stamberger. For her, one was the permission and to get a message from her to dedicate today's workshop. And I want to be on record. Of course, Moaz cautioned me then. Actually, they are a very private family. She's very private. So she has not replied officially, but we are going to send the clipping of this dedication to the great man through Moaz to her, to Mrs. Stamberger.
Thank you.
Thank you, Moaz, for doing that.
Take care.
Thank you.
Have a nice day.
Kirtane, sir?
Yeah, hi, can you hear me now?
Yeah, very clear.
Yes, very clearly, sir.
Okay, all right. No, it's really happy that you're having this dedication for Heinz Stamberger. And my association with him goes way back to 1985. When he made this first trip to India, he came to KEM and demonstrated with that side-holding camera on a cadaver to us in the ENT department of KEM hospital. And that was for us the beginning of sinus surgery. In 1986, I visited him in Graz. And I must tell you something here. I mean, I also had the chance to interact with Professor Messerlinger because of my knowledge of German. But not many of you must have ever had the opportunity of seeing Dr. Stamberger do a stapedectomy. I have seen that. Anyway, I'll just keep it very brief. His dedication, his commitment, and his humility is something that I want to tell you about. I think I invited him in 2003. He didn't have a visa. I went to the airport. We were walking across the barrier on the phone, and I tried my best to request the immigration people, but they deported him. Yeah, so he had traveled from Graz to Frankfurt, Mumbai, was deported, went back to Frankfurt, but we requested him to go to the embassy there, to the consulate. And I, through some connections in Delhi, managed to talk to the consulate so that he landed at 6 o'clock. 8 o'clock, he goes to the consulate. There's a big queue there. 9 o'clock, the consulate opens. And he's wondering when his turn is going to come. And the guy comes out and just calls out, Professor Stamberger, says, yes, your passport, please. Stamp the visa. Heinz went back to the airport to Frankfurt. And from there, phoned me up and saying, Willem, I have another problem. My luggage is missing. So I said, don't worry, you just come here. We'll get you a shirt and a trouser. You lecture. He says, no, you don't understand. All my teaching material is in my luggage. I said, doesn't matter.
Some connection issue.
I think there has been some connection issue.
Okay, we go to City.
Have you got me? I'll take it very
Yeah.
I just finished. And he came back. He found his luggage still going round and round on the belt after 24 hours. And he sort of landed at 3 o'clock, said, don't wake me till 11 o'clock in the morning. 9:30 in the morning, he came down. He took over the premises and proceedings went all right till evening. I mean, a man that committed to teaching that he had been deported but came back. And on the 1st of December was his birthday. And I remember a week before he passed away, I used to call him up. We used to chat every time on his birthday. And I gave him a call. I talked to him, wished him for his birthday. And a week later, we heard the news that he had passed away. I'd always told him that he'll be a milestone, like a milestone in a surgery of the nose and sinuses. And that is absolutely true. So a great man. And it is our privilege to be associated with him. We pray that his soul may rest in peace. Thank you.
Yes.
Hello.
Hello.
Yes, Satish.
Yes.
Hello.
Yes. Professor said he would like to say something.
Yes, sure. Thank you. Thanks, Ashish and Satish, for arranging this tribute.
What is Ashish doing?
Can you hear me?
Yes, yes, we can hear you, sir.
So, what do I say about this man, this great man who contributed so much to the ENT fraternity, changed so many lives, paved the career for so many, and was loved and respected by all? Words fail me. It is almost surreal to refer to him in the past tense. I feel that he is still around. Heinz meant a lot to me. He was my inspiration, and he is also the reason what I am today and where I am today. It was in late 1991 that I first met Heinz in Asia Oceania meeting in Hong Kong and listened to one of his presentations. It was so inspirational that I decided to pursue rhinology and endoscopic sinus surgery as my career. It was a butterfly effect that was to change not only me, but to several lives around me. Heinz was a great teacher and a mentor, and every time I met him, I learned so much from him. His knowledge went way, way beyond ENT and endoscopic sinus surgery. I remember that a few years ago in India, in Hyderabad, I took him to dinner to the Philip Noma Palace. And during the dinner, there was a performance by Sufi singers. And Heinz was very quiet throughout the dinner. And I thought maybe he didn't like the performance, maybe he didn't enjoy it. And I felt bad. And after the performance was over, I apologized for bringing him there and told him that these are, Sufi singers and, they... And he looked at me and said, "Are you kidding? I could sit here the whole night and listen to them." And what followed was a 1-hour tutorial on who the Sufis were, where they originated from, how they came to India, and where everything, he knew everything about the Sufi singers, that I was just intimidated by the vastness of his knowledge. And he surprised me again on another occasion. And this was in Jaisalmer, where Satish, myself, and Ashim were there. And we were in the desert. And I was lying down on the dunes, looking at the sky and looking at all the stars. And I just made a comment. And I wonder what that star is. And what followed was almost 1-hour lecture on the universe and astronomy. He knew everything about the universe. We also know that Heinz loved the desert, and he was a great photographer. He loved life. His knowledge extended from the depths of the ocean to the vastness of the universe. Such a great man he was. He also had a very witty sense of humor. And I remember once I called him, I intended to call Professor Aldo Stam for something, I can't remember what. And someone answered the phone on the other end. And I said, Aldo Stam, how are you? And the person on the other side answered, Dr. Sethi, this is not Stam, this is Stamberger. I had accidentally dialed the wrong number because they were, Stam and Stamberger, not much of a difference there. And he was so nice about it. And I said, I'm so sorry to wake you up. What time is it there? He says, 2 a.m. in the morning, but it's very rarely that I hear from you. So let's discuss something. And we spoke for almost 20 minutes that evening. I still remember, I can never forget that. I could go on and on talking about Heinz Steinberger. But it's not fair. Sorry, there was a phone call. I think it's Satish calling me.
We need to go on air.
All right. I'm finished right here. I'm so sorry. And that's all I have to say about him. I really miss him. I think we all miss him. And the entire world miss him, and his contributions will remain immortal forever. Thank you very much.
Thank you, Sethi. And we're back. Sorry, folks, it got extended. We got carried away. Sincere apologies for overextending on time. Satish, back to you and to the great art.
Thank you, Ashish. Thank you all. And this was really a great moment for us to remember that legend. And for that matter, we had all such senior people who had an opportunity to work with him, and what a great time. Thank you so much. And now we get back to where we left earlier. So, we did a sinus surgery on this side, by and large, and the last part what I was doing was doing a posterior ethmoidectomy and then the sphenoid sinusotomy. And the basic fundamental was to look for the sphenoid ostium first and then taking into consideration this as a posterior limit. You carry out the posterior ethmoidectomy without going behind the level of the ostium so that you cannot injure the structures behind like carotid artery or the optic nerve, most importantly the optic nerve here, which is many a times in a cell behind. Now, doing this part for the sinus surgery on this side, the most important thing which now I should mention here, as a lot of questions we have already got regarding the anterior ethmoidal artery. Many questions we have got regarding the anterior ethmoidal artery I was going through during the break, and I will show you a part of the course of this vessel so that we can understand why we are so concerned about this small vessel. This vessel has a diameter of less than a millimeter, but there are certain implications of injuring this vessel which can lead to disastrous complications. And those complications, if you don't manage in time, they have the potential to give a permanent vision loss as well. So, this is the anterior ethmoidal artery which I am seeing with the 0-degree telescope. Can you see this? How is the picture?
Yes, sir.
Can you see this? This is the vessel. I am elevating this mucosa here. And this is the canal. See this vessel, it carries the blood from the internal carotid system. The internal carotid artery, as it goes intracranial, we'll see today, as we go with the time, the course of the internal carotid up in the cavernous sinus and the brain above. So the first intracranial branch as it goes in the subarachnoid space is the retrograde one, that is ophthalmic artery. And that artery runs along with this optic nerve in the optic canal to enter inside the orbit. And here it gives two major branches. The first one, here, anteriorly one, is the anterior ethmoidal artery, which leaves the orbit and then run in another canal. See, this is the orbit, that is lamina papyracea. And just out of the lamina, this is running out in a canal along with the nerve. You can see the white nerve also along with. Can you appreciate?
Yes, sir.
That is the anterior ethmoidal nerve, that's the branch of nasociliary nerve, which is a branch of V1. That is ophthalmic division of trigeminal. So these two nerves run in a bony canal right from the orbit. Orbit is the first cavity compartment this vessel is running through. Then leaving the orbit at the medial end, running in a bony canal, and then piercing right here at the lateral lamella of the cribriform plate. See this. See this. That is the most important reason why we are worried about this middle turbinate. Give me the 70-degree to show exactly where I am working. Why we are so concerned about manipulation of the middle turbinate up, where it can give CSF leak. This is the place. This is the place where this turbinate is attached to the cribriform plate. See this turbinate where it is attached to the cribriform plate. So, if I am manipulating the lower part of the turbinate, it may not transmit to the skull base. But yes, if I am manipulating at the higher level, it can be transmitted to the skull base. So you have to be careful at the upper part where this turbinate is attached to the cribriform plate, and this lamella of the cribriform, particularly the lateral one, is so thin, less than the thickness of a fraction of millimeter, through which this vessel passes to the intracranial space, that is olfactory fossa of the brain.
Yeah.
Okay? So, this vessel leaves the orbit, run in the canal, that is the second compartment, that is the roof of the ethmoid, and the third compartment where it enters the intracranial space. So, this is the third compartment. And why it is important to understand? While doing this work of the sinus surgery at this level, if we happen to transect this nerve laterally, what can happen? This nerve can retract into the orbit. If it is completely transected and happens to retract into the orbit and keeps on bleeding, then can be a disaster, because this orbit is a closed cavity. All around bones, except anteriorly, even a 5 ml extra blood in the orbit can be good enough to compress the optic nerve and the vessel supplying the ciliary artery, supplying the optic nerve. So let me show you. See this. This lamina I am breaking. This lamina I am breaking here, and you see how this nerve is entering into this canal. This is coming out of the intraorbital space. See this? Can you see this vessel?
Yes, sir.
Very clear.
Coming out of the intraorbital space, and here, the muscle here just above, that muscle is the superior oblique muscle. And see that superior oblique muscle, can you see?
Yes, sir.
Very clear?
Yes.
Yeah.
And this muscle inferiorly here is the medial rectus muscle. So this muscle enters into the orbit at the confluence of these two muscles, and you can appreciate on a pre-op CT scan, which can define on a soft tissue window setting both these muscles separately, and here how it enters into the orbit. So if this muscle is transected here and happens to retract inside the orbit, this can lead to hematoma formation, which can compress the optic nerve, which if cannot, or if it is not managed properly and promptly, can lead to blindness even. So this is something important to understand, and we should be able to understand this fact that this nerve has to be respected and work properly in this region when you are operating. At the same time, medially, this vessel as it enters the lateral lamella, if this lateral lamella at this point of time, this vessel is injured, as I mentioned, this lateral lamella is so fragile that injury is good enough to damage this vessel, and the injury which is good enough to damage this vessel is good enough to damage the lateral lamella as well. And then the complication which we are concerned is a CSF leak. So the bottom line is to avoid on either side endangering this vessel, we should work in the middle of the course of this vessel. So while working in this region, you should be able to define your lateral as well as medial limit and stay in the middle of the course. So in case even if you happen to injure the vessel, only bleeding can happen from this small vessel, which you can easily manage by means of using any marrow cell, Surgicel, gel form, pressure, whatever, and it goes in spasm. So don't work at the extremes at this level, extreme laterally and medially, and work in the middle of the course so you can avoid injuring this vessel. And at this point, I'll take 1 minute to have some few words from our university chairman, Mr. Bakshi, which I introduced the last time, where we are working this dissection today, and he just came just to bless us for a minute, and we need your blessing, sir, for a minute so that we can continue further.
I think, can you hear me? Yeah?
Yes.
For any good work, my good wishes are with you. Rather, in between the last Sunday and this Sunday, taking ideas from Dr. Satish and Dr. Mishra and Dr. Bafna, we could move far ahead of what we had thought. And if you see the background very clearly shows that within a week's time, we are in a phase of developing the cadaver dissection skill lab at JNU. So this is going to give ample opportunities to the fraternity, doctor fraternity, to come to Jaipur. I welcome you on behalf of JNU, and under the guidance of Dr. Bafna and Dr. Satish, we've constituted a core committee which is going to run the entire skill development lab here at Jaipur. And everyone across from the country, and I think get better from anywhere in the world, can come and work here, can share your knowledge, can improve your skills, because ultimately this is nothing but a phase of improving what we can do better for tomorrow. What we are going through the COVID period right now is also learning that there are so many things that are bound to happen which we don't know. So the more we dissect, the more we learn from the cadavers and what we can do, it'll be a good learning. So this is the first launch of the skill lab that we propose to do. And all members on board right now today, I welcome you. And by the next week, we'll float an official document stating about the skill lab. Thank you, Dr. Jain, for being always taking out time here for us. and educating all of us. Thank you so much.
Thank you.
Thank you.
Very important announcement for everyone who are watching online. Is announced to develop a skill lab, state of the art in Jaipur, for anybody across the world who can come and dissect and wants to improve the skill. This will be a state of the art, well-equipped laboratory with all equipment, endoscope, microscope, and a lot of cadavers, so you can dissect the area of your interest, the ear, nose, throat, skull base, head and neck, and improve your skill anytime. So that's a great announcement from the big boss. Thank you. Thank you. So we get back to the entrance model artery where we left. Thank you, sir, once again. So what I was saying, this is the entrance model artery course, and wherever you are working in this region, stay in the middle of the course to avoid injury on the either side. That is the bottom line. Prabhakaran, any comment on this point about this artery?
It's very nicely seen. We can see it very clearly. I think the most important thing is not always running on the skull base like that. Quite often it's on the mesentery. That's when it's so easy to injure it. As long as it's running on a skull base like this, we don't really injure it. It's only when it's running on the mesentery that we have to be very careful. So it's very important to identify the artery even on the CT scan before we start the surgery itself.
Thank you. So that is important. When it runs in the mesentery, you have to stay extra careful. That is the message. Now, this artery, after entering this lateral lamella, it enters the intracranial space in the olfactory fossa. And here, it gives a branch to the fox cerebri. We'll show you the fox as we go intracranially. And there it comes anteriorly and comes back in the upper part of the nose again. And this is the area of the upper part of the nose, the lateral wall and the medial wall, the septum, everywhere it supplies. That's the important area where the anterior modal artery supplies. And from there it goes again out on the dorsum of the nose at the junction of the upper lateral cartilage and the nasal bone to supply the dorsum of the nose. That's how the course of this vessel. And looking at this area where this vessel comes, there is a very important flap described by Professor Paul Casanova that is based on this vessel, anterior ethmoidal artery, and that's amazing flap you can use to reconstruct your nasal septal defects, or you can use that flap for your anterior ethmoidal skull base defects as a vascularized flap. Another thing, you can use that flap to to mucosalize your raw areas once you leave after the draft procedures. So what is that flap? For that matter, if I give you a little gross idea about it, give me the knife. I hope you are oriented where I am.
Very much.
Yes,
very
yes.
much, very much.
See this? That's a very important flap. That's the anterior border of the this axilla. At this point, I am drawing a line. This incision, this is the anterior one. Right down, you can go right to the level of the floor, or you can take a part of the floor as well. Just to giving you an outline, not elevating. Then the posterior incision is 1.5 centimeter behind, same vertical incision. Go down to the level of the floor and you can take a part of the floor. Now this anterior incision can be extended anteriorly to the level of the posterior margin of the septal perforation if you are using for the septal perforation. And then elevate this entire flap and advance anteriorly to cover the septal perforation. That is amazing flap. Simplest way to cover a septal perforation with a vascularized flap, which otherwise is a difficult, the problem to treat otherwise, the septal perforation. And this is the best and the simplest way you can use this Paul Casanova flap based on the anterior ethmoidal artery to cover these. And I told you the other applications, you can apply it to the skull base defects, you can elevate and apply to the, like we did last time, the meningoencephalocele. We could have applied if we need any kind of a huge defect we have. We can use this flap, or you can use it as I show later, the draft procedure you can use to cover the raw areas of the bone over the draft procedures. So this is Paul Casanova flap based on the anterior ethmoidal artery. So having known the course of this anterior ethmoidal artery, if you go behind, see this is anterior ethmoidal skull base. This is the posterior table of frontal sinus. This is anterior ethmoidal skull base, and behind that is posterior ethmoidal skull base. We have the optic nerve here, and the posterior ethmoidal artery generally is few millimeter anterior to the optic nerve. That is the constant location of this postsigmoidal artery. And if I elevate this mucosa, see this, can you see the glimpse of the postsigmoidal artery?
Yes, sir.
Sometimes, many times it is not visible because this part of the skull base through which this vessel passes, unlike the anterior ethmoidal artery which passes through the thin anterior skull base, this part of the skull base is relatively thicker, and as this vessel passes through this thicker skull base, sometimes it is not visible. So, once this vessel is there and you are walking there and it is dehiscent, this part of the skull base is thin, you have to be extra careful because if this vessel happens to get injured and retract in the orbit, this has more disastrous complication than retraction of the anterior ethmoidal. The reason is, this anterior ethmoidal when retracts gives to immediate proptosis, and that you can appreciate immediately and you can take your measures. But this part of the artery, the postsigmoidal, being very close to the orbital apex, even the vessel when it is retracted, you may not appreciate, the patient may not develop the proptosis, you may not be aware of it, and by the time the patient comes out of the anesthesia, he would have been blind. So be careful about the posterior, this is more dangerous. The space close to the optic nerve being optic nerve, and the area close to the orbit apex being very narrow, this is a more dangerous vessel to be more respected than the anterior ethmoidal artery. And behind is the optic nerve. So this is something about the regular sinus surgery on this side.
Yes.
Now,
sir, can you tell us the importance of suprabular recess in relation to the anterior ethmoidal artery?
Suprabular recess in relation to the
anterior ethmoidal artery?
Yes, see, suprabular, I am back with a 0 degree. Suprabular recess is what? An area above the attachment of the bulla. Bulla attachment is generally anterior to the anterior ethmoidal artery when it goes to the skull base. Now, when the bulla doesn't go to the skull base like this, it doesn't cover the anterior ethmoidal artery, and the anterior ethmoidal artery is bare in front of you, like we saw today. So, in such situations, you have to be more careful. It sometimes can be more dangerous to see the anterior ethmoidal artery in this level, at this level. Okay?
And now, people want to see the rescue procedure for the anterior ethmoidal artery bleeding detected in the orbit.
Okay, that's an important point. I can show you. I mentioned that day, give me scissors, you now. I mentioned that day, the immediate procedure, the fastest procedure one can do when the anterior ethmoidal artery bleeds and the proptosis happens to occur, and if you do the afferent pupillary test, it is still intact and the orbit becomes fixed. See the canthotomy. The fastest procedure one can do in seconds. What you need to do is, this is lateral canthus. See this angle? Just take your scissors and run along the lateral canthus and divide this lateral canthus angle, and you see this orbit runs anteriorly. This orbit falls anteriorly once it is distended from behind. The simple thing can be done in less than 10 seconds. And this is canthotomy. This is simple lateral canthotomy. The second procedure is, in case still the pressure doesn't fall down, in case still the pressure doesn't fall down, what you can do? Retract down. Retract down. Retract down. We go deep to this. See where I am going. This is zygomatic arch, zygomatic process. Go deep to the zygomatic process and see this. I can see this tendon with my scissors. Open this space and cut this inferior canthal tendon completely. I've cut this inferior canthal tendon completely, so my eyeball is free. Absolutely free from any attachment here on this side, and it will further bulge anteriorly to accommodate more blood. The volume of the orbit will be increased, and whatever blood which was pressing upon the orbit, that pressure can be taken off by means of increasing the intraorbital volume. So this is because ultimately this vessel has to stop on its own. It has to stop on its own. Bleeding, this is a small vessel, goes in spasm, and what more you can do to initiate the spasm more and more, in between you can do a sort of tourniquet onto the eye to initiate the spasm in the vessel. Pressure on the vessel, some people give massage on the orbit intermittent to initiate the vessel going into the spasm, and it works. So the canthotomy and cantholysis are the immediate rescue procedure in case this vessel has retracted into orbit and given a sudden proptosis and a fixed eyeball. The third thing which you can do at this point of time is the orbital decompression. I have already, to show you this vessel, open the orbit here. Otherwise, how you can do orbital decompression? See, orbital decompression has many indications. I will mention certain things which need to be taken care of. Number one, how to do it and what area you have to spare. First of all, remove the thin bone lamina papracia from the medial wall, leaving this bone intact in 1 centimeter proximity to the sphenoid sinus. Can you see this?
Yes, sir.
The posterior bone intact so that whatever fat or tissue prolapses out of it doesn't prolapse and block the sphenoid sinus outflow. The same is, you have to leave 1 centimeter area in close proximity to the frontal sinus absolutely intact. Can you see here? So both the things, both the areas you have to spare from the decompression. See this 1 centimeter bone should remain intact, close to the frontal recess. And then what you can do, you can make the cross hatches on the periosteum by means of the knife and allow the fat to bulge inside the ethmoidal cavity. That will serve both the purposes. Number one, it will serve the purpose of decompression, and since this has happened intraoperatively, everything is in your view. You can go to the ethmoids immediately to the lamina papracia and do a good decompression. So that you can do at the same time. Secondly, at this point of time, whatever blood this artery is giving, whatever this artery is bleeding, now this blood can drain into the ethmoidal cavity, so it doesn't give any more pressure onto the intraorbital structures. Okay?
Yeah.
So what you can do?
You will show us the optic nerve decompression also for right now or afterward.
Okay. So you can give such cross hatches for the fat to allow prolapsing into the orbit. See this cross hatches on the periosteum.
Yes,
Periosteum.
Sir, how to, while doing this, how to assess that the bleeding has stopped? I mean, how will you assess?
You cannot control.
Okay.
What you can do is, this way, first of all, you will allow the pressure which is built up inside the orbit to damage the optic nerve. That pressure will be lost. And number two, whatever blood which is coming out of the vessel will drain in the ethmoidal cavity, and it will no longer lead to accumulation of pressure inside the orbit. Okay? The bleeding, whatever is happening, if it is coming into the sinuses, it will not give any major complication as long as the optic nerve is not compressed.
Yes, sir. So since you have, you just told us about orbital apex, can you tell us more about that? Can you show us anatomically? Or superior orbital, fissure, orbital apex?
Yes.
Yes.
Okay, I will show. I told you we'll show you the anatomy of the orbit from inside. And I will show that from, I am removing this mucosa to show you. I will show that from the transcranial side to see each and every structure inside the orbit layer by layer. So you'll never forget in life. And from this side, I will show the approaches to the orbit, but not now, later. First, we'll finish off the basic work of the sinuses on both sides and extended sinus procedures. Now, as Pachauri boss asked about the optic nerve decompressions. So in indications of the optic nerve injury and other traumatic conditions, what you can do is, see now, I am in the posterior most part of the ethmoids. See this?
Yeah.
Yes.
This is, see my thin bone through which my periosteum elevator is passing. This is at the level of the posterior most part of the ethmoid, or that is where the annular tendon is. See this?
Yeah.
See this? I am uncovering. If this bone is thick, I would use a diamond burr.
Yeah.
If this bone is thick, I would use a diamond burr. Let me show you. Otherwise, if it is thin, you can flake off this bone with a periosteum elevator like what I am doing. So, let me show you how to drill this bone.
One more point, Dr. Anukaran Mahajan want to know how we can ligate the anterior artery, Lynch incision, etc.
No need to. Ligation of this vessel is not possible. And for that matter, to answer this question, I would say, Never ever go inside the orbit and attempt to catch or coagulate the vessel. If you do that, it will worsen the situation rather than improving. You will damage the intraorbital structure more than otherwise. See now what I am doing? Can you see this?
Yes, sir.
I am removing this bone almost 180 degree medial to the optic nerve. I will show you the detailed anatomy later of the skull base at this level. Now see, certain anatomy at this level, can you see below? This is the prominence of the carotid artery. I will show when I show the all parts of the carotid. This is the anterior, the prominence of the cavernous carotid. Anterior prominence of the cavernous carotid. This is a small depression between the optic nerve and the carotid known as lateral opticocarotid recess. And similarly, there is a confluence of the carotid artery and the optic nerve medially as well here. That is known as medial OCR, medial opticocarotid recess. So now here, see this. This optic nerve, this bone being flagged off. I have thinned out a little bit more. And see, using the Carrison punch, see this periosteum elevator, it is safer to do rather than using any sharp instrument. And you can see easily, you can flag off this bone. This is called drill. This is the decompression of the optic nerve. You can do it easily. And some people do the fenestration also sometime to make it more adequate, more convincing sort of decompression. Some people do not. This drill bit has gone. So this is the optic nerve. You can decompress the entire optic canal distally up to where it joins the opposite side to form the optic chiasma. So we are also, I also belong to the skill many a time where I do the fenestration of the sheath to make it more effective. The only issue is fenestration violates the, the subarachnoid space, because all the sheaths around the nerve, they are taken right up to the globe. The arachnoid, the pyometer and durameter, all those layers are taken along the, up to the globe. All the three sheaths of the meninges are taken around the optic nerve to the globe. So this part of the optic nerve which I have opened, you can still remove this periosteum and do a fenestration here. The only thing when you do fenestration, you have to use a plug to prevent the CSF leak further. Now, once you open this side, the only fear is injuring the ophthalmic artery. If you go to the published studies, the course of the ophthalmic artery into the optic canal, course of the ophthalmic artery in the optic canal is variable, and most of the time, can you see the optic nerve proper?
Yeah, very clear.
Yes, sir.
Ophthalmic artery most of the time run inferolateral to this nerve. See the entire course of the nerve.
Yeah.
Can you see very clear?
Very clear.
Hello?
Yes, sir. Yes,
yeah, very clear, very clear.
Very clearly.
Satish Jain, sir, just to interrupt you for just 1 minute. It's an excellent dissection, but could you really highlight exactly where to make the fenestration? I'm Dr. Vinod Silis.
For the
Can you really highlight?
Fenestration?
Yeah, where exactly you make the fenestration in the optic nerve?
Behind that tubercle. See, this is the level of the tubercle at the posterior end of this, at the anterior border of the sphenoid opening, where the proper canal starts, and there you make a fenestration, but avoid fenestration toward the cranial segment.
You make it in the superior half or the inferior half, anything like that?
In the distal part.
Okay.
In the distal part. So, what I was telling is the course of the ophthalmic artery. Most of the time the artery run inferolateral to the optic nerve. And if you really want to confirm for particular individual case, you can get an MR angiogram done before this, and a time of flight sequence in the MR angiogram will tell you what exactly the relationship of the ophthalmic artery with the optic nerve. If this, unfortunately, the ophthalmic artery is inferior-medial here, you can end up damaging the ophthalmic artery, and that can be a disaster. So that's why people avoid this fenestration most of the time. But once you do, it is more effective than only decompression of the optic nerve. Professor Prepa, what do you prefer?
That's a good question. So if you have a tumor that is causing an external compression of the optic nerve, then removing the tumor itself is adequate. But if you're doing for an optic neuritis where there's edema inside the optic nerve itself that's causing vision loss, then you will have to do a fenestration. You will have to cut the perineural sheath. And where you cut it, it's very important that you don't go in too medial, because if you go in too medial to where it becomes optic chiasma and goes to the subarachnoid space, then your chances of getting a CSF leak is much higher. As long as you do the fenestration, and the perineural sheath that you need to cut is very thick. If you do it, as long as you do it more lateral, the chances of you getting CSF leak is much lower. And even if you do get a CSF leak, it'll stop on its own. So the take-home message is, if you have a tumor or something that's causing an external compression, then just a decompression is adequate. An optic neuritis where there's an internal edema of the optic nerve, then you may require a fenestration.
Yeah,
that's
wonderful.
Great.
Yeah, wonderful.
That's great. That's a great information.
Sir, there's a question from Dr. Danish from Pune. How to save ophthalmic artery while decompressing optic nerve?
That's what
Any chances of bleed from
I was telling.
intercavernous sinus?
I've already mentioned to stay inferior-medial where artery is going to be unlikely. And if you really want 100% information about the place of the artery, you can get a time-of-flight sequence of MR angiogram. And that will give you a complete information of the relationship, how the vessel is going into it. Okay? Now, as I told you, we'll go to the extended procedures. So before I go to the extended procedures, I have to combine both sides. And before that, combining both sides, I will quickly show one important flap so that my septum will be violated later on. And that is the gift the two great gentlemen, Haddad and Basageste, had given to this world. This flap, based on certain vessel, they did a cadaveric study after injecting the sphenopalatine artery and studying the various branches and their anastomosis to the other vessels. And finally, they found this posterior branch of the sphenopalatine, I will show, is something which supply the nasal septum and has anastomosis with the other arteries around. So if we take a flap based on this posterior nasal branch, we can raise this entire mucoperiosteum of the septum of that side, and that is a vascularized flap which is quite robust, like PMMC for head and neck surgery, and you can use it for reconstruction of the skull base. So this is our most popular flap for the still most popular flap for the skull base reconstruction. This is very simple for the otolaryngologists who are doing septoplasty. This is so simple for them, there is nothing great into it, knife. So I will tell you how to raise this flap. First of all, the anatomy of the vessel. This is the area, this is opposite side. If I show it on that side, this is area where I showed you the sphenopalatine comes out of the sphenopalatine foramen. And it divides into multiple branches to the middle turbinate, to the inferior turbinate, and one branch goes behind on the anterior face of the sphenoid. See the sphenoid? Below, if I elevate this periosteum, on this anterior wall, this branch goes in the mucoperiosteum. See this? So to protect this branch, I am showing this flap on the opposite side because that part of the septum is not violated. So what you can do, I will make two incisions. See the level of my ostium? My first incision is immediately below the level of the ostium, okay? The second incision is above the level of the choana. So the pedicle remains in between these two incisions to protect the pedicle, okay? Now, as I come anteriorly, this area of the upper part of the nose, septum, in relation to the upper part of the turbinate belongs to the olfactory epithelium. So in order to avoid that injury to the olfactory epithelium, what we do? just come anteriorly with the opposite incision, little horizontally, almost horizontally, little superior inclination up to the anterior border of the turbinate. Can you see here?
Yes, sir.
This is the anterior border of the middle turbinate.
Yes.
And then I can go steep up. This is steep up right to the level of the roof of the nose. Can you see? Right to the level of the roof of the nose. This is my superior incision going. In order to preserve this olfactory epithelium behind. Is that clear?
Yeah, very clear, very clear.
Now this superior incision, I can continue anteriorly. I can continue anteriorly up to the mucocutaneous junction. Even if I want a longer, I will take some part of the skin also. I can take this epithelium also into the flap if I want little longer. So depending upon the length of the flap required, see my superior incision. I am going right along the roof of the nose. Can you see?
Yes, sir.
To the anterior part. Now, I will come most anteriorly here and make a vertical limb like this right to the level of the floor. Can you see this again? Now the classical Haddad flap would involve this lower incision coming inferiorly,
blade,
coming inferiorly to the level of the floor of the nose, to the level of the floor of the nose inferiorly.
Sir, in live case, what would you use to give incision without bleeding?
I use a cautery tip, fine cautery tip.
Okay.
Very fine Colorado needle. See this coming right to the posterior part of the hard palate. Okay? And then you make, in the classical Haddad, you go along the floor of the septum. See like this? Like I'm not making incision. And join this anterior limb. This way you can raise this entire mucoperiosteum of the same side. Can you see? Leaving the olfactory region behind. Can you see this?
Yes, yes.
Let me elevate for you. Let me raise the classical Haddad, then I will show you the modifications. So this way, I can raise this entire flap. Now being otolaryngologist doing septoplasties, there is nothing great in it. We can raise this flap better than anybody. Just go in the same subpericordial plane and elevate it all the way. In the live surgical situation, we inject the saline to give us a feeling of hydrodissection. Here not. Not adrenaline, saline. See this? In the right plane, the incision we marked, I am elevating this flap and see such a huge vascularized flap coming up. You can easily elevate in no time. And this is what these two men have gifted. This is, I believe me, this is the biggest reason to the success of endoscopic skull base surgery, because in skull base surgery, the biggest obstacle in the early when it started was to manage the reconstruction part, to manage the CSF leak. And that was a major source of morbidity and even mortality. And this flap has completely changed the situation. Now we are creating bigger and bigger defects and reconstructing well because of more and more flaps available. See my incision line which I am elevating?
Yes, sir.
Is that very clear?
Yes, sir.
See this classical Haddad flap you can elevate in no time. And you can reconstruct the defects in the skull base in centimeters. It can reach far anteriorly.
Sir, in your YouTube video, I had seen Haddad himself had appreciated this, your technique while you were doing it.
Oh, I was so blessed that Professor Haddad himself came and commented. And that was so nice of him. These two Argentinian surgeons have revolutionized, believe me.
Yeah, they made us our life.
Sure, no? And say this, you can elevate, you can give more length to the pedicle by going more laterally. See? Going more and more laterally, you can add on the length to the pedicle.
Yeah. Dr. Vinod Felix has joined us.
Hi.
And Dr. Narayan Jaishankar is also here with us.
Hi, Narayan.
Hi, sir. Beautiful job. Hi, Rajeev.
Good to have you guys.
Yeah.
Kripa, hi. Good morning.
Hello.
Hi, Kripa.
I told you last time, Narayan is an accomplished, skull-based surgeon, not limited to the endoscopic or microscopic or anything. And this is the need of the time. I tell you, we'll come to the exact point when I will point out. The reason is, in a skull-based pathology, see, this is the flap, Narayan.
Yeah.
This is the flap. You can raise and you can take anywhere to the skull base. Okay? The only counterproductive thing about this flap is, you have to raise it before you create the defect.
Yeah.
So you have to be little staying towards elevating a larger size flap. It should not fall short, number one. Number two, you have to keep in some areas secure until you finish with your resection so that the flap doesn't get damaged. So what you can do meantime, we can park our flap either in the middle meatal enterostomy we create or in the nasopharynx, wherever we want to. If you want to add on further length to the flap, what we do, we elevate it right to the lateral wall, to the level of the sphenopalatine artery. We can elevate this entire along with the pedicle to give it little more length. Okay? So this is about this flap. Now,
sir, many have this doubt. If there is a septal deviation or a spur, then what precautions will you take to elevate this flap?
Yeah. If there is septal deflection, sharp septal deflection, you have to be staying more careful. That's the only thing. Number one. Number two, even if you give small tears, it doesn't affect the viability of the flap because it is all around having an osmosis with a lot of vessels. And third is, now, first of all, coming to the point that why I respect this man, Narayan and Prabhakaran and all these who are doing 360 work. The reason is, there are many pathologies in the skull base. We'll come one by one to all, which requires nowadays decision making by means of optimizing the appropriate approach. Like for example, if I am given a petrous apex lesion, I have lot of ways to address it. I can go through the ear, I showed you in the temporal bone dissection, to go to the petrous apex by the infracochlear approach. Same thing I can address through the transsphenoidal approach. My petrous apex is there. I will show today in the dissection. Now, which approach to be used to get the best result? That is important to understand and take a decision depending upon the particular anatomy of that particular side. If I have a huge pneumatized sphenoid sinus with my petrous apex, suppose having a cholesterol granuloma projecting almost in the sphenoid, I would avoid an infracochlear approach and use the endoscopic approach. Similarly, if I have a favorable anatomy in the temporal bone, I will go that way. So it is not the surgeon, it is the approach which is needed you are advocating. Otherwise, what happens? If somebody is an endoscopic skull-based surgeon, he will push in everywhere the endoscopic approach because he doesn't know a lateral skull-based approach. If somebody is a lateral skull-based surgeon, he will push in everywhere that approach because he doesn't know the endoscopic one. You should be able to approach able to use all these approaches according to the need for the betterment of the patient rather than what you know, and using that approach only.
So about the flaps, any other flaps you would like to tell us?
Can you speak a bit louder?
So any other flaps? So someone's asking about reverse Haddad flap.
Yes, I am coming to
Paul Casanova flap.
Yes, Paul Casanova I have already shown.
Yeah.
This is classical Haddad. Now, people have given a lot of modifications to it. See, the science is evolving. It doesn't mean the Haddad who have developed this flap is the end of the story. That's how the science is evolving. now creating big defects, needing bigger flaps. So there are a lot of modifications people have developed owing to the better understanding of the vascularity by means of doing a lot of angiographic studies and cadaveric studies. So now, the modification number 1, if I have this flap, the width of this flap is right from here to the roof of the nose, you can see. Okay?
Yeah.
If you want a more wider flap, what I can do, posteriorly at this level, I will go laterally and involve the floor of the nose. I will not make this incision along the septum now. I will extend the width of the flap laterally by going far laterally towards the floor and the lateral wall. See this? I can elevate like this behind laterally, and I can raise a flap far laterally, including taking the entire inferior meatal mucoperiosteum. Can you see the width? How much I can give? So this flap I can raise till here, coming anteriorly like this, and then join this incision. So that flap modification will have, then this incision will not be here at the level of the septum. My incision will extend far laterally and elevate like this, and the entire nasal septal component. So the width of the flap will be almost doubled. In cases of bigger defect, you can add on this modification. Now, if you want even bigger, so this is an amazing flap I am going to show you, which was developed by a Korean guy. What he did, a double vascularity flap, double pedicle flap. What you can do that, see, before going to that, I will show you another flap, that is lateral nasal wall flap. Like the septal mucoperiosteum flap, another area we can raise and utilize as a flap is lateral nasal wall. And this is important to know all these flaps, because many a times, like I remember last month when I was doing an olfactory neuroblastoma, the tumor was involving the septum completely. And we didn't have any other flap, didn't have the possibility of raising the nasal septal flap. So in order to give reconstruction, vascularized reconstruction, what you can do, you can raise the lateral nasal wall flap. Again, it's a huge flap. I will show you. It can be used based anteriorly on the branches of the facial artery here and the anterethmoidal here, or it can be based on the posteriorly on the artery of the inferior turbinate, which is branch of sphenopalatine. So what you can do, if you want to raise anteriorly based, then you have to make incision there posteriorly. If you want to make posteriorly based, you can make the incision anteriorly. Like for example, I am giving this incision right at the level of the pyriform aperture. See this? This is in order to raise the lateral wall flap. This is a huge flap again, very, very useful flap. If you don't have option of using the Haddad flap, you can always raise this flap from the lateral nasal wall by means of giving incision right anteriorly at the level of pyriform aperture. See this?
Yeah.
Yes, sir.
See this? Now inferiorly, I will make the entire, this mucoperiosteum out from the inferior turbinate. Utilize the entire mucosa of the middle inferior meatus and the septal floor, the nasal floor as well. So this entire thing can be elevated together. See this?
Yes, sir.
From the inferior turbinate, scissors. By taking this incision further to the floor of the nose, the idea behind raising these flaps and giving you idea is, once you are doing an endoscopic skull-based surgery, you should be able to use, or in your basket, you should be able to give the best possible reconstruction in the given situation. See, I am taking the nasal floor also.
Yeah.
This way, the Colorado needle in the live surgery is much easier. It gives you bloodless field as well.
So many are asking, what about this raw area which is left behind? What post-operative?
Raw area mucosalizes over the period of time by secondary intention.
Okay.
What you need to give, what you need to give in the immediate post-operative period, you have to start with the douching to take care of the crusting. See now the floor I am elevating?
Yeah, yeah.
This floor, earlier I said with the Haddad flap as an extension, and this time with the lateral nasal wall flap. See this?
Yes, sir.
Entire inferior meatus mucoperiosteum along with the turbinate, all side turbinate mucoperiosteum. This entire huge flap, when you don't have the option of using the Haddad flap, you can use this. Can you see very clear, crystal clear?
Yeah, yeah, crystal clear.
Yes.
And this is amazing flap, I tell you.
So for large septal perforation, which flap would you recommend? Because the Casanova
for
flap.
septal perforation, boss, we have many things in the basket.
Yeah.
The one I have already shown, the Paul Casanova flap. The second is, what we use in the larger one particularly, what we do, we go by the open rhinoplasty approach.
Okay.
We go by the open rhinoplasty approach and we raise the bilateral Haddad on both sides.
Yeah.
One side superiorly based, other side inferiorly based. Haddad means nasoseptal flap.
Yeah, yes.
Bilateral.
Yeah.
So one side you elevate more on the inferior side, one side on the more on the superior side of the perforation, and then we interpose the temporalis fascia in between.
Okay.
Temporalis fascia in between, and then reposite the flaps back.
Satish, what did you do to the nasolacrimal duct in this case?
Yeah, you have to be careful to separate the mucosa from it, so you don't damage the valve of Hessner. That's what I was doing. Now see, this entire flap can be raised like this.
Yeah, yeah.
Right? This is lateral nasal wall flap. This is, believe me, it is difficult to raise than Haddad, number one.
So Satish, what is the vascularity of this? Can you describe
the vascularity of this flap is based on the inferior turbinate artery behind. I will show that vessel. See this?
Okay.
This I will go behind based on the inferior turbinate artery. See the bone of the inferior turbinate which I am keeping intact.
Yeah.
Can you see this?
Yes,
Yeah,
sir.
yeah.
I will show that vessel. See this? And this entire flap, boss, you can take anywhere to the skull base. This is a huge one. When you elevate completely, I just gave you the overview of the steps of using this flap. And this you can take right to the skull base. It is even sometimes bigger than the Haddad flap, as when you take the floor along. And you can take anywhere along. Can you see this?
Yeah, yeah.
Prabhakaran?
Yes, sir.
Yes, sir.
Agree to me?
Lovely.
Agreed?
It's beautiful. Yes, the only thing is the crusting that you will have. You will have significant
crusting is inevitable.
That's
More
the
and
only
more
thing.
saline douching is the only answer to combat the crusting. Saline douching.
So I think the message to the younger ones is that you tailor make your reconstruction on your flap even before the surgery itself.
Yeah,
you look at the scans, you decide how you're going to reconstruct, what you're going to do, even before you start your surgery. So that's the most important thing. So use a flap or reconstruction that will give the least damage and preserve as much mucosa as possible. So you must always decide before you even start the surgery. You shouldn't be looking for the flap in the middle of surgery. So I think that's the take-home message here. Nice dissection, Satish. Beautifully done.
You mean to say, sir, we design the length and breadth of the flap before the surgery?
Before the resection.
Yes,
That is something counterproductive, as you have to plan this before the resection many a times. And then you have to be extra careful. Now, having raised
Please
this
change, sir. So just a minute, sir. I think we have Professor Omura from Japan.
Oh, welcome.
He's actually, he's a very big name in Japan. He has done the maximum number of endoscopic CFR in Japan.
Oh, great.
Yeah,
welcome.
Good.
Then,
Welcome.
Professor, you may be needing all these flaps every now and then. Hello, Professor Omura.
Nice to meet you. My name is Kazuhiro from Omura.
What I was showing was the flaps. This was the nasoseptal flap, this one.
Yeah.
On this side.
Yeah.
This is nasoseptal flap. And this was the lateral nasal wall flap. And what I was saying, this Korean guy, he used this both flaps together. The one vascularity, vascularity to one flap is coming from this posterior nasal artery, this nasoseptal. And the other flap is getting vascularity from the inferior turbinate artery. And you can use both flaps together to cover the largest defect of the skull base you can create. So this is a double pedicle flap one can create. Now, coming to the vessel, I mentioned on that side, this sphenopalatine artery, as it comes out of the sphenopalatine foramen, I will show you more clearer later when I go to this part of the dissection, but here give you an idea again. See, this is the lateral wall, this is the perpendicular plate of the palatine bone, and this is the vessel which is coming out of the sphenopalatine foramen. It gives one branch to the middle turbinate, one to the inferior turbinate, and this particular branch to the inferior turbinate, you know, many a time when you do the turbinectomy, this bleeds. This is exactly 1 centimeter before the posterior end of the turbinate, where it enters. Exactly 1 centimeter from the posterior end of the turbinate. And when you do turbinectomies and all, many a time this vessel bleeds a lot. So you have to be very careful when you do such procedures. So this is about different flap. Now suppose...
Satish, can I interrupt?
Yes, please.
Satish, lateral nasal wall flap can also have a superior base blood supply.
Yes, I told you earlier. This was posteriorly based. I told you we could have elevated superiorly based. Like on this side I show you, this you can elevate the entire inferior turbinate, entire floor, entire meatus, inferior meatus, till anteriorly till piriform aperture, and based here anterior-superiorly, and there it is based on the branches of the facial artery and the anterior ethmoidal artery, and it is a very good flap, but this can be used for the most anterior part of the skull base. So like when you want to use for the most anterior defects like meningoencephalocele or defects of the dermoids you create, sometime you do dermoid surgery which are going intracranial, you can use this flap, the anterior part of the flap. Okay? Now, having exhausted with these flap, and many a times in the revision situation, when this sphenopalatine is already coagulated, and you don't have any option of using any flap on either side. You don't have an option of using Haddad flap. You don't have an option of using lateral wall flap. What you can do, sometimes if the lateral part of the sphenopalatine is intact, you can use a flap based on the greater palatine artery. What is that? That is again our preferred flap. You know, this is the posterior wall of the maxilla. Okay? At the medial end, I will show once I go to the dankers. At the medial end here, the sphenopalatine artery, the internal maxillary, gives a branch going vertically down. That is greater palatine. Okay?
Yes, sir.
Understood?
Yes,
this
sir.
greater palatine goes down in the palate, you know, and this is the vascularity of the palatal flap which plastic surgeons use for cleft palate surgery.
Oliver's flap.
Huh?
Oliver's flap. Oliver.
Yes.
Right.
So what you can do, this is again a huge flap. What you can do, you can use a flap like this. You can raise the entire hard palate mucoperiosteum. Entire. This is again a robust flap because the greater palatine is a big vessel. Based on one side, what you can do, simple. See this quickly.
So Dr. Manish Munjal is asking, what is your experience with bilateral Haddad or attached?
Yes, many a times. I am coming to say that is known as Janus flap. That's a very important question from a senior person. Manish Munjal sir, I will come to it. As I finish this, I will show you that bilateral one. So now, what I am elevating this palatal flap. See this? All this is much easier in live surgery. Flap elevation is always easier in live surgery when blood is flowing. And you do a hydro dissection after injecting the saline. See this? Entire hard palate mucoperiosteum can be elevated. and brought on one side. I will bring everything here by giving this incision, horizontal incision behind. Everything here on the pedicle of the greater palatine on one side, opposite side will coagulate. This side will coagulate. Here is the pedicle. See this? And we'll take this on this side. Now, having raised this, based on a vessel here, how can you bring up in the nose? Let me show you. These are the flaps which are rarely destroyed, and they work. Because most of the time the sphenopalatine are all damaged medially, and this part of the flap still has a vascularity. And you can raise this.
What is the posterior limit of incision in this case?
Posterior edge of the hard palate. We can raise only from the hard palate. See this flap? There's a very thick flap you can see.
Yeah.
And very reliable flap at the other end.
So Dr. Yash Lavana wants to know from Surat that what if we lose the vascularity of Hadad flap? Can we use it as free flap?
No.
Free flap? Not really. Hadad flap is, the advantage of the Hadad flap is, it is having a robust blood supply and it is pedicled. If you make it free, that will go. And that vessel is not so big to anasmose with some other vessel there.
Satish Jain sir, I am seeing this for the first time, this Oliver's flap being elevated.
Really?
Yeah, really. And I don't know if you know that, this was actually first described by a resident. Oliver was a resident when he described this flap.
Okay.
See, take the maximum mucoperiosteum of the hard palate, maximum, so that you can give width to the flap. This way, and it's a huge flap. See how big it is. Now, how to introduce in the nasal cavity? That is the big question.
Satish, you said this will be used for cleft palate. In which nasal conditions will you use this flap?
Pardon?
Which nasal pathologies will you use this
Not
flap?
for nasal pathology, skull base.
The skull base.
Exactly.
When all the flaps are over.
If you want to reconstruct the skull base, the best thing is to have a vascularized tissue. Now, these are the situations, there are situations when you don't have a regular flap availability. And many a time it happens in revision cases. We got a lot of revisions.
One good point by Dr. Ajay Panchal. Can this Hadad flap be elevated simply by using hemitransfixation incision, which we use for the septoplasty?
Yes.
And that is one more simple. I think
Yes, always you can.
The more practical.
That's how I do my Hadad flap, by hemitransfixion. That's how I do it.
More in practice actually.
Yeah. The only problem is when you do that, then when you dissect to the stalk, to where the vessels are, it can be quite blind. So the idea of doing it the reverse way is to identify the vessel first. If you do the hemitransfixion way, it's much easier. I do the same way as well. But there's always a chance of damaging the vessel towards the end.
Yes. Now, having seen this flap being elevated like this, you know, this will be based on the vessel over here. Now, what you can do after that, after having elevated such a big area, you go to the nose. This is the region where this vessel is going below. Okay? Hello?
Yep, we're listening.
We will elevate this floor mucoperiosteum from here. We'll sacrifice the inferior turbinate. And this 1 square centimeter of the nasal floor, mucosa we will elevate, will not sacrifice. See this? We will elevate. And here in the floor of the septum now, floor of the nose, we will drill and make a perforation. Okay? And that flap will be delivered from here, inside the nose. This entire flap will be delivered from this defect here inside the nose. Can you see here?
Yeah.
We will give a bony defect of 1 centimeter, even more, and pull it out. And we will replace this mucosa back so it doesn't give any perforation. Okay? Then
Yes, sir.
elevating the pedal of this greater palatine till here. This will be the level of the pedicle, and this flap can entirely cover the skull base. See this? How big it would be.
Yeah.
That is the situation when you don't have any intranasal flap and still you want a good pedicle flap and still you can get in the surrounding region. Now, in case you don't have any option of these flaps by any means, then you have to go to the outer side, outer flaps. So, two outer flaps I am going to show you today. One is the pericranial flap. See this?
Yeah.
This pericranial flap is raised by giving a bicoronal incision. We'll go later. Bicoronal incision and raise the entire flap, and we'll, by means of doing an osteotomy here in the posterior wall of the frontal sinus, we'll take the entire flap inside the nose to line the entire skull base up to the foramen magnum. Whatever big size you want to raise, you can, and you can bring inside the nose. Okay?
Yeah, yeah.
Another flap, which is again a robust one, but for that you need to go to the infratemporal fossa. If I drill these pterygoids to go to the infratemporal fossa, which dissection I am going to show you today, you can bring in, if you remember in the temporal bone dissection time, I had shown the temporoparietal fascia flap.
Yes, sir.
The huge temporoparietal fascia flap, 20 centimeter, based on the preauriculary here on the superficial temporal artery. You can bring in inside the zygoma into the infratemporal fossa and lie the entire skull base. So that is another flap you can bring in case required. So this is just to give you an idea what flaps you can use in given conditions. Okay?
So the palatal flap that you showed, can that be used for to close the oroantral fistula?
Yes, obviously that is the primary choice. For all oroantral fistula, the palatal flap is the first choice. Second choice is the buccal myomucosal flap. You can use here from the buccal mucosa, the myomucosal buccinator muscle flap along with the mucosa based on the facial artery. That is again a very robust flap for the oroantral fistula, and a lot of people have introduced through the vestibule inside the nose and introduced to the skull base as well. The facial artery myomucosal flap to the skull base. There are so many publications you can see using this facial artery flap. Okay?
Okay, sir.
Now,
so coming back to Dr. Manish Munjal's question, sir, will you tell us about the bilateral Hadad
so
flap?
like Hadad I have elevated on this side, I can elevate the Hadad on the opposite side and sacrifice the nasal septum. See like this. I can elevate opposite side and both sides on both different pedicles. You can use it as a big flap for the skull base that is described by the genus bilateral Hadad flap. Now, you were asking about the raw area. Suppose I have elevated this flap on this side. How can I cover this raw area? What you can do, go behind, remove the posterior part of the, bony part of the septum, remove this completely and make an incision on the opposite mucoperiosteal flap, this Hadad, opposite Hadad, and posteriorly right from top to bottom and bring on this side to line this cavity.
Yes, yes.
So that is to cover the raw area at the expense of giving a perforation on the posterior side, which is mostly asymptomatic. Okay?
Okay, sir.
Yeah,
Sir, also, Dr. Manish Munjal wants to know your experience of septal cartilage attached to Hadad like osteomyocutaneous and CSF leaks. He says that small saddling can be noted eventually. So, what is your experience?
What happens?
Sir, experience of your septal cartilage attached to Hadad,
Okay.
like yes, in CSF
there are
leak.
a lot of people who have described, the same thing, the Hadad, this mucoperiosteal flap, along with the along with the bone or the cartilage. We have tried once, not for any other thing, but for the reconstruction of the orbital floor and the medial wall. It worked to some extent, and people have described it, not for the skull base. For the skull base. Because in the skull base, we don't need any structural reconstruction like cartilage and bone. We don't need that, and we don't do that. Yes.
Satish,
yes.
You have some lovely flaps. Now, can you also discuss one special circumstance? Say you have an esthesioneuroblastoma.
Yes.
So, what are your closure options? What would your thought process be?
Closure. The first choice is Hadad. First choice is Hadad, no doubt about it. If Hadad is not available, then lateral nasal wall flap. Now, looking at the defect, if it is not very big and even the lateral wall is not available, I can use the palatal flap, or otherwise the best is pericranial. Pericranial is so good, so robust based on the supratrochlear and supraorbital vessels, so easy to harvest, so quick. And once you have done a olfactory neuroblastoma, gone to the cranial fossa, you can easily rotate this flap inside. So in that situation, and it doesn't give any visible scar because your incision is hidden in the hair. So pericranial flap can be a good choice in those situations. You can always...
May I interrupt?
Yes.
Yeah, Professor.
So how to do the primary closure?
Primary closure?
Yeah, you are talking about how to do the pedicle flap, but how about, for example, you use fat, yes, or you use fasciolata?
Obviously, that is part of it. We first use the fat as our first layer to the defect. Fat, glue, then we use fascia, and then cover with the vascularized flap, and then we support it from below with something.
So you use fat intradurally,
yes,
and the fasciolata extradurally.
Yes, exactly.
Then do you do the rigid reconstruction, like someone ask you about the bone or some cartilage? Do you think you need the rigid reconstruction?
Never use bone or cartilage or any structural reconstruction of the defect.
Okay.
Cold drink. We don't do
also,
that.
Also, there's a question from Malaysia that Dr. Yaw wants to know what is rescue flap.
Rescue flap, that's an important question. See, I will show here. That's a very important question. When you are doing, suppose, the surgery like pituitary surgery, you may need a Hadad flap in case you give a CSF leak. Many a times, you get away without giving a CSF leak and you really don't need a Hadad. But what happens in the transsphenoidal approach, when you widen the sphenoid axis, if you don't keep an option of the Hadad earlier, you may ultimately damage the pedicle. So what you do in that situation, before doing a transsphenoidal approach, like this on this side I am doing, I will preserve this pedicle by giving a horizontal incision to some extent and turning it little inferiorly to preserve the inferior branch of the nasoseptal artery. I am not raising the entire Hadad flap before that surgery, but I will raise this little bit of the area to protect my pedicle, like this. I will raise this to protect my pedicle, like this. See, like this, and push it down. So when I do the sphenoid enlargement, now you see, you can take away the anterior wall and the rostrum without damaging the pedicle. Now, in case at the end of the surgery, you don't need a Hadad flap, you can deposit it back. And in case you give a CSF leak and at the end of the surgery you need a flap, then you can further raise the flap and use it because you have saved the pedicle. So in the beginning, you save the pedicle as a rescue in case needed. You don't need to raise the entire flap unnecessarily. But yes, you have an option in the end of the surgery if needed, you can then elevate because your pedicle is intact. So leaving the pedicle intact for the end in case required as a rescue is known as rescue flap. So only this part of the job is to be done to save this pedicle over here. That is rescue flap.
So, so do you even do the money box approach?
Pardon?
The pericranial flap that the money box approach, the pericranial flap that we use to close the septal perforation?
Okay, money box.
Yeah.
It is not money box, it is mailbox approach. What is that? That you raise the pericranial flap from here to here. You have not done a sort of lothrops and you want to bring it inside the nose. What you can do is, you can, from here, you can drill a slot in the nasal bone here. 1 centimeter by 1 centimeter slot in the nasal bone to bring your flap inside. That slot is like a mailbox slot.
Okay.
To introduce your pericranial flap inside to the skull base. That is mailbox slot.
So do you make another incision at that level?
Pardon?
Do you make another skin incision at that level?
No, not really. When you raise the pericranium from there, only the middle portion of the pericranium. Yes. So when you raise this incision, the flap up to the supratrochlear and supratrochlear and supraorbital vessels, in the midline you can raise a little bit because in midline there are no vessels. You know, Felix?
Yes, yes, yes.
You don't need a separate incision for that.
Okay, sir.
You can raise with the same incision. Okay?
Okay, sir.
Now, we move to the other advanced procedure to the sinus. For example, this maxillary sinus is so difficult to address. There is a pathology which is far laterally or anteriorly going. Even with your 70-degree angle instrument, you are not able to address that. Number one. So first, what you do, like earlier we described, some people use to go through the inferior meatal antrostomy and gives another avenue for instrumentation.
Yeah.
But still, that doesn't give full freedom. So what we advocate, I will show you the sublabial entry from the sublabial route for my microdebrider, instrument, suction, anything. Let me show you a very simple way. Yeah. Are you oriented?
Yeah, yeah.
I am in the sublabial space. Now the question number one, where to enter into it for that opening with the trocar and cannula. I will be using this trocar and cannula. This is 4 mm. I will be going 1 centimeter above the gingivobuccal sulcus number 1. At what level? Where this bone is, the anterior wall is thinnest. How to have an idea where the anterior wall is thinnest, where it can go easily? Go in the mid-pupillary line. See this pupil?
Yes, sir.
See this? This is mid-pupillary line exactly. So what I will do, Allah lagaya. Yeah. Elevate. See this? 1 centimeter above in the mid-pupillary line and with this direction. Directing towards the opposite middle canthus. See this? Opposite side. This has a guard. You can go inside the anterior wall of the maxillary sinus. Cadaver is a thick wall, I don't know why. This is inside. Can you see?
Yeah, yeah.
Yes,
now
sir.
give me 70 degree and give me red 40. Now let me see. First of all, let me see where I am. Can you see my trocar side?
Perfect, please.
Now with the 70 degree, if I have to go to the anterior wall to work everywhere in the frontal, the maxillary sinus, I will remove that trocar. See this? I will remove this trocar. I will not use any cannula. I will use directly my debrider.
Sorry, debrider.
Directly the debrider. Can you see this? Hello?
Yes, sir.
Yes, you can see, yeah.
Seen
Right
clearly.
here.
Now I have a 360-degree freedom to work everywhere in the maxillary sinus. 360-degree freedom I have now. See the most anterior area to the most, see this is superior area.
Yeah.
This is posterior superior. This is posterior inferior. Posterior inferior, posterior inferior laterally. Anteriorly, everywhere 360-degree I can use this red 40 debrider. I can do a sort of somersaulting of the debrider blade inside. See this?
Yes, sir.
And I can use anywhere. So this is for the maxillary sinus. In case you have a difficult access to the far lateral regions, far anterior regions, you can have an additional avenue of instrumentation. Okay?
Yes, sir.
Now, coming to 0-degree back.
How do you really decide between the inferior meatal window and the sublabial? Is there an inferior turbinate window and the sublabial window? Inferior meatal window. How do you really decide between the inferior meatal window and the sublabial window to approach the maxillary sinus? Is there some criteria you follow?
Inferior meatal window we never do.
Okay.
This sublabial is more versatile. It gives you 360-degree freedom under vision with a 70-degree telescope. And the moment you remove your this thing debrider, this mucosal incision heals in no time. In 1 or 2 days it heals up and there is no complication. This region is free of complications and it gives 360-degree freedom.
Okay.
Dr. Amit Kesri is asking regarding the pre-lacrimal approach, and Dr. Amit Kesri giving a regard to Dr.
I will
Professor.
show today because in the live surgery that day I showed the dankers.
Yes, sir.
That time was a discussion on the pre-lacrimal from Professor Sethi. Is he with us?
Yeah, he can join us, no issue.
So I will show today now the basic difference between the pre-lacrimal and the dankers. So there should not be any confusion, and see the advantage of dankers over the pre-lacrimal. So again for us, pre-lacrimal is almost obsolete. It is the dankers which is the approach of choice, modified dankers because it is endoscopic. The dankers initially were described through the sublabial route by the dankers years back. Now it is modified totally through the endoscopic route, so modified dankers, and this was described by the Stanman-Canfield. So this is known as Stanman-Canfield approach as well. Just a moment, having cold drink.
Yeah, have it.
Sir, also Dr. Manjunath is conveying regards to you, and he's asking that he wants to know the difference between the olfactory epithelium and the normal epithelium. How will you differentiate?
Okay. Is this Manjunath ready?
Manjunath, yeah, from Hubli.
Yes, his master Manjunath Reddy.
Yeah.
He is an amazing lateral skull base surgeon, for your information.
Yes, yes.
So great Manjunath, there is a lot to learn from him in lateral skull base. So that's a very important question, how to differentiate into olfactory and the normal epithelium. First of all, by naked eye you cannot, it is a histological differentiation. But by studies, the areas where the olfactory epithelium is abundant is in the region of the cribriform plate. See this on this side. This is middle turbinate. This is septum. Between those two, see this pale looking epithelium. This is all olfactory epithelium, and it goes on the contiguous areas of the upper part of the lateral nasal wall, on the turbinate, and the upper part of the septum. So by and large, this entire area is having olfactory epithelium, and working in this region, if you remove this, can have an impact on the olfaction of the patient. Okay? Now, coming to the Amit Kesri's question, what is pre-lacrimal and what is the difference with the dankers? I will show both. Number one, Here we have already done the orbital decompression. So best is to do on, okay, prelacrimal on this side only. Now, knife. The idea behind is, see, with this medial wall as an obstacle, we can't control or we can't go inside the maxillary sinus with a 0-degree endoscope. There is no view of the maxillary from this side. So, if you remove this medial wall or create some access to the medial wall, head-on access to the maxillary sinus, you can certainly have a full control in that region. So, the obstacle in the removal of this medial wall is lacrimal duct, nasolacrimal duct. And people are scared because of its own complication if not done properly. So, in Denkers, like I showed in the live surgery, we have a live surgery on Thursday of a juvenile nasopharyngeal angiofibroma where I will be showing the Denkers again. So, in Denkers, you remove the entire medial wall and part of the anterolateral wall and we cut this nasolacrimal duct flush to the orbital floor so that it doesn't give epiphora in the future. In prelacrimal, you don't damage the lacrimal, you stay anterior to it. So what is that? What is that? I am going to show you. Yeah, see this? At the level of the pyriform aperture. Can you see this?
Little bit out.
Yeah. I am making the incision. I am making the incision at the level of the pyriform aperture. Can you see?
Yeah, we can.
Yes,
Yeah.
Yes, we can see.
Yes, this is bone deep. Now, what I will do, I will elevate this flap of the bone. See this?
Yeah.
Here, you are not supposed to damage the inferior turbinate or the lacrimal duct at all. This is prelacrimal. Further on with the Denkers, we will remove everything. And same thing, I will elevate this. This is done better in the live surgical situation with the cobblator. You have seen that day.
Yes.
Cobblator hai na bhi yahan? Dena.
Regarding next Sunday, Satish, we are having facial nerve session for 6 hours.
Pardon?
Regarding Sunday, next Sunday,
yeah,
we are having facial nerve session for 6 hours.
Yes, full day.
Full day.
That is both live surgery and cadaver. That is a full day workshop, most likely on facial nerve. The cadaver will include the demonstration of the facial nerve anatomy right from its origin in the brain stem till its destination to the facial muscles. And then at every point of time, we'll discuss the pathology at each level of the course of the facial nerve which can affect the nerve, how to handle them, how to tackle them.
Flaps. Okay.
Then in the second, in the cadaver, in continuity, we'll have all procedures of demonstration of nerve anastomosis, reanimation, almost 50 procedures in the facial nerve, reanimation and anastomosis that will demonstrate on the cadaver. And then after at least 2 cases of live surgery of facial nerve anastomosis like fasciomesenteric or other procedures. So it will be a full day, half day cadaver, half day live surgery on facial nerve. But Thursday will be pure live surgery.
Yes.
And this time, last time we kept the vascular tumor paraganglioma, glomus jugulare. This time we are keeping other vascular tumor, juvenile nasopharyngeal angiofibroma and carotid body tumor, along with some other skull-based cases.
So request to all, please keep your Thursday 4
PM 4 p.m.
And Sunday morning 10:30 to 3:34 p.m. free on Sunday and Thursday.
Now, can you see this pyriform aperture?
Yeah, we can see.
Yeah, so Thursday is 4 p.m. India time.
Yes, yes.
Now see, for this pre-lacrimal approach, I have preserved this flap. Can you see this? I have preserved this flap, mucoperiosteal flap.
Yeah, we can see.
And expose this bone, which I am removing now a little bit with a punch, and then I will drill away. And enter into the maxillary sinus without damaging to the nasolacrimal duct, staying anterior to it. See this?
Yeah.
See this anterolateral wall, this is medial wall. Can you see both?
Yeah.
Yes.
Anterolateral wall and medial wall. Give me the drill. And I will show you exactly where the... Oh, where the pedal? No, यार इधर उसको छोड़ो ना, रिलीज करो ना उसको उधर से.
Satish Jain sir, is it better to preserve the pyriform aperture rim to prevent cosmetic deformity?
Pardon?
Is it better to preserve the pyriform aperture rim?
It's not so important, I tell you. The important thing is the preservation of the flap so that you can resuture it back and cover it.
You need to preserve the periosteum. If you preserve the periosteum, then you will not have any collapse.
Yes.
So the incision must go straight to the periosteum. The bone itself is not important.
So Prepa and Satish, I want to ask you all a question. Both of you do quite a bit of angiofibromas. So what are your thoughts on Denkers? The controversies about use of Denkers in this younger population.
Denkers in?
In this younger population of angiofibromas, for example, would you stick to a medial maxillectomy or you have no hesitation doing a Denkers?
Pardon, Narayan, can you repeat your question? The drill, I couldn't hear you.
Sorry, the question is, in the cases of angiofibroma, would you hesitate to do a Denkers or would you would you prefer to just stick to a medial maxillectomy or would you go and do a Denkers without a second thought?
The reason is, Narayan, like this in Thursday case also you will see. The reason for doing Denkers is, number one, to give it gives you a space to maneuver your instruments, The best space you get to maneuver your instrument is with the Denkers. You get full space to maneuver your instruments. And in the vascular tumor, like angiofibroma, you get ample of space to control the vessels as well. That's why in angiofibroma we prefer this, except in grade 1 cases, purely intranasal cases. Then you really don't need. You just go to the spinopellet. See this, my entry?
Yeah.
Can you see? And
Yes,
at the end of the surgery, I will reposit this back and suture this. Can you see this? To cover everything.
Yeah.
My nasolacrimal duct is not damaged. See the maxillary sinus behind. And I will put just 2 sutures at the level of the pyriform aperture. See this? You went into the maxillary sinus anterior to the nasolacrimal duct, did your job and come out. Now, why we prefer the Denkers? Number one, first of all, this is a narrow axis. For regions you are doing, if it is a non-tumor, you can go by like I did to the sublabial approach, that entry into the sublabial can be sufficient for a simple situation. If it is a tumor, and you are removing the tumor by this approach, then you are not leaving an option of surveillance. By closing this window, you cannot do a proper surveillance which is required if you are dealing with a tumor. Suppose I am doing a papilloma, that did the same case. Now after the Denkers, if I put a 0 degree, I can see the entire area where the tumor I can surveil for the future. So by means of doing a Denkers, you leave the opportunity for future surveillance. And that is the biggest advantage, because then you don't need radiology again and again to see the recurrence. You put your 0 degree and you see everything in front of you. You don't need 0 degree, the radiology at all. Got my point?
Yes,
so
sir.
that is the advantage of that.
Satish, that's good for tumors. I'm talking of angiofibroma. like you and Prepa have done it. Prepa, what is your view about Denkers and angiofibroma? Do you
the
facial growth?
Yeah, the issue is the facial growth, but usually the anterior 1 or 2 centimeters of the anterior wall of maxilla is not part of the facial growth as such. And even when we do Denkers, the amount of bone that we remove is probably just 1 to 1.5 centimeters. I'll only consider Denkers if the tumor extends lateral to the infraorbital nerve. If the angiofibroma goes between the thyroid muscles and goes lateral to the infraorbital nerve, then I might consider Denkers. But otherwise, usually if the tumor is medial to the infraorbital nerve, you don't really need Denkers. An endoscopic middle maxillectomy is adequate. But what you can do is you can make a window in the septum so that your instruments can and your scopes can come from the opposite side, and your colleagues or your fellows can hold the instruments to a window in the septum. So in that way, you may elevate the need for Denkers. But if you ever need to do a Denkers, you just need to remove 1.5 centimeters, just enough for the scope to go in at least. You do not, that way, you do not really affect the growth of the face as such. I hope that answers the question. One of the reasons why I'm not in favor of a pre-lacrimal approach is exactly like what Satish says. I feel that I would rather do an endoscopic middle maxillectomy and do it well, because that gives me the advantage of being able to do an endoscopic examination of the cavity to see any recurrence. I find the idea of doing a pre-lacrimal approach and then doing a CT scan every year or every 6 months just for surveillance it's a bit too much of a drain on the resources, and as well as unnecessary radiation to the patient. And then the endoscopic middle maxillectomy that is done properly has got almost nobody complains of nasal obstruction or an empty nose syndrome with middle maxillectomy. If it's done properly, I think it's a very good way, and it's much better than the pre-lacrimal approach. I hope that answers your question.
Yeah, wonderful approach.
Yes, sir.
Wonderful.
Yeah.
So, Prabha, how do you handle the inferior turbinate in this malignancy cases? You
just remove it.
Remove it.
Yeah, sorry, yes. Which Narayan or no me now?
So you can continue what I'm doing. Since we have already discussed about the sinus surgery on the opposite side in detail, I am just finishing off this side, the sinus surgery.
Lovely, beautiful,
so
yeah,
that
I can see that, yeah.
Quickly, in next 5 minutes, straight. So that I can show the common approaches, midline approaches, quickly.
Sure, excellent. So the question about malignancy. So if I have a sinonasal malignancies, what my oncological margins would be, I only leave the skull base, the orbital rim, the anterolateral wall of the maxilla, cribriform plate. I will remove everything else.
No problem. Suppose you have benign tumor in the maxillary sinus.
Right.
Do you preserve the inferior turbinate if that is not involved by the tumor?
It depends on how much exposure do I need. So you can actually do a large middle metotomy, a large maxillary opening. And if that's adequate to remove the whole lesion, then you don't need to remove the inferior turbinate at all. But if the lesion is anterolateral wall of the maxilla or the floor of the maxilla, and you can't visualize and you can't see, then I will do a middle maxillectomy. So it depends on the size of the tumor and the size of the pathology itself. If a tumor can be removed well by a large maxillary opening, then you don't need a middle maxillectomy.
So you don't routinely remove the inferior turbinate for post-op tumor surveillance, right?
No.
What about Omura? You have a different opinion, or is this the same? I think Dr. Omura, how do you manage the tumors in the maxillary sinus?
Yeah, so I'm published the direct Dharma approach that I can preserve the piriform aperture, but you can also drill out only the frontal bone of the maxilla. Then you can also preserve the piriform aperture and also inferior turbinate and lacrimal bone, lacrimal duct also, and you can make a very working.
So you preserve the lacrimal duct and the piriform aperture rim. You remove the bone behind the lacrimal duct and anterior to the piriform aperture rim, right?
Exactly. Laterally of the anterior wall of the maxillary bone.
That's exactly
only the piriform aperture. If you preserve only the piriform aperture, then you can go directly to laterally and also medially. And then as you say that if the tumor is benign, then you can resect with surgical margin.
I think the most important fact is that the pathology dictates the approach. So we don't operate thinking, oh, I'm going to do this today. You look at the scans, you look at the pathology, the extent of the lesion, and that dictates the approach. So what we expose, it's almost completely depend on the extent of the pathology. We don't go into operation theater with one fixed idea. I think that's the take-home message.
Hello.
Yeah, one thing, Dr. Satish.
Hello.
Satish.
Sir, we are there with you. So now what are your plans? What are you doing, sir, now next?
Hello.
Yes, sir.
Yeah, we can see.
Yes,
we can hear
so
you.
I just finished the sinus surgery on the opposite side quickly.
Okay, sir.
Without demonstrating, we have already discussed in detail on the other side.
One thing you left, Satish, one thing you left one is regarding the supraorbital cells. People wanted to see it.
Okay, see this side.
Yeah.
What is supraorbital cell? See this. This is the orbit. You can see with the 70 degree.
Yeah.
This is the orbit. This is orbit.
Yeah.
This is anterethmoidal artery.
Right.
This is frontal sinus above. Caudal to the frontal sinus behind. See this recess going above the orbit?
Yeah.
This is supraorbital recess. Sometimes it is even very, very deep. Going far laterally and beyond the orbit sometimes. See with the 70 degree the depth of this recess.
Yeah.
This is supraorbital going above the orbit. This is a very important anatomy, as once there is a fully developed supraorbital recess or the cell, it is always the artery which is pushed caudally. This anterethmoidal artery is always a caudal anatomy to the supraorbital recess. So whenever you see supraorbital recess, the anterethmoidal artery is always caudal to it. Okay? So that is supraorbital recess. So I just did quickly so that we get back to the important issue. This is frontal sinus, supraorbital recess, anterethmoidal artery, skull base, the sphenoid sinus there, the maxillary sinus there, and the middle turbinate there. Okay? Now, as we discuss about the extended procedures on the frontal sinus, okay? The most important procedures on the frontal sinus, as I said, the only area where we can extend is anteriorly. Anterior is risk-free area.
Okay.
So what I can do in the live surgery, this entire mucoperiosteum anteriorly, above the level of the axilla, we make a flap. But here I am removing so that, see this mucoperiosteum? See the level of the axilla. Now, I told you my frontal sinus is here. In draft, you remove the entire anterior wall and the floor. Okay? So in order to remove this anterior wall and the floor, you need to expose this, first of all, by removing this mucosa. And the second thing you need to be careful in the dankers, in the draft procedures, is to avoid injury to the cribriform plate. The skull base is immediately behind. So how to avoid the injury to the skull base? See this? For everyone, this is a very, very important step.
Yeah.
My area of the frontal sinus floor is here. That I have to completely drill off, this region. This is my frontal sinus, you can see.
Yeah.
And this area anteriorly I have to go. But I have to define my posterior limit first, so that I don't end up injuring the cribriform plate, number one, skull base. And number two, if I go right up to the beginning of the cribriform plate to give a wide opening, the chances of stenosis of this overall opening is very less. Okay? So now, see this mucoperiosteum? This is the level of the inferior middle turbinate. I am raising it inverted behind. See this? What I am looking at, the posterior limit of my Lothrop's opening, draft opening. And that will be the beginning of cribriform. How will I have an idea? Keep on elevating behind. See this close up. See the close up. Can you see something?
Yeah.
Yes.
Perfectly.
Can you see something? Anybody, what is this?
Vessel. It is branch of, I think, artery.
This is the ethmoidal
artery, branch of the
anterior branch of the ethmoidal artery.
Yes, yes.
And a nerve which comes over here. Let me remove this sickle, you know. And then immediately caudal to it. See medially what is there.
Olfactory, first olfactory.
See, there are two structures. This anterior one is a lateral structure which I am sacrificing. See this?
Vessel.
Can you see this canal? And see behind a more medial structure where the fold of the dura is coming out. Can you see this?
Yep.
Yeah.
That is first olfactory neuron.
No, yes.
So don't get confused. This is the canal for the anterior branch of the anterior ethmoidal artery and the nerve. This is lateral structure, and the medial behind is the first olfactory neuron. See, this is the dural sheath which is coming out. Can you see it very clear or not?
Yes, it's clear. It's very clear.
There should not be any confusion. Now, staying anterior to it, I can remove this entire floor completely. Can you see this? And if, see this, I am with a 70 degree. This is your frontal. This is the entire floor, and above this floor is the frontal sinus. If I remove this entire floor and allow this frontal to drain in the nasal cavity, that marsupilli is known as something defined by the draft into various categories. So if you work at ostium level, that is draft 1. Now if I remove the floor completely, up to the level of the turbinate medially, it is draft 2A. See, this is the level of the middle turbinate. If I remove my floor, up to this level is draft 2A. Okay? And if I completely flush with the nasal septum, this is draft 2B. So let us first show you the draft 2A. Okay? And what I will do, I am using a different drill because my regular, the stylus drill which I always use, I have always shown the 15 degree stylus, high speed, is broken, you have seen. So I am using the straight one. Anyway, Panidal. So my landmarks for this now I am back with a 0 degree, and the entire work will be done with a 0 degree again. For anybody who is interested in doing the draft, believe me, you are working in the safest region, number 1. It is a lot of bone work that is frustrating. Otherwise, there is nothing great into it. This entire area which the bone I am exposed, this bone I have exposed has to go so that the frontal sinus completely open in the nose. All this obstacle of this bone will go. That's how the frontal sinus will be visible and draining. And that will be draft. So this area is free of any neurovascular structures. My limit will be, laterally will be skin, anteriorly will be skin. Okay? So to begin with, I will start from below. Pandal.
Satish, later you must show the drill also that you're using.
Yeah, this is a high-speed drill. Again, this is from Medtronic, but this is not the one which I use, the 15 degree.
Yes, the slim one.
That transnasal burr, which I use from the stylus, has a self-irrigation mode. This doesn't have a trans-irrigation mode, so we are using the outside irrigation. See what I am doing here? Just before the level of the axilla, I am flushing with the outside skin from the lowermost part. Can you see?
Yeah.
So as to define my lateral limit. What I intend to do here is to define my lateral limit. And you will find the lateral limit as you see the change of color. This draft has so many indications, and indications are expanding. Earlier, the open approaches of frontal sinus were very popular, the osteoplastic flap and all, which now with the advancement in the endoscopic technology have almost obsolete. There are still some indications we are using, I will tell you. Can you see the lateral limit? This is outside skin.
Yes, it's very clear.
change in color. Let me show you from outside. Can you see?
Yes, beautiful.
That is my lateral limit. Now having the lateral reference in view, now I will keep going from behind to anterior. See this? And all.
What is the basic difference between outside in and inside out for drug?
So outside in is another technique which is propagated by, I told you that genius Richard Harvey. So Richard Harvey promoted the technique outside in. What is that? Let me show you. See, why I am doing this way? So that I have already defined my posterior limit here and I have already defined my lateral limit here. Okay?
Yes, sir.
Now I am going posterior to anterior till I find the anterior skin. Okay? What he says, to carry out it faster. That's a good concept, I don't deny. To carry out this faster, he says, after defining this posterior limit, olfactory neuron, he goes anterior directly into the sinus. Saying that once you have defined your posterior limit, you cannot define anything, danger, anything here. The only thing is the skin anteriorly. So if you define the sinus early and then go around, you can do faster. That is the concept. I don't deny that. But this is the traditional way and simplest way to learn, which I am showing. Now see this beak I am removing. Entire thing I will remove, keeping my lateral limit as I have already shown the outside skin. And will keep going laterally, anteriorly.
I think the question to whether to use inside-out technique or outside-in technique.
I do mostly outside in.
Yes, if it's the frontal sinus is pneumatized, then you can do outside in. If your frontal sinus is not pneumatized, then you do inside out. So it's just a matter of safety.
Yeah. They see those who are doing Lothrops.
Yeah.
They can easily understand the outside in.
Correct.
But for beginners to understand, it's a little difficult.
This is safer. It's always safer to do.
Yeah, because here you are going by the known landmarks.
Exactly, yeah. So it's always better to identify the frontal sinus and work your way around. The other problem with this is...
Once you are used to this, you know the anatomy, you can do anything.
The other problem with this is the drilling actually causes a lot of osteogenesis. So it causes a lot of bone reaction, osteoblastic reaction, and bone and the bone will tend to regrow as well. So I think the Lothrop tends to be overdone sometimes. Quite often you can get away with rough 2B, but the more you drill, the more scar tissue you will form. So sometimes if you can use curette or a punch and remove bone, you will find the amount of scar tissue that you have, the amount of restenosis is actually much less as well. So it's a balance between opening, preserving mucosa, and how much stenosis you're going to have.
Yes. You know, Prabhakaran,
yes, sir.
What we do to prevent that? Number one,
use flaps,
that was the problem in the beginning. See now with the 0 degree, our sinus is coming into the view.
Very good.
That was the initial problem when this science of Lothrop was introduced, the stenosis and a lot of issues. Now, we irrigate with a steroid solution post-op.
Right.
So that problem of reaction, stenosis, granulation is much less, number one. Secondly, we don't leave too much of raw areas behind.
Yes.
We use a vascularized flap or the free mucosal grafts. Got my point?
That's true, yes.
To prevent the reaction.
So these are the points that you must remember if you're doing this kind of surgery. It's not just opening it up, it's also to make sure it doesn't close back.
Yes.
Because the chances of closing back is around 30% of it actually restenosis to a significant amount.
But now, these were initial figures. Right. Now with the more and more use of steroid irrigation.
It should be much less now,
Yes. Now see, I removed a part of the beak. For the orienting the people. See now, this was my inferior turbinate. See this one? This is the ethmoidal artery we saw. I am doing with a 0 degree. This is your olfactory neuron here. Okay?
Yes, sir.
And this is my lateral limit I have already defined.
Yeah.
And I keep on going anteriorly. See this? Keep on going anteriorly.
The anterior is very safe. Everything is at the back.
Yes. The only thing, if you are not careful anteriorly and keep going, only thing you do, you can give is a buttonholing.
Yeah.
That you can put a suture outside. That should be avoided, but that is a complication at the most you can give. See, now I am keep going anteriorly until I reach the
Skin.
outside skin. See how thick is the beak. It's more than a centimeter. See now with a 0 degree. More and more sinus coming into the picture now.
Yeah, very clear.
Actually, I am not today. The other bar is broken. Otherwise, I would have finished by now. Anyway.
This bar is a bit thick, though.
Yeah. See now, once I have seen the sinus cavity proper, see this? I can keep moving medially as well. Safely. Can you see?
Yeah, very clear.
I can keep moving medially because medially I have seen my posterior limit I have already defined. That is first olfactory neuron. I will not go beyond that. See that?
Yes.
This is, see, this is my first olfactory neuron. So I have to stay anywhere anterior to it.
Okay.
May I comment?
Yeah, sure.
So, as Prepa said, if the frontal sinus is not pneumatized, well, now you can see the right side of frontal sinus and you can nicely view it. But if from the CT scan, if there is a very small non-pneumatized frontal sinus, then it is sometimes dangerous to go through the go across the border between right side and left side, because sometimes you can drill out the endoscopic.
Yes. Can I make a comment on this?
Yes, sir.
See, I mentioned there are certain indications for the open approach still. That is osteoplastic flap approach. Okay?
Yes, that's true, yeah.
Now, when to do Lothrops, when to do open? This is a big question and I'll give you a crystal clear answer to it. First of all, what do we achieve with the Lothrops? See this. A big opening, give me 70 degree. See, I don't have a proper burr. That is 15 degree angle. See with a 70 degree. See this much I have drilled. Okay? Hello?
Yes, sir.
Very good. Yeah, very clear.
This is the outside area skin. This bone, if I remove till here, this bone completely, then the entire sinus would be marsupialized. Can you see this?
Yep.
Yes.
And this is my medial limit here where the cribriform is beginning. See this first olfactory neuron. So, what do we get out of this? We get a big opening with good ventilation and drainage of the frontal sinus, preventing future problems of frontal sinusitis. Okay? In case we are doing for sinusitis. Now the indications have expanded. Let us talk about the sinusitis only. So in the end, what do we want? We want a good big size cavity draining into the nasal cavity. For big side cavity to remain where the drugs can go inside, the final size of the ostium should be bigger. Okay? So my indication for this draft 3 or draft 2, whatever, in frontal sinusitis for inflammatory disease is when the frontal sinus is big enough where I can leave a big opening. Got my point?
Okay, sir.
If the particular patient has a very small frontal sinus, in spite of doing a draft, I will end up giving a very small opening which can close any time.
Okay.
So to me, that is a relative contraindication for doing a draft.
Okay.
And for them, those patients, the best is obliteration of the frontal sinus forever. So in that situation, still I do open approach, that is one short answer. Come from above, bicoronal flap, it's not visualized. Then remove the anterior wall of the frontal sinus bone flap. Remove all mucosa. Remove all mucosa, drill away everything. And then obliterate with the fat. Plug the frontal drainage and obliterate with the fat. What will we achieve ultimately? No inflammation can go once you remove the mucosa and obliterate. Okay? Now, why obliteration is done in those situations? Because in that situation the sinus is small. You can afford to remove the mucosa easily. What my point?
Yes, sir.
Now, on the other hand, if you think, if I am doing obliteration for a big sinus with big, scallopings, what will happen? I cannot ensure a complete mucosal removal from each and every nook and corner of the frontal sinus. And if I take up such a big sinus for obliteration, it is a disaster. The mucosa which is left inside will lead to mucocele formation. Got my point?
Yes.
So for bigger sinus, best is to give a drainage like draft 2 or draft 3, whatever is indicated. For a smaller sinus, don't fall into draft. Just straight away go and do a obliteration. This is one thing by and large very crystal clear. Now the second thing is, this is for inflammatory conditions. We have many times cases coming with a draft done somewhere else and still the pathology coming back because it was not adequately done and the primary pathology was not adequately addressed. Like if it is AERD, you have to address the primary disease, otherwise there is no point. If it is eosinophilic, you have to address the irrigations post-operative properly. If not done, it will come back. And if it is all said and done, taken care of, and if the surgery is not done properly, means the widening of the ostium is not done properly, it may narrow down and fail. So, in the failed Lotrops, again you have an option. It doesn't mean a failed Lotrops cannot be revised and do osteoplastic. Still you can revise. Secondly, a failed osteoplastic because of any reason. You have done a cavity obliteration with a fat and obliterated the frontal sinus. If the mucosal removal was not complete, it can come back with the problems. That still can be revised by a revision osteoplastic, and many a times if mucocele is there and a good big size frontal sinus, you can revise with a draft procedure. Even a previously done obliterated sinus can be revised with a draft. Now, having said and done all this, every time the situation is not so crystal clear. We have got so much complex situations, you will not believe. N number of time patients operated, 2 times draft done, 2 times obliteration done, and the patient has still frontal sinusitis. Then we have to think of elimination procedures, which I am going to show you. Elimination means, now the final answer is eliminate the frontal sinus. The frontal sinus should not exist to give frontal sinusitis. So what you can do in those extreme situations when nothing is working? See, behind the frontal sinus is what? The cranial cavity. In those situations with repeated surgery done and the posterior wall is also partially gone, you can remove the posterior wall completely. Drill away the inside of the frontal sinus completely to saucerize everything, remove the mucosa, and allow the brain to expand anteriorly till anterior wall.
Canalization.
Obliterate the frontal outflow with a periosteum or something, and this is cranialization. So now the frontal sinus is eliminated and the brain is expanded till the anterior wall of the frontal sinus. That's it. Forget about the frontal sinus. There is no frontal sinus to give future frontal sinusitis. Got my hope?
Yes.
This is extreme procedures.
So with small frontal sinus, how can you make sure that the mucosa is all out before you obliterate?
Yes, in small sinuses, when you open up the frontal sinus from outside, everything will be under vision because it is not so big and beyond your visualization. So you can easily remove. As compared to a large sinus with huge scallopings beyond your visualization, which you can leave the mucosa behind. So smaller is always a...
So we should not obliterate.
Smaller you should obliterate. Smaller are the best for obliteration. Larger are best for the drainage. I hope you understand this, what I am saying after this discussion. Another thing, because of the repeated frontal sinusitis, you have the anterior wall of the frontal sinus gone. Now you cannot afford the cranialization because the anterior wall is already gone. If you allow the brain to expand to the anterior wall, it will be exposed outside, can get infected. In that situation, when the anterior wall is gone or posterior intact, the procedure is known as facialization.
Okay.
Or Riedl's procedure. Riedl described this. What he described? Remove the anterior wall completely. Drill away the inside of the frontal sinus completely with mucosa and all. Drill away the inside bone completely. So no diseased tissue remains. Block the frontal outflow and allow the facial skin to fall on the posterior wall. There is no frontal sinus as such existing anymore. The facial skin is falling directly on the posterior wall. Got my point?
Yeah,
that is known as facialization. And now we have eliminated the frontal sinus again. There is no frontal sinus at all. So cranialization and facialization are two extreme procedures of the frontal sinus, which you can think of according to the indications. In the
what about the cosmetic deformity, sir? Cosmetic deformity after the facialization?
Yes. Because of this cosmetic deformity, depression, this procedure gone to disrepute. You know. But now, again, because of the the introduction of the bone cement, again it has come back to the revival. Now what you can do, whatever the defect you have left after drilling away everything, you can camouflage with the bone cement.
Okay.
Okay? Bone cement is now being extremely used in the cranioplasties anywhere. Anywhere. Okay, so you can camouflage with the bone cement and surface it to the level so that no more defect remains. No frontal sinus, no defect. And I think that is the final answer to those situations. Any questions on this?
One basic question: how you maintain the built turbinate while doing drilling for the draft? Because it is very, we have to manipulate a lot.
Yes, you have to sometimes partially resect it. It doesn't make too much of a difference when you are dealing with such a pathology.
So Prepa and Satish, I want you all to throw light. Sometimes you get these CSF leaks from the posterior table of frontal sinus. Posterior table of frontal sinus, CSF leak.
Yeah.
So what is the preferred mode of approach? Would you go for one of these endoscopic approaches or an open approach? What would you do?
Now, as I told you, how it is evolving so fast. Nowadays, in last 5 years, I have not done a single open. All endoscopic. And I will take you the maneuvers. Now I am coming to that. The extended graft approaches. I am going to show you 5 to 8 approaches.
Let Prepa also answer that. Prepa, what would you do?
Yes.
Most of the leaks from the posterior table of frontal sinus usually stops on its own. So you can actually wait for a while. But if you want to repair that, instead of doing osteoplastic flap, one, you can do an endoscopic through a lotrom. But the problem with that is you have a large cavity, and then once you have repaired, you have nothing to hold up the repair. So that's the problem with doing endoscopically through a draft 2B or a lotrom. You have a big cavity, the gravity will pull whatever substance or material that you put to hold your graft back. One easier way is to make a simple eyebrow incision, drill a little bit of bone, and put in an endoscope, and you can actually look straight at the defect, if depending on where the defect is, and then you can actually close it back very nicely. And with that, you can not only repair, you can also have put gel foam or whatever to hold the graft back. So it depends a lot on the size of the defect, the location of the defect. Obviously, very large defects will need open surgery. But again, it depends on where the defect is, how large it is, and how pneumatized the frontal sinus is.
Okay, Satish. Satish.
Yes. I tell you, Narayan, can I add on?
Yeah, Satish, let me add before you say your final word. So you and Prepa are fantastic, say, endoscopic surgeons, okay? For ordinary human beings, would you also suggest like pericranial, open surgery, which we do, and lay on the sinus, inner table? Okay.
That's a very good question.
More secure and less of drilling and handling of the frontal sinus.
Sir, can you repeat the question again? It's an interesting question. Can you repeat it again, sir?
So again, my approach to frontal sinus posterior table leaks is not to do it endoscopically. I would rather have an open approach and lay a pericranial flap from the cranial side to seal this leak completely. Find it better than giving all the difficulties of doing it endoscopically. Of course, you require a lot of tact. That's one part. But again, the stenosis and again, whatever Prepa already said, I think it's a much secure way to just do a bifrontal craniotomy and lay a pericranium on that area and seal it up. What say Satish? Easier approach, better, less morbidity.
Now, Narayan, I tell you, see, in CSF leaks, what all you need, wherever the defect is, you can address endoscopically if you have an exposure to that area. You know? Maybe the cribiform, what all you need? The exposure of the bony defect. Because the sealing of the leak is same wherever it is coming from. Whether it is coming from the sphenoid sinus, cribiform, frontal sinus, the final sealing of the bone defect is same. That is, you have to plug with either fat or muscle, whatever you are using, and then reinforce with the fascia and glue and whatever. Same. The difference is the site-wise exposure. In the frontal sinus posterior table, the why people are going away from the endoscopic approach, not using the time it consumes to expose by means of doing a draft approach. Believe me, if you are fast at doing draft, this endoscopic, you can finish off in 15-20 minutes. Then once the defect is in front of you, you have to do the same thing, like you do for any defect. You plug the defect with the fat, resurface it and put something, fascia or something, and pressure and come out. So for frontal sinus anywhere, believe me, if you start doing, the best is endoscopic, number one. You have to start loving endoscopic because it takes time sometime. Number one. Now for the junior colleagues who are not very good with these approaches, I'll give them an idea what they can do. Let me finish this draft 2 on this side. 1 minute.
Yes, sir.
See why I'm taking time. Why I'm taking time? Because my regular burr is not available. I will tell you the way how somebody can easily do it without facing any big problem, and then you can take the help of trephination. I will show you how one can do a trephination. See, with more and more endoscopy, the trephination being done less and less. But still, in the learning curve, if somebody is finding problem, it can rescue you from lot of problems. See, now I am doing with a 0 degree. Can you see?
Yep.
See, more and more widening of the frontal. This is draft 2 on this side. Yes, what I need to remove this little bit of the bone. See the skin, anterior skin?
Yep.
And before the anterior skin, this little of the bone is left. Can you see this little bone is left?
Yep.
And once this bone is removed, this will be a wide opening. Once I finish, I will show you that maneuvers, various maneuvers, what you can do to improve your results.
Satish, you yourself discussed chances of stenosis, chances of sinusitis, chances of refailures of leaks. Instead of all this, and of course the time consumption, instead of doing all this, I'm talking of specifically only frontal sinus. Is it equally effective and good to do an external approach or do a craniotomy and lay a flap? It sounds very reasonable.
See, I told you the reasons for not doing already. the time and the reluctance to do so much of drilling. Believe me, see that draft now?
Yes,
a little bit of the bone is still need to be removed. See that the bone which is coming projecting anteriorly.
Yeah, entirely.
See this? And then it will be wide enough. Then of it. I tell you, Narayan, suppose this patient, imagine as a leak from the posterior table, okay?
Yeah.
What you need to do is this much of draft to the exposure. Suppose he has a leak from here where my burr is. See this? Now with this exposure, what all you need to do is just coagulate the area, put your fat plug, put fascia glue and come out with little pressure over it. The only thing required is that, is exposure. And once it goes endoscopic, it has its own advantage, boss. See, in the frontal sinus, I told you the lateral, the open approaches have their place, no doubt about it. But if you can avoid it, it is always better. Now, what rescue procedures you can do? Now, one by one, I tell you. Even for the beginners.
Satish, let's ask Prepa what he would also do. Let's have some controversy.
I think it doesn't really matter whether you do open or endoscopic, as long as the leak stops.
Yes.
If you're not comfortable with endoscope, do open by all means, no problem.
Absolutely.
So for the younger generation up there, the younger generations, you don't have to do endoscopic just because we do endoscopic. It took us a long time to reach where we are now. We didn't start doing frontal repairs endoscopically ourselves. We started by open surgery, then slowly as we evolved, we came to this level. So if you're not comfortable to do it endoscopically, please by all means do open. As far as the patient is concerned, he doesn't care whether it's endoscopic or open, as long as you can stop the leak. There's no point doing endoscopic if you're not going to stop the leak.
Okay, Satish sir, what about combined approach?
Yeah, that's what I'm coming to. That's what I was waiting for, just to finish this side with this and see the 0-degree picture of the draft. To see the posterior table completely, the lateral aspect, and this is purely with a 0-degree. Okay? This is intersinus septum medially. Can you see?
Yes, sir.
Now, for the junior colleagues, if you have a leak and if you are not good at it, what you can do? Let me show you first the technique of trephination, which has many indications even in this era. Like Prabha said, somebody is not used to the endoscopic approaches. Let them do some open approaches. So what open approaches one can do? See, let me show you what trephination is, number one. This is an amazing thing to add on to your endoscopy sometime. First of all, trephination is what? You make an opening in the floor of the anterior wall of the frontal sinus. Okay? External opening. And what is the safe region? Safe region is, this is midline. See this? This is midline. Exactly 1 centimeter lateral to midline, not beyond that in the eyebrow. Why I'm saying not going beyond that? Because 16 millimeter here, and here is the supratrochlear nerve, and a further centimeter beyond is the supraorbital pedicle. Okay? So, the 1 centimeter from the midline in the eyebrow. This just small incision, This small incision, I carried away. Periosteum. You don't have to go too big. This small incision, and nowadays a trephination set is available from the Medtronic. That has a guard to protect you from going deeper. Anyway, you can do with your regular instruments. Give me a drill. Drill there, cutting. See now what I'm going to do? I'll use a cutting drill and make an opening, okay? And see what it makes a difference. Cutting देना यार सोचो मत देखो इसे भी give that one. So what I will do, I'll make an opening in the wall of the frontal sinus here and go from above. This is an additional avenue for your instrumentation, for your endoscope, for your suction. You can use any instrument from here. You can use the endoscope from below and instrument from here. You can use endoscope from here, instrument from below. If there is a CSF leak, it will be a child's play once you open from the trephine. If you have a eosinophilic sinusitis, very resistant. What you can use it for the irrigation, steroid irrigation for post-op, or you can put a, cannula and you can irrigate for a week or two continuously from there. Yes, now, find all. Find all. See what I have done. Yes, yes, so the, see, 0 degree then, no? Can you see my endoscope from above? Hello?
Yes, yes.
Now my endoscope from above in the frontal sinus. That is our Lothrops we have done. Can you see very clear all around?
So which degree endoscope is this?
This is 0. Now what I will show, I will take a 70 degree and use my instrument from above.
Okay.
This is 70 degree.
Yes.
And see your instrument from above.
Yes, yes.
Can you see?
Yes, clearly seen.
What an avenue. If you have to use if your CSF leak is here, you have a direct access to that region without any problem. In no time, you can easily see. This is not only for the CSF leak, for tumors. If you are dealing with a benign tumor on this region, suppose you have an inverted papilloma attached to some wall of the frontal sinus, and you are not able to access from below completely to visualize it to ensure complete removal, what you can do? You can go from above and put your endoscope from there. See my endoscope through this opening. Now I can rotate 360 degree. See this?
Yes, sir.
And I can see each and every nook and corner of the frontal sinus through this. 70 degree now. So the beauty is, with this access, very small, 1 centimeter, you see, for the period of time, you will not realize even the scar. There's hardly any scar it gives. Hardly any scar. In the eyebrow, that too. But it gives an amazing avenue to deal with so many pathologies in the frontal sinus as a second avenue for instrumentation and visualization. Now, this is another option for the CSF leak and tumors. I tell you, there are certain situations, even in the benign tumors, where you don't feel like giving a drainage, Lothrops, and you don't feel like giving an obliteration. You are in a fix. I'll give you an example. Recently, a papilloma case was operated 3-4 times earlier somewhere, had diffuse involvement of the frontal sinus walls. Obviously, it infiltrates the bone of the frontal sinus. So you have to drill away the bone thoroughly. Okay? And in order to drill away the bone thoroughly to remove from every part, you don't leave any mucosa ultimately. And if you leave such cavity for drainage, it is never going to heal. It will going to suppurate, it is going to infect, a lot of issues. At the same time, you cannot obliterate it because it's a bloody tumor. You cannot leave any tumor tissue. You cannot be 100% sure any time. And you can leave the tumor tissue buried. And that is, those are the most difficult situations what to do. So, in those situations, you can go by the open approach, you can do a trephination. You have to ensure that the tumor is completely removed from each and every nook and corner of the frontal sinus. So that you can obliterate. That is the only way.
Sir, Dr. Nageshwara was asking, is there anything called as hemilathrop or semilathrop?
Yes, that's what I'm coming to. Exactly, that's what I'm coming to. So this was about the draft 2. Now the next is, what are the applications of the extended draft procedures? What is the reason? Suppose I have a pathology here far laterally in the frontal sinus, suppose here, which is I am not able to access through my regular draft. Let me show you. See this? This is draft 2 on one side, okay? Draft 2B rather, I would say. I have reached up to the level of the nasal intersinus septum, you can see. Now, if I do the draft 2B on the other side, along with removal of the intersinus septum and the upper part of the nasal septum, it will be draft 3 or modified endoscopic Lothrops. Okay? Now, in such draft 2B, if I am not able to address the far lateral pathology, what all I can do? Number 1, let me remove these soft tissues to show you better. Just for the sake of demonstration. Section karna. This concept, everyone should have a very clear concept of this fact, how you can improve. So suppose the lateral access is not possible with this, even this approach. So what you can add on, you do a septotomy on the opposite side. Do a septotomy. Give me the collator. I will do a septotomy. See this. Rather than coming from the same side, because you cannot go far laterally from the same side. What I will do, I am making a septal window. See this. See the septal window? Quickly,
Yes,
just for sake of demonstration here. Now I am coming from this side. Can you see? Hello?
Yes, yes, sir. Clearly see.
Now coming from the opposite side, I can reach far lateral. See this, now my angulation is different with the 70 degree coming from opposite side, and I have a reach far beyond divider. I have a reach far laterally now on that side. Got my point? So this addition of a septotomy to a draft 2B is considered or named as modified hemilothrops.
Okay, sir.
Okay? This is one modification. Let me show you further. Yes. Let me clear this to show you. So this now, I am coming from the opposite side. See the septal window? And
So
going far laterally to the opposite side there. This is modified hemilothrops. Okay?
Sir,
Now,
where exactly have you made this window, sir?
this window is made in the behind the septal cartilage superiorly, and my posterior limit is generally the middle turbinate.
Okay.
Superiorly you can extend as much as required according to the need. Okay? So addition of this window to go far laterally coming from the opposite side, this is known as modified hemilothrops. Okay? Now, in addition to it, if I add on intersinus septotomy, see, we have addressed this side only. Okay? We have not addressed the opposite frontal recess. Okay? In some patient whom you have to address the far lateral pathology, at the same time the opposite side as well. What you can add on? The intersinus. Because my angle bar is not there today. Now see what I am doing here. I am opening the intersinus septum. Can you see?
Yes, sir.
This intersinus septum I am opening without addressing the opposite side frontal recess. See this? So this will drain the opposite frontal sinus also from here. 60 dena. What my point?
Yes, sir.
This is along with this septotomy, and intersinus septal removal, this is known as modified subtotal Lothrops.
Okay, sir.
Now I will give you another variation, very, very interesting. Chala na. Yes. See now, I have opened this intersinus septum. Is that clear to everyone? Hello?
Yes. Yes,
This
sir,
is
yes.
modified subtotal Lothrops with a septotomy and intersinus septum removal to drain the opposite side. Now the next situation is for an indication, particular indication. Suppose, and that comes, we have got cases, somebody has operated on one side 0 degree. Somebody has operated one side and a lot of neoestrogenesis happened because of the removal of the mucosa. And at that time during previous surgery, the orbit was also entered and some fat prolapse was there. The orbital wall was injured. Now, difficulties. First of all, going back to that stenosis sinus is very difficult. Okay?
Yes,
that too, when the orbital plate was injured earlier and the fat was prolapsing earlier, that made a lot of fibrosis there. So going back to the same side is very, very difficult now. You can understand. So what you can do now, the best is, and the procedure what we do for that, what we call it as a modified mini Lothrops. What is that? You don't go to the same side at all, because that part is already ruined because of the previous surgery and adhesions and the orbital injury or whatever. Go to the opposite side, normal side, absolutely normal side. Do a draft 2B on normal side and remove the intersinus septum and allow the same side sinus to drain to the opposite side. Got my point?
Yes, sir.
So normal side surgery with removal of the intersinus septum, not doing anything on the same side. The same side sinus will drain to the intersinus septum to the opposite side is known as modified mini Lothrops. This is where we are operating on the normal side, nothing doing on the same side because of the regions. Okay?
Yes, sir.
Now, the next situation is when you have a far lateral pathology in the frontal sinus. That is again a big problem. Earlier, what used to be considered was any pathology lateral to the lamina paprecia cannot be considered good for the endoscopy. You know? Now, with the advancement in the surgical technique, instrumentation, we can address any far lateral pathology with endoscopy. What we need to do is, we have to transpose the orbit. Now we have a good number of patients, series now, of orbital transposition. What does that mean? I will show you. See this. Couch suction, you know. Let me show you as a very simple procedure to be done properly. See this. I have done this draft too. This is 0 degree picture. And my pathology is far laterally here. Okay? Which I am not able to remove it, not able to address it, and not able to communicate it properly. So what I will do now, the obstacle is the orbit. Okay? I hope you are oriented.
Yes, sir.
The obstacle is this orbit. So what I will do this, I will transpose this orbit. What you can do that? See now what I am doing. I am breaking this lamina paprecia. Can you see?
Yes.
The most important thing is keep the periorbita intact. Only lamina paprecia, and that too posteriorly till the level of the anterior ethmoidal artery. This is amazing procedure. I have many videos I have put on the YouTube of this procedure. This is lovely. And anybody can do it. It's not that difficult at all. You have to break the lamina paprecia. See, these procedures are so seen and done well on the live surgery. When you have a bleeding, you have a cobblator, you have all those. See now what I am elevating the periorbita from the orbital side. Can you see?
Yes, sir.
If any doubt or if you're not oriented, let me know, please. Prapa.
Yes, sir.
Please, we need your comments. See now.
It's nice. It's a good approach.
See now what?
The only
I'm removing this bone.
Yeah.
The only thing we
worry is that.
Yeah.
The only thing is.
Pardon?
Sorry, the only thing is sometimes when you do this, the anterior admoidal artery gets stretched.
Yeah, don't
so
worry.
It's a very elastic structure.
I told you.
It doesn't rupture. That's what people worry about. But it's actually a very elastic
Even
structure.
if it ruptures, you have a solution, I tell you.
Yeah.
If such thing looks imminent, what you can do? First of all, I told you my posterior limit is anterior ethmoidal artery.
Yes, correct. Yeah.
In case you have to go beyond, take a bipolar and coagulate the vessel. That's it.
Exactly. Yeah. Yeah.
Forget
and
about
actually,
it.
you can push the orbit quite significantly.
See
and
now
the
how
artery
much
will
I have
just
pushed.
stretch.
See how much the access has improved. Can you see? How much the access has improved. I will keep pushing. The bottom line is this periorbital should remain intact. Now, in case this periorbita gets damaged, suppose what you can do, still you can do it. Because once it is injured, the fat will start prolapsing. See what I am doing? Elevating more and more. Can you see?
Yes, sir.
And I will remove this bone more and more. See more and more bone being removed?
Yes.
And more access of the sinus is improved. Can you see? Now,
yes.
Yep.
Let me do this. No, drill. Let me finish it. See, keep going laterally until you reach the far lateral. See, my far lateral access is improved like anything. Cobbleter.
Yep.
In life surgery, what we do, we make, as we keep going, we keep stiffening the periorbita. Stiffening means it should not fall back. So what we use? Cobbleter. See this. We keep stiffening like this. Can you see? Cobbleter is very safe. See this?
Yep.
As you keep going, keep stiffening the periorbita. Stiffening, simple stiffening by coagulation by means of cobbleter. If somewhere is the fat prolapse, use cobbleter to stiffen that area. It will not prolapse. See this?
Well, you can easily do a bipolar as well. Some of the fat you
Bipolar
can
is so difficult to reach, number one.
Right.
Cobbleter give minimal collateral trauma, thermal trauma because of the constant irrigation.
Is cobbleter widely available in India? It is.
Yes.
I know Prabha doesn't use a cobbleter.
I don't have one yet. I should buy one.
See, my drill is coming from the opposite side. Can you see?
Yes.
So the take-home message is usually anything that is medial to the midline of the orbit, you can do endoscopically. Once it's lateral to the midline of the orbit, then it can be a little bit more tricky. It might be easier just to do a simple eyebrow incision. The amount of morbidity is much less. See, like these approaches are fantastic because it's being done by a very experienced surgeon. But in the hands of someone who's just starting off endoscopic sinus surgery, you will have significant morbidity as well. So do it gradually. Don't straight away start doing this for your first few frontal surgeries. Not sure, do the eyebrow incision with the endoscope. Slowly work your way to this. Satish, you agree?
Yes, agreed. See, it's always a learning curve for everything. But at least you know the subject, you start doing, then only you will be able to do it.
At least you know this can be done.
How much laterally I have gone now? How much laterally?
Yes.
And I can go further. I can keep going to the pterion. I have gone to the pterion several times with this approach. Far laterally above the orbit. Keep stiffening the periorbita, keep drilling the frontal bone, and go to the far lateral extent and come with your drill from the opposite side through the septal opening. See, I am far lateral in the frontal sinus. See, where is the midline?
I know what Narayanan is thinking. He's thinking, isn't it so much easier just to do osteoplastic flap? Correct, Narayan?
No. It's not. No. I'm not thinking of that. It's nice to see all these approaches, but when we are talking, you're talking to a lot of people who are not as good as to do draft procedures. Now the flip side is, yes, you need to get used to it. But for CSF, for tumors, 100%, do all of this, no problem. For CSF, I think it's an overkill because again, I have seen people just dumping fat in that area, and that leads to a lot of problems of sinusitis, mucocele formation. It can lead to stenosis of the frontal and again new bone formation and so a lot of complications you see. So that is the only reason I said for CSFs, I don't think this is a good procedure. But for tumors, I agree with what is being done.
I would agree with Narayan that most of the neurosurgeons prefer to do the open approach for the CSF from frontal side.
See, that is individual. I told you the variation, their expertise, and the time, and so many things. Equipment, time, cost, everything matters.
Satish sir, what is your indication while for doing these steps? When will you approach? When will you, for which surgeries will you do this approach?
This orbital transposition for all far laterally extending pathologies.
Tumors.
I have done so many times, not only tumors, even for the mucoceles I have done several times, far laterally expanding, which are not communicated to the frontal sinus. Revision frontals, wherein the loculations are formed far laterally, which are not communicated to the sinus proper. And this is something, you keep going laterally. This is orbital transposition. So, to summarize the frontal, number one, draft 1 is what we do in a regular one, when we address the... Yeah. Hello? Hello?
Yes.
Draft 1 is when we do the regular sinus surgery with going to the ostium. Draft 2A is what I did, had I done not till midline up to the turbinate. 2B is the same thing, removal of the floor and anterior wall up to the midline. Okay? And draft 3 or the modified Lothrops is when you do this draft 2B on both sides, along with removal of the intersinus septum and upper part of the nasal septum. Okay? Now, this is about draft procedures. Decision making for small frontal sinuses, if you are struggling, not able to give good patency, you can do obliteration because that will not bother much. And it is easier to do obliteration as you don't have a big sinus to remove a big mucosa. For a larger sinus, do everything possible to give drainage because obliteration will be very, very difficult to remove mucosa from each and every nook and corner of the frontal sinus. Tumors, the prime thing is removal of the tumor is the first priority. And for that, access is the most important thing. Tumors, mostly you need draft procedure because you need to ensure that the tumor is completely removed, and many a times you have to remove the underlying bone of the tumor where it is attached to. And for that reason, there are a variety of modifications of the drafts available now. To draft 2B, if you want to go laterally and do a septotomy and come from the opposite side with an angle, that is hemilothrops. To that, if you add on intersinus septum removal is modified subtotal lothrops. If you do on the opposite normal sign in a previously stenosed sinus and go to the normal sign and remove the intersinus septum is mini lothrops. Sometimes is a procedure known as modified central lothrops when you work in the center only without going to the periphery for CSF leaks or other region tumors. So all these are the procedures required. For CSF leaks and for tumors or anything, if you are not used to instrumentation far laterally here and there, you can use the help of the trephination. Not only CSF leak, for pathology, inflammatory, non-inflammatory, whatever. Because it gives an additional avenue for the instrumentation, visualization, whatever. You can use endoscope, you can use instrument from there. Or you can use irrigation from there. For far laterally existing pathologies, if you are not able to access, then orbital transposition is the best answer. And there is no limit now in the frontal sinus. Every possible frontal sinus pathology, in my opinion, can be best addressed endoscopically. I agree with Narayan. The learning curve, the expertise, the time, the equipments, so many things which matters in decision making, and it is a learning curve for everyone, for us also, for everyone. If you are not good at it, you can take the help of trephination or you can do open approach. Now, once it comes to open approach, the osteoplastic flap is the best one. And we will show now. That is the simplest way you can do. You remove the anterior wall of the frontal sinus and remove all mucosa and obliterate with the fat. That's it, after blocking the frontonasal duct. Now, in the most extreme situation of the frontal sinus pathologies, the multiple revisions where the mucosa has gone bad, the underlying bone has gone bad, and it is really difficult to give a durable answer. Durable answer means whatever you do, it works for some time, it doesn't work for long because of the underlying pathology. Then are the procedures which are known as elimination procedures, where you have to eliminate frontal sinus, that's it. Elimination can be done according to the pathology. If the posterior wall is destroyed, cranialization. Remove the posterior wall and allow the brain to expand anteriorly after removal of the sinus mucosa, after drilling everything. The anterior wall is deficient, facialization and then reconstruction with bone cement. So these are the number of options one can use in frontal sinus. So this is almost more than almost 10 to 15 variety of procedures one can use. The thing is when to use what. Second is technology, because many a times or almost always it requires endoscopic entire system of instruments, cobblator, debrider, high-speed drill, navigation system and so on. So cost is a big factor in these surgeries, I tell you. Learning curve is a big factor. If you, like Prabhakaran was saying, if such a CSF leak you want to address, open and do it in half an hour, you can come out. But again, there is no control over the management post-operatively. If it is coming, what to do, the revisions are difficult. There are so many angles to it. So endoscopy, the best answer, the best reason for the endoscopy is surveillance. That is the additional value of the endoscopy. Whatever you do with endoscopy, you have a possibility, all the time opportunity for the surveillance to that region by means of endoscope, which otherwise not with a closed procedure or open procedures. Secondly, the use of vascularized flaps, which we have already discussed in the nose and hand. In the frontal sinus also, like in the obliteration, we'll show you the pericranial flap, how one can use the pericranial flap. So until now, before we move further, we have a lot of things to do. Any questions?
So what is the lateral limit for the orbital transposition that you were showing? So
Sandeep. What is the?
Lateral limit for the orbital transposition? That
No limit, up to pterion. You can go up to pterion. All the way above the orbit, you can keep on going far laterally. Nose to the septotomy. Keep pushing the periorbita. Keep stiffening the periorbita with the cobblator and you can go on and go on.
Okay. So there's a question from Cambodia. How to minimize the bone exposure while maximizing the frontal sinus area created with draft 2 and 3 procedure?
See, I have already mentioned, the bone exposure is a big problem, like Professor Prabhakaran mentioned. If you leave too much of raw area, that will invite a lot of bone reaction. Osteitis, neo-osteogenesis, and it may even stenose if not taken care of. So to control that, number one, if you have done a lot of raw areas, you have to irrigate thoroughly with the steroid solution, antibiotic solution in the post-op. Thorough, judicious irrigations. Number two, best is to cover the raw areas. Like the flaps you have raised. See the inverted U incision I made and brought behind till the first olfactory neuron. That same flap can be used to line the floor of the frontal sinus. So all raw areas you can cover with the vascularized flap. We have already discussed even the nasoseptal flap. So many flaps you can use to cover the raw areas in the frontal, and you can use free mucosal grafts in the frontal. Professor Eldostam, welcome. So nice to see you. Thank you. Were you going through the discussion?
And everyone.
Hello, sir.
Yeah, good evening, sir.
Hi, Aldo. Good to see you.
No, yes, here. Nice to see you.
Same here, sir. Thank you so much.
Yeah.
So,
Here in Brazil,
were you going through the discussion we were having?
yes, now in Brazil it's 7 a.m. It's very early here. And I wake up very early today. But I was seeing your dissection, Satish. It is really great. This medial orbital decompression is very impressive. You can go to remove tumors over the orbit in the great majority of the times. The only thing that you do here is to coagulate the anterior and posterior thyroid arteries very early in order to devascularize the tumor and have more space to displace the medial orbital wall and to avoid any damage of the anterior or posterior thyroid artery. So this is the only difference. But I agree completely with you. It's great, this section. I like very much this kind of technique. Thank you so much.
Peppa, any comments?
I think it's excellent. It's just that for the younger generation, you need to go slow. Pick your cases carefully. Don't do what Satish does as your first case. Get there eventually. But what is great is Satish has done it beautifully, clearly, and made it very easy. A walking textbook. Satish Jain.
So, now,
Very simple.
first of all, to Professor Aldo Stem, what I have done until now to quickly apprise you. Okay? So, sir, first of all, on this opposite side, I showed a complete endoscopic sinus surgery on this side. All steps in detail, okay? Then I showed the orbital decompression and the optic nerve decompression on this side. Okay? Then on this side, I showed them the pre-lacrimal approach, not the dankers. I'm covering this flap back. And another rescue approach is through the sublabial area to introduce your debrider from here in the maxillary sinus, for the maxillary sinus. Then to the opposite side, then after that we raised, I showed them all the flaps in the nose. Hadad flap, modification of the Hadad flaps, lateral wall flap, inferior turbinate flap, double pedicle flap, the palatal flap, all those flaps. Then we did a sinus surgery on this side and did a draft 2 on this side. This is 0-degree picture. Draft 2 and various modification of the Lothrops, like hemilothrops, modified subtotal Lothrops, mini Lothrops. Then concept of cranialization of the frontal sinus, Riedel's procedure, facialization, and finally the orbital transposition to go far laterally in the frontal sinus. This is what we have done so far. Okay? Hello, sir.
Got it. Yes.
Professor Aldo Stem, can you hear me?
Yes, I can. Thank you.
Okay. So now we move on to the advanced thing now. And that is, before moving to the skull base approaches, I will show you one of the most important corridor to the skull base, which every day we are using in a practice for some or other indication. See, what I am using is a 0-degree in the nose, and everything is in front of you. In skull base also, whatever approach you are using, it should be done with a 0-degree. Even if you are using the paramedian approach, it should be done with a 0-degree to prevent disorientation. So, for the paramedian axis, we have the best approach which opens the gateway to the paramedian skull base in no time is the modified dankers or Stunman Canfield approach. So what do we do in the modified dankers? What you have to do is, let me show you on this side, because other side we have ruined by the pre-lacrimal. Yes. So what you do in the modified dankers, like we did in the live surgery that day, you have to remove the part of the anterolateral wall and the medial wall of the maxilla to enter into the maxillary sinus head-on. Head-on means with a 0-degree. Because you have to go with a 0-degree endoscope, and that gives you unparalleled access to the every part of the paramedian skull base and that too so fast in no time. So let me show you.
Sir, here, while you're doing this Denker's initially procedures, can you tell us which instruments are you using? Many wanted to know which instruments are you using for this.
All these instruments I use are from Karl stores. Number one, like this is, see this is the favorite instrument I am using again and again. It's the Cottle's elevator from Karl stores. Amazing tool. See this?
Yes.
What an angulation. It can be used in an elevator, sometimes can be used as a sharp instrument also. 40 then, not divided. So for the Denkers, what I need to go, see this is the anterior wall of the maxillary sinus and this is the medial wall. And to enter inside the maxillary sinus, I need to remove this wall, like you saw in the live surgery that day, when I was doing a inverted papilloma. And you'll be seeing on Thursday also. Thursday we have angiofibroma. Kya hua? Yeah. Come on. Virender, on the micro debrider mode. Please.
Sir, there is a question. What is the secret of your energy?
Pardon?
What is the secret of your energy?
Sanjay Khanna is asking
your blessings. Your love, affection and blessings. See now, this medial wall is completely exposed.
Yeah.
And so is the anterior lateral wall. See, this procedure is shown so well on in the live surgical situation than on the cadaver.
Yeah.
Because you struggle with the instruments in the cadaver and you have to go fast. We have unlimited things to show and time is running out. So now, that day I discussed one thing here. Since we sacrifice the nasolacrimal duct, we have to ensure that the patient doesn't develop epiphora in the post-op period. And the best way is, sir pakadna. See, this is the anterior bone I am removing with the punch. And to prevent epiphora, the short way is to cut flush the duct right at the level of the orbital floor. That way you can prevent epiphora. If your duct is overhanging, see the nerve fibers on the anterior wall. Can you see this?
Yeah.
These are anterior superior alveolar nerve branches. See this?
Okay.
Now you can remove this anterolateral wall as much as your pathology dictates. Like in angiofibroma, sometimes we get cases where the tumor is going out of the zygoma in the cheek, far laterally, and you literally have to remove a lot of part of the anterolateral wall up till posterolateral wall. So it depends. And the biggest obstacle until now was this infraorbital nerve. This is my limit. The infraorbital nerve is usually the limit of the Denkers. Now how you can overcome now? I'll tell you, I'll show you. And we do several times. Now this is no more a limit, you can say.
Yeah.
This infraorbital nerve can be transposed now. And this procedure was described by Paul Casanova again. I will show you. See this anterolateral wall completely. Can you see the nerve now?
Yeah, very clearly.
Now, if you have to remove the bone beyond that, what you need to do is, I will show you how you can transpose this nerve further and you can go on and remove the entire wall. This is infraorbital neurovascular bundle. And by and large for the Denker, this has been considered to be the limit. Okay?
Yeah.
So now, what we'll do, remove this flap. It will come again and again. Let me remove this flap. We have already seen this. It should not come in the way. This is the maxillary sinus for your reference.
Yeah.
And we can see the floor of the orbit level here. So first of all, to avoid epiphora, you have to define the level of the floor of the orbit. And then we will cut the nasolacrimal duct sharp. Now, give me the retractor. Drill. I'm sorry, today I don't have my regular drill. Using the other one. Fast. So I will make an entry into the anterior wall of the sinus to show you the reference of the limits. This is just for the sake of demonstration. Otherwise, I can remove it with the chisel and hammer simply in no time. देख स्पीड देख What happened? Paramita, keep collecting questions.
Yes, sir.
Actually, people are still asking about this Casanova flap for the septal perforation. We have to keep on both the sides flap, or one side flap is enough?
One side is good enough because one side you have a vascularized flap. It can work if you make the perforation raw well.
Yeah.
So it is not very clear to many people still about closure of the septal perforation. Many are asking the same question again and again. Maybe
there are so many queries about it.
Okay, what I'll do, we have other cadaver.
Yeah.
I'll create a perforation in the septum and I'll show a big perforation and I'll close with the open rhinoplasty approach. Okay?
Yeah,
Later.
that's wonderful.
So that will clear the cutting there. Fast. I'm waiting for the drill. Quickly.
The chisel. What is disadvantage of using chisel hammer over here?
Nothing. Give me chisel hammer. Okay, let me show. Just I wanted to show the anatomy, the reference level. Just for the reference that you should not go too superiorly to damage the orbit. You know the roof? The direct relation in the roof is the orbit. And we are not supposed to go See the entry into the maxillary sinus?
Yeah, very clear.
That is the entry into the maxillary sinus. कुछ नहीं कर रहे यार. Not working, man.
So what is the best way to cut the nasolacrimal duct? Means, should be?
I will show you with a sharp scissor. Not working.
So you're trying now the medial maxillectomy, correct, Satish?
Dankers.
Yeah, you'll extend it to Dankers, but first you're trying to demonstrate medial maxillectomy?
No. What I'm trying to demonstrate here is, what is my level? See from the inside. Just this level I want to show, otherwise I would have finished by now.
Yeah.
See, Narayan. Can you see the level of the roof?
Yes. The floor
Can you see the interior of the maxillary sinus from here?
Yes.
Now my point is, it should be at the level of the roof of the maxillary sinus. Now, let me finish it with the chisel and the hammer. Fastest.
So that's where you will cut your. That's where you'll cut your lacrimal. Endolayer.
Yeah, I will show you. I will show you lacrimal once I reach there.
So you want to cut it flush with that wall, right?
Yes. टूट गया. Mobilize. Anyway. पकड़ सिर. completely mobilized. I am removing this bone completely.
Yeah.
So it doesn't come in the way. That's why a good drill is required. And somehow the drill has gone. निकालना यार इसको.
So for the anti-thyroidal artery ligation, sorry, Ms. Kotra, you have a specific bipolar or normal bipolar is enough? For anti-thyroidal artery ligation,
ideal is endoscopic bipolar.
Endoscopic.
Endoscopic bipolar is ideal.
Okay.
If you have seen the PJ Wormhole bipolar,
Yeah.
that is endoscopic suction bipolar. That is always good. That it keeps on sucking the fume as well. Okay?
Yeah. Sanjay Khanna is asking so many questions. Sanjay Khanna, our.
See, the entire bone has gone. Debrider. Give me debrider.
Can we use modified Denker's approach for recurrent AC polyps?
Not really. That is too much for the AC polyp. What all you can do, we discussed that day in surgery, if your AC polyp is coming back again and again, you know.
So, Prepa, apart from angiofibromas, what are your more common indications in your practice for this approach?
For Meckel's cave, for
this approach, what are the other?
You mean for Dankers?
Yeah.
For the middle cranial fossa, this is the fastest route to the middle cranial fossa. Anyway, this bone, too much of the bone piece came together, Narayan.
Yeah, I saw that.
Yeah, because I didn't have a drill. This is the nasolacrimal duct. See this? And what you have to do is keeping this bone intact. Pakadna. Generally, what you have to do is, because the bone is gone, I'm really sorry. And you remember the live surgery day I demonstrated?
I saw that quite clearly in the
I
live.
will show on Thursday because this drill was not there. So I'm struggling without drill. You cut like this sharp.
Okay.
At the level of the orbital floor. Okay? And now this is the interior of the maxillary sinus.
It should be cut straight or should be oblique cut?
Straight, flush.
Okay.
Absolutely flush and flush to the level of the orbital floor.
So, Prepa, what are the lesions you use this approach for?
I will use modified Dankers for infratemporal fossa. So whatever that is lateral to the infraorbital nerve, like schwannomas of V3, whatever lesions or even malignancies that go into the infratemporal fossa, whatever is lateral to the infraorbital nerve, I'll use the Dankers. The same thing as angiofibroma. So it's not so much as the lesion, it's the anatomy of the lesion itself. Whatever's lateral to the infraorbital nerve. Whatever's middle to the infraorbital nerve, you can reach quite easily by doing a large maxillary opening or by doing a middle maxillectomy.
What care would you take to prevent the cosmetic deformity when we are doing a modified Dankers?
The problem is always the collapse of the alar cartilage. So the most important thing is that when you raise the flap from the anterior wall of the maxilla itself, or from the cheek itself, you must be in the subperiosteal plane. So your dissection, you cut straight at the right at the anterior to the anterior wall of anterior infraturbinate. It might be flush to the bone, and then when you elevate the mucosa or the skin with the subcutaneous tissue from the anterior wall of the maxilla, it must be on the subperiosteal plane. You must dissect it completely and expose the bare maxillary bone. Otherwise, the retraction and the fibrosis in the scar tissue in the subcutaneous space itself will cause the alar cartilage to get pushed in. Then you will have slight deformity and stenosis of the alar cartilage. Especially if you remove as much bone as what Satish is doing now.
But
the subperiosteum is the one that will hold the entire anterior wall of the cheek in place.
Telescope अच्छा नहीं है क्या?
Nothing is wrong with telescope.
Alteration in the growth.
Clean it.
For these children.
Clean करना इसको करना कुछ. Narayan.
That's what the objection some people have as regards that for an angiofibroma, which is.
Pardon?
So some people have this objection to doing the modified Dankers because of the cosmetic deformity that it can cause for
Samir, I tell you, a properly done modified dankers doesn't leave any cosmetic deformity. And we have series of n number of cases. The only thing you have to be careful is avoid injury to the ala of the nose, lower ala. If ala is injured, then obviously you have to supplement. Otherwise, it doesn't leave any morbidity at all. In times to come, it heals so fast, the mucosalization is so fast because you flush with the floor of the nose. And the way you cut the nasolacrimal flush with the orbital floor, you don't give morbidity of that epiphora also. And it gives you the immense, benefit of opportunity of surveillance in the future by 0-degree telescope is amazing. You don't need radiology. You don't need radiology at all.
And the easiest way to make sure that you don't injure any ala cartilage or subcutaneous tissue is make sure you are subperiosteal. Then you will not have cosmetic deformity.
More than cosmetic, does it affect the facial growth?
Not really.
No,
this was again, and recently you go through the publication in the laryngoscope, they have completely denied it. It doesn't affect. So all these are, questions which automatically come to the mind. But it doesn't generally affect. So now, are you getting the picture?
Yeah, getting.
Yeah. So even in a few cases that we have done, we have not faced any cosmetic deformity. Of course, our numbers are much smaller than what you are talking about. But yeah, we've not faced that issue.
Yeah, it doesn't give actually. See now.
Actually, sir, we have faced some couple of cosmetic deformities because I think I removed a lot of bone superiorly and we had some cosmetic deformities.
Okay. Now see what I'm trying to show. This was the infraorbital nerve from anterior side. Can you see?
Yeah, very good.
And here it is running in the roof. See this bone over it? And here it is running in the roof of the sinus towards the pterygopaltine fossa. This is the posterior wall of the maxilla, a very thin bone. If it is thin, you can remove. See this? And this area behind is the pterygopalatine fossa. Now this pterygopalatine fossa is a very important anatomy for skull-based surgeon for that matter. It is like a crossroad. It is serving as a crossroad communicating several cavities from surroundings. And that becomes the source of spread of disease from this fossa to anywhere around. Like for example, angiofibromas invading. See, angiofibroma start here. This pterygopalatine fossa, behind is the pterygoid process on the face of the pterygoid bone here. And once they enter the pterygopalatine fossa, from this fossa they spread preferentially to the pterygomaxillary fissure into the infratemporal fossa. This pterygopalatine fossa is communicated about through the inferior orbital fissure to the orbit. This is communicated below through the greater palatine canal to the oral cavity. It is communicated to the nasal cavity through the sphenopalatine foramen. It is communicated behind through the Vedian canal to the foramen lacerum. It is communicated through the foramen rotundum behind to the middle canal fossa. So it is like a crossroad with a lot of connections all around with a lot of fissures, canals and foramens. And these canals and foramens are carrying a lot of neurovascular structures. So this is a very, very important anatomy to understand in skull-based surgery, because once you reach at this level, you can reach the middle fossa in no time. If I follow the foramen rotundum and just above that is the middle canal fossa. In 5 minutes I can reach the middle canal fossa from here if I want. So this is a most direct access, and what I am using is a 0-degree telescope, you can see. Not even an angle telescope. So in the pterygopalatine fossa, these structures are arranged in a special manner. The most anterior structures, this is the pterygopalatine fossa periosteum. Behind this periosteum is some fat tissue. The most anterior structure embedded in the pterygopalatine fossa are the vascular structure, and that is because of because of the internal maxillary artery and its course and its number of branches. So that network of internal maxillary constitutes the most anterior structure in the pterygopalatine fossa. It gives off number of vessels. Whatever foramen I have enumerated right now, it gives off a branch to pass through that foramen. Got my point?
Yes, yes.
Like for example, it gives a branch, greater palatine artery, to pass through the greater palatine foramen. It is here at the medial end. It gives a continuation is sphenopalatine, which passes into the nasal cavity through the sphenopalatine foramen. Then it has a infraorbital artery which goes along with this infraorbital V2, that is infraorbital foramen. Then it has a special branch behind posterior superior alveolar nerve. Then it is a branch behind which passes through the Vedian canal into the Vedian artery into the Vedian canal. Then close to Vedian canal, infromedially the palatovaginal canal, and it gives a pharyngeal artery to the palatovaginal canal. So every foramen is the one which is leading, and one of the branches leading to all these foramen from the pterygopalatine fossa. Behind this arterial network is the neural network. Neural network is composed of the V2 and its connection. So all these foramen, again they pass a nerve along, like infraorbital nerve, which is a continuation of V2, posterior superior alveolar nerve, greater palatine nerve, the pharyngeal nerve, Vedian nerve, all these nerves, zygomatic nerve from the V2, all these are passing through one or other foramen from outside. So this pterygopalatine fossa understanding is so important. Pani dena, and cold drink. So important to understand the surrounding areas, because there are a number of pathologies in this area which pass on to extend to the pterygopalatine fossa, and number of pathologies do pass through the pterygopalatine fossa to the other area. So radiology is important, then these connections are important, and then surgically you should be able to address those connections. So I will uncover this anatomy now.
Yes,
First of all, see this posterior wall of the is partly I have removed here, and partly still it is intact. How is the picture?
Yeah, it's okay. Just clean the lens only. That's okay.
Pardon?
Clean the lens, please. Lens.
Okay.
That's okay. Okay.
Okay. So now, let me show one by one all these connections and canals and how they are related to the skull base and other pathologies at the skull base. So this bone I have already told you that is perpendicular plate of the palatine bone.
Palatine bone.
And here it continues horizontally as a horizontal plate. Very important anatomy for skull base and to understand the pterygopalatine fossa. This bone, as it rises, it divides into two processes. See this one laterally and up going to the orbit. Can you see this?
Yeah.
This is orbital process.
Yeah.
See, this is orbital process, you can see. And the other one which goes behind, see that? That is the sphenoid process. See that? That is going behind.
Yeah.
This one is sphenoid process where my suction is. See that? And between these orbital and sphenoid process, above is the body of sphenoid, you can see behind. Converting into a foramen, that is sphenopalatine foramen. Can you see this vessel coming out of it?
Yes, beautiful.
See this vessel coming out of it? That is the sphenopalatine artery. See this soft tissue, I want to remove this flap.
Yeah, cut it out. Artery gone.
Yeah, because it is, we have already shown this. It is coming in the way again and again.
Hadad gone.
This was lateral nasal wall.
Yeah. Okay.
Will you also show us sphenopalatine ligation?
Yes.
You can see.
I am reaching direct there.
Yeah.
I have already shown you the artery.
Yes.
What is left in the ligation, just put a clip.
Okay.
Just put a clip. Scissors lagana. Bullous potato. Scissors. So what is left for the ligation is put a clip. Cut. Just a minute. Yes, I removed all these to get more space, okay? So this is your exit of the sphenopalatine artery from this foramen. Hope the picture is good there.
Yeah, good, very good.
So if you have a bleeding from the sphenopalatine, refractory bleeding, bothering hypertensive patients, just expose this artery here and put a clip. See this? Just put a titanium clip and it is done.
Yeah, yeah.
Now I am removing this orbital process. See this?
Yeah, yeah. Go on.
Can you see the vessel going down from it? In it. See this vessel going down.
Yeah, yeah. Yeah, yeah.
This vessel going down, this one. Vertically
yeah.
down. And this is greater palatine.
Yes.
In live surgery, I do this with a diamond drill. My favorite diamond drill. Here we have to save time as well. See this greater palatine artery now?
Yeah, yeah, yeah.
So clear. This is greater palatine artery and running in the greater palatine canal. Can you see? And behind this is lesser palatine artery running in a small canal, lesser palatine canal. You can see both together.
Yes.
Very clear. And this is the artery which is the basis of the greater palatine flap I have shown you earlier. Okay?
Yeah, yeah, yeah.
Now,
people are asking regarding the video neurectomy also, if possible.
Pardon?
Video neurectomy also.
Yes. I will show you. First I will show you video now. See, once you reach these structures, the neurectomy is what you have to do is cut the nerve. Important is how to reach, how to find out.
Yeah.
Method of finding out. Debrider. Now is the better exposure of the pterygopalatine fossa, and one by one I will show all the structure which I have just mentioned. I'll just remove this extra mucosa tissue which is coming in the way. Now, let me remove first the periosteum of the pterygopalatine fossa first. Can you see this?
Yeah.
And what you will find behind that is a layer of vessels. Can you see the main artery?
Yes, sir.
In angiofibroma, where this is the principal feeding vessel, you will find much, much bigger. See that?
Yes, sir.
Let me expose the artery properly. It is coming from here. It is very, very tortuous. See this main vessel?
Yeah, yeah, now we can see it. Very clear.
In angiofibromas, it is much bigger, and we use nowadays clips. Now.
Satish?
Yes, boss.
You must admit you got a fantastic cadaver, huh?
Yeah, yes.
This man died yesterday.
24 years old cadaver only.
Wrong time.
24 hours.
Oh my God.
This is a donated body, I told you.
Okay.
Narayan.
Yeah, yeah.
This is 116th donated body from our Jain community in Jaipur. 116.
So he expired yesterday, is it?
Yes. Now see this vessel. I am just removing some part of the flap, fat. Teasing out some fat so that I can show better. Okay? Now see, this is the sphenopalatine artery, you can see very clear. And this is giving here the branch which is going below. Can you see this?
Yeah.
This branch? What is that? That is the posterior superior alveolar artery. This one.
Yes, sir.
Let me confirm first.
Yeah.
And see this. This is giving here the greater palatine artery. This is continuing medially as the sphenopalatine artery. Number of branches. See that? Hello?
Yes. Very clear.
Number of branches it is giving rise to. Now, having seen this, let me show you behind that the neural structures behind that. And that will be the basis of, I'll show you why median nephrectomy, what is the basis of that.
If I'm not mistaken, this also happens to be Prepa's favorite area, isn't it, Prepa?
Really?
Yeah.
Drill then. Give me a drill to show the infraorbital nerve, the V2 and its course, so that you will be fully oriented all the time.
So you do endoscopic maxillectomy also for CA maxilla, like stage 2, 3,
yes,
T2,
yes,
T3?
Yes, very common.
What is the comparison between open approach and endoscopic approach?
Depending upon the extension. See, if it is going to the orbit, obviously I will go with the open approach.
Yeah.
If it is going to the infratemporal fossa and all that, open. If it is limited to the maxilla, not invading beyond the confines of it, yes, endoscopic. That is the indication. Now, behind this vessel, can you see the nerve?
Yeah, very thick.
It is the same continuation of this nerve. See this anteriorly, what we saw, infraorbital.
Yeah, very clear.
This is V2, which is continuing here anteriorly as the infraorbital. Can you see this?
Yeah. Wonderful,
and this now, if we follow, is debrider. Now I will remove these vessels here. The vessels I have nothing to do with now. Because in the neural plane behind, I will show you the foramens which are behind. Okay? And once you do the median neurectomy or any of these things, many a time you have to sacrifice this sphenopalatine artery. See this? I am removing these contents of the pterygopalatine fossa to go behind, because I am going towards the posterior wall. See this? Section. See the bleeding.
Live. Looks like a live case.
So in live surgery, what instrument do you use to dissect off this fat and take it off?
Cobblator.
Prepa, you?
Sickle knife and a bipolar.
Prepa uses a lot of bipolar.
I don't have a cobblator yet.
He has not yet become the cobblator fan.
No, not sure.
Section there.
Oh my God, such a fast blood.
See, this is the collected blood in the pterygoid venous plexus.
Yeah.
Mop. Or wash karna fir. Now I will follow this nerve behind to show you the entire neural network. Neural network means this is coming from laterally up as a V2. Medial to that is the median now, and medial to median is the palatovaginal canal through which the pharyngeal nerve is passing. Okay?
Yes, sir.
Now, see, this is the nerve. This is V2.
Yes.
And on this is this ganglion which is suspended. Can you see this circular structure?
Yeah.
This is pterygopalatine ganglion. All the ganglions in the head and neck are suspended on the branches of, on branches of maxillary nerves. Cannot be anywhere else. But those are suspended, morphologically related, not functionally.
Yes.
You know what I mean to say?
Yes.
For example, this ganglion on which the pterygopalatine ganglion is suspended, this is suspended on which branch? V2. V2 is a branch of trigeminal. So this is suspended on this nerve, but the function of this nerve is not serving. This ganglion is not serving the function of this nerve. This is my Vedian canal. I am going to show you soon. Here is the Vedian canal, and here is the pharyngeal canal. Just in a minute. So what I am trying to show, this ganglion is suspended on V2. That is a branch of trigeminal. This ganglion, this one. Okay? But it is not serving the function of trigeminal. It is morphologically related. What does it mean? So what function it is serving of? Which cranial nerve? 7th cranial nerve. Got my point?
Yes.
How come? The 7th cranial nerve gives a branch. It gives off a branch, greater superficial petrosal nerve.
JSPN, yeah.
That comes along the carotid artery, horizontal petrous above that, and at the foramen lacerum joins the deep petrosal to form Vedian.
Yes.
That Vedian joins this ganglion. That GSPN contains the postganglionic fibers for the salivary stimulation.
Yes.
For the stimulation of, the nasal and palatine glands.
Yes.
Yeah.
So, that's why Vedian neurectomy is the answer sometime for that rhinitis because of the stimulation. Vasomotor rhinitis and all that. So, but this ganglion is serving the function of 7th cranial nerve, but it is related to the 5th cranial nerve. That is what I am trying to say.
Yeah.
Now, the 2 cranial nerves, see one by one. Give me the knife. First, see the foramen rotundum. Infero-medial to that, Carrison punch. No, sickle. Infero-medial to that is the foramen Vedian, and infero-medial to that is the foramen palatovaginal. Now, let me show you one by one. This is Vedian. This is Vedian. My B2 is here and the palatovaginal is here. Let me clear that area and show you. I have seen. Just wanted to show you. Okay. Give me, remove this, something to remove this chunk of bone here. It is coming in the way. Yes. Can you see this V2?
Yeah,
see this
clearly.
V2? V2?
Yeah.
Where it is going to? See this. Or where it is coming from, I would say.
Yes, sir.
Entering the foramen rotundum. I will show you the proper foramen divider, so that you will never forget in life. Just removing all these tissues to show you the foramen quickly. Yes. See the V2? Prepagaran?
Yes.
See the V2 going up?
Rotundum. Yep. That's
and
foramen rotundum
that is the foramen rotundum. Can you see very clear?
Beautiful.
Very nice.
See the nerve is going into this foramen.
Yeah.
This is foramen rotundum. I will circumferentially cut the tissue around the foramen to show you the exact foramen. See, this is foramen where the nerve is going.
Yes.
Knife, yes. I've cut the connection of the median to the ganglion. And this is the nerve. Give me
yes,
the...
nicely said.
No, debrider. Let me clear it. Now, so I've completely gone around it to show this is the nerve. Can you see the foramen?
Yes, very nice, very clear.
This is the nerve going into the foramen, that is foramen rotundum. This is the pterygoid bone into which this nerve is passing into. See this? This foramen is passing to the pterygoid. This is pterygoid process.
Yes.
Okay?
Yes,
and this is the nerve which is going into this. I hope it is very clear.
Yes, it's very clear.
Now, infero-medial to it. See this, infero-medial to it. This is another very important foramen for us. This is Vidian canal. See this?
Yes, sir.
All the way. It is funnel shaped. I'll show you. See this?
Yes.
Complete canal. Show from all around. Can you see the Vidian canal now?
Yes, very clearly seen.
This is Vidian canal. So clear.
Very good.
Yeah, wonderful.
See, laterally is the foramen rotundum in the pterygopalatine fossa. We are in the pterygopalatine fossa.
Yes, sir.
After seeing the vessels, now we are seeing the nerves.
Yes,
so
sir.
this is V2, this is Vidian canal. And medial to that, can you see another nerve, this one? Which one? See, underneath a very thin bone. See this bone? See this now where it is going. See this now going medially. Can you see it or not clearly?
Yes,
we can see.
It's clear, yes.
This is Vidian canal and see this nerve going separately, quite superficial. This is the palatine bone sphenoid process. See this?
Yeah.
And this is covered by this bone. This is the bone from the sphenoid. Some people call it palatosphenoidal canal, and some people call it, because below it is covered by the vaginal process of the medial pterygoid plate of the sphenoid. So call it as a palatovaginal canal. This one.
Yes, sir.
So this is palatovaginal canal through which this nerve is passing. I am cutting off this, separating from the Vidian to show you separately.
So while doing Vidian neurectomy, we should take care of this part, because we should not cut this nerve.
This nerve is not to be cut in Vidian neurectomy. Yeah. This is the superficial one, palatovaginal canal, and this is the Vidian neurectomy. Now, what is the change over the period of time from Vidian neurectomy to posterior nasal neurectomy? We don't do Vidian neurectomy anymore, but yes, we combine our sinus surgery in allergic patient with a posterior nasal neurectomy. What is that? See this. This Vidian now, I told you, it carries the postganglionic fibers from the facial for the nasal and palatine glands. See this now.
Yes.
And this, after joining the pterygopalatine ganglion, this gives rise to posterior nasal nerves, which pass through, I showed you, through the this bone. See these nerves, small filaments. See this?
Yeah, filament. Yes.
Like this. They pass to this mucosa above the inferior turbinate. Okay? So that is how the posterior nasal nerves are supplying the inferior turbinate and the nasopalatine glands. Secondly, this Vidian now carries the secretomotor fibers to the lacrimal gland as well. Okay? Which this Vidian now relays in the pterygopalatine ganglion, and from the ganglion a separate branch emerges. Separate branch emerges laterally, that is zygomatic nerve.
Yes.
I'm trying to show you that it goes like this above. Zygomatic nerve, which goes to the lacrimal gland.
Yes,
okay?
yes.
So if you cut the median nerve, proper median nerve, what can happen? If you cut the median nerve, it will take away not only nasopalatine but the lacrimal fibers also. And that can give rise to dry eye. But if you selectively cut the posterior nasal fibers rather than median nerve, you can surely prevent a dry eye. That is the difference in the median neurectomy and posterior nasal neurectomy.
So then where exactly is the site of the cut to prevent the dry eye?
Just anterior to the spinopelvic fossa.
Try to understand again. Who can? Cold drink. Biscuit, isn't it? Biscuit. So, what I was trying to say, the median nerve carries the postganglionic fibers to the nasopalatine glands as well as the lacrimal gland. Clear?
Yeah.
In the pterygopalatine ganglion, all these fibers are relayed. From there, the nasopalatine gland fibers are relayed through the posterior nasal nerve into the nose.
Yes, sir.
And the lacrimal fibers are relayed through the zygomatic nerve to the lacrimal gland.
No.
Now, if you cut the median nerve as a whole, you take away not only nasopalatine but the lacrimal fibers unnecessarily, which you don't want.
Yes, sir.
Which can give rise to a dry eye.
Yes, sir.
Though it has a somehow connections. Buddha.
Satish, Dr. Kirtan here. May I say something here?
Yes, sir, please.
The zygomatic branch is a branch from the second division.
Yes.
The lacrimal branch is from the first division. So there is a very
No. Sir, I tell you.
No. Listen to what I'm saying. From the zygomatic branch, you will get a connection to the lacrimal nerve, which will go to the lacrimal gland. It's a very peculiar system where from the second division, you get a connection to the branch of the first division, and that goes to the lacrimal gland.
That's why many patients do not suffer dry eye. Now, what I'm trying to say, this zygomatic branch from the pterygopalatine ganglion, it actually carries the postganglionic fibers for the gland.
Yes.
That lacrimal branch, which is from the V1.
Yes.
That comes from the V1. It is a sensory nerve that doesn't contain postganglionic fibers. But
the zygomatic branch will give a branch from V2 to V1 branch, and then that goes to the zygomatic branch itself doesn't go to the lacrimal gland.
Yes, that's why the lacrimal branch of the V1 that supplies the sensory sensation, it doesn't contain postganglionic fibers. But it is presumed that many a times, in spite of the median nerve section, patients do not suffer dry eye. Because that lacrimal fibers from the V1 are supposed to contain some postganglionic fibers to the lacrimal gland as well.
Okay.
Is that clear?
Yes, sir.
Sir, for the sake of the juniors for attendance, can you really show again the palato-vaginal and median canal again? Because they're confused with the palato-vaginal and median canal.
Okay. Again, let me show you. See this, to orient you. This is the nasopharynx. Okay?
Yes.
This is the maxillary sinus which I opened. This is the pterygopalatine fossa I have opened. Okay? Point down. In the pterygopalatine fossa, laterally this nerve you can see ascending up to the foramen rotundum. This is V2. Can you see this now, V2?
Yeah, very clearly.
This is superolateral. There are 3 foramens in the pterygoid process. From superolateral, from superolateral to the inferomedial, in order there are 3 foramens one by one. Let me show you. The pterygoid plexus is oozing. Now, this superolateral is containing the V2. This is foramen rotundum. Okay? Inferomedial to that, there is a 5 to 7 mm difference. This is pterygoid bone process. This is median now. Okay? And inferomedial to that, this one, there is a very shallow foramen. Sometimes it is underneath a very thin bone going towards the nasopharynx, containing the pharyngeal nerve and the artery. This is palato-vaginal canal. Can you see?
Yes, sir.
Yeah, very clear, very clear.
Very clear? Now this median nerve is an amazing landmark for the carotid artery in the skull base surgery. If you ask me, for the carotid artery at different level, there are different landmarks at different level. The best landmark for the foramen lacerum carotid, the best landmark is the median nerve. Because this median nerve is formed at the foramen lacerum, where the GSPN comes and the deep petrosal joints, and the median nerve comes here. See this. In the floor of the sphenoid, if you follow this median nerve, it will directly take you to the foramen lacerum. There cannot be any better landmark than this for the foramen lacerum carotid. If you see inside the sinus, we'll go inside later. This is the clival recess. This is the sella turcica. And above that is the optic nerve, which is going like this. See this optic nerve going like this to form the optic chiasma? Yes. Sella, and parallel to sella is the paracellar carotid artery. Okay? Now this paracellar, I will show, that day I showed in the radiology, the entire course of the carotid artery at various level, right from the origin from the common carotid, how it traverses the various parts of the skull base. And we'll see a lot of parts today here now. Now, give me the drill first. Let me drill this bone of the sphenoid a little bit over here. And before that, let me show you certain landmarks in this region, otherwise you'll miss that.
There is something like the median nerve lies the same line of the medial pterygoid plate, and palatal is medial to that.
Yes.
Yeah.
Let me tell you what you are trying to say. Yes, that's a good point you raised. See this. This is the floor of the sphenoid sinus. This is the sphenoid sinus on the opposite side. Can you see this? The floor of the sphenoid sinus, both sides. Can you see?
Yes.
Now, this is the pterygoid process on this side. See this pterygoid process? Yes. This is the medial pterygoid plate. And here laterally is the lateral pterygoid plate. See this. Let me separate these fibers of the lateral pterygoid muscle on this side. This is lateral pterygoid plate. Can you see this?
Yes, yes, sir.
Both pterygoid plates, on lateral to this is the lateral pterygoid muscle inserting. See, this is all. This part of the infratemporal fossa is full of lateral pterygoid muscle. See this muscle?
Yes, sir.
And this is attached to the lateral surface of the lateral pterygoid plate. This is lateral pterygoid plate. This is medial pterygoid plate. Similarly, on the opposite side, here is the medial pterygoid plate, and this is the floor of the sphenoid. So, at the level of the floor, let me take this floor down. At the level of the floor, with the junction of the medial pterygoid plate, this bone forms a wedge. Can you see this wedge?
Yes.
Through which the median canal passes. And if you correlate on the opposite side, this gives you a picture of H. H means? H means this is the horizontal limb of the H. And there are two vertical limbs of the H like this. The lower one is the medial pterygoid plate and the upper one is the paraclival carotid. See this paraclival carotid here. So this upper limb, lower limb, and this is the horizontal limb of the H. If you do on both sides and then correlate, it will be like H. I hope it is clear?
Yeah.
So this is medial pterygoid plate. This is lateral pterygoid plate here. And the most important part of the dissection, probably already 5 o'clock. So I will show at least two things. See this, what I have shown today, I have not even started the skull base part. Not yet started the skull base part. Skull base is used, we'll cover some other day. But what I want to show here, basics at least for the routine practice in ENT, what we come across. These pterygoid plates, I tell you, for that matter, you must have realized in your practice, I call it most important 1 square inch for the ENT surgeons. See this, the round I am making? 1 square inch. This is the most important region which I am going to open up today. What does this 1 square inch contains? All the tigers, all the critical structures. How come? This is pterygoid process with all the nerves here. See this, all the 3 nerves. Just about this is the optic nerve. This is carotid artery. Anterior to the carotid artery here and below the optic nerve is the superior orbital fissure containing all the nerves coming from the cavernous sinus. The sella turcica, entire this 1 square inch is full of critical structures. And any paranasal sinus lesion extending to this terrifies the surgeon. And I tell you, this becomes the biggest cause of referral of because it terrifies the surgeon, so he'll end up referring the patient to someone else. And this I am going to clear up today. Anybody who is doing the sinus surgery can do this part as well. I am going to uncover this anatomy in detail here today, so you can get to know what this 1 square inch actually is. There are so many tumors, like angiofibroma. If it expands to the cavernous sinus, it terrifies. It expands to the orbital apex, it terrifies the surgeon. If it involves the cranial nerves, if it involves the carotid artery, it terrifies the surgeon. Isn't it?
Yes, sir.
Am I wrong?
No,
yes,
no.
So this 1 square inch area, I am going to uncover today for everyone. And believe me, any sinus surgeon can do this. What all you need to know is the anatomy. Let me remove some bone here from the floor of the sphenoid.
Jain sir, this is the Amit Kesri sir. I just wanted to ask a few things pertaining to JNA sir in this area.
Yes.
The first question is that when we drill the Vidian canal after the removal of the tumor, and so how far deep we can go? Sometimes it is difficult to because sometimes the Vidian canal is expanded, especially in this area. So I find it difficult by drilling.
Very common, you will find the angiofibroma invading the Vidian canal.
Yeah, very common.
We have seen several times. You go to Dr. Alok Thakkar's publication, they have claimed in a significant number of patients in the Head Neck Journal, 2016. And many more publications, the Vidian canal involvement is so common in angiofibromas, and that is why we'll discuss that in detail on Thursday. The management of the angiofibroma in the live surgical situation, how you can avoid all possible regions of so-called recurrence in angiofibroma. All those regions are something you can handle, because this is the region 1.5 inch, 1 inch, square inch, which is responsible for all possible problems of the so-called recurrence, complication and all that. So I will show one by one, the multi-diamond, the anatomy of this 1 square inch region, and behind this is the carotid artery. I need a full 7-hour session for the carotid, I tell you, from the parapharyngeal to the destination in the brain. That's a huge subject, and we'll do some other day. Today, this basic important thing is more important to address. And of the entire dissection today, I believe this 1 square inch area is the most important part of the dissection. I'll uncover it, completely uncover it. What all problems it can give, you will see. And how you can avoid as well. How you can treat as well.
The steps you are doing is almost same for the transpterygoid approach to lateral recess of the...
Not really. In the transpterygoid approach to the lateral recess CSF leak is a different scenario. In that, the lateral recess is developed.
Yes, sir.
How the lateral recess? What is lateral recess? For everyone, for definition purpose, this is the sphenoid sinus in the center. See this? If this sphenoid sinus pneumatize this pterygoid bone laterally, see this?
Yes,
this pneumatization extends into this pterygoid bone, that is lateral recess. And in that situation, this bone is hollowed out completely. And what you do, transpterygoid, go from the nose and drill the pterygoid and you open the area. And you seal the CSF leak. So straightforward. That is transpterygoid approach because you go through the pterygoid and pterygoid is pneumatized which form the lateral recess. Got my point?
Yes.
So that is different. Here the pterygoid is not pneumatized, you can see.
Yes.
See, it is not pneumatized. Carrison. So, I am moving towards the important area now. Removing this bone.
If I can add to what Satish has said, the lateral recess is always between the V2 and the median nerve. That's where the pneumatization will always be.
Yes.
So all you need to do is remove the anterior wall with a Carrison punch between median and V2. You will see the lateral recess very nicely.
Absolutely. See what Dr. Prabhakaran is saying. This lateral recess I told you is at the cost of pneumatization of this. Now this pterygoid process pneumatization if happens to occur, what is going to be there? The lateral limit is going to be V2 and medial limit is going to be median. And in between there is pneumatization. So you'll see on the scan, I can show on my laptop, the scan showing lateral recess pneumatization and you see these two nerves on the either side of the lateral recess. So that's a very important point, Prepa, you have raised.
Yes.
Now, coming to the most important part of the dissection of the day, I tell you, to shatter your fear completely, I am showing you some struts, some bones. Some bones here. You see this is the V2 going?
Yeah, very clear.
And it is going into the foramen rotundum. See this. Can you see this foramen rotundum?
Yeah. Yes.
And above the foramen rotundum, there is a bone. See this. Can you see this bone?
Yes.
Yeah.
See two different cavities, everyone. Is that clear or not?
Yes. Yes.
This is foramen rotundum. And above is a different cavity. This is superior orbital fissure.
Yes, sir.
Now let me clear it what I mean to say. See, this is carotid artery. This is carotid artery. This is sella. Parallel to sella is the paracellular carotid. And anterior to the paracellular carotid, anterior carotid passes through what? Carotid passes through cavernous sinus. And anterior continuation of the cavernous sinus is what? We call by a very sophisticated name, superior orbital fissure. Try to understand. This is anterior extension of the cavernous sinus. As simple as that. See this. Where my section is? Pakad lena section. Kyun हैरान कर रहा है? पकड़ना. इधर आके पकड़. Yeah, the maxillary strut. So, see what I am trying to say. Concentrate on this 1 square inch. This is the paracellular carotid prominence. I will remove this bone and show you the carotid. And this carotid passes to the cavernous sinus. Lateral to the carotid in the cavernous sinus are what? All the cranial nerves passing to the orbit. The third, fourth, sixth, V1, correct?
Yep.
That is lateral to the carotid, and they pass through anteriorly through this space into the orbit. This is the entry into the orbit. And this is known as superior orbital fissure. Okay? Is that clear? I will make it clear again and again. Now, this is the continuation of the cavernous sinus. Now, below the cavernous sinus is V2. See this V2, this is V2. And this is separated by a thick bone from the superior orbital fissure that is known as maxillary strut. Can you see this?
Yes, sir.
This bone is maxillary strut separating it from the cavernous sinus. See this? So the V2 never passes through the cavernous sinus for everyone, make it clear. V2 passes inferior to the cavernous sinus and it is separated by a thick bone known as maxillary strut. Now, above the maxillary strut is the superior orbital fissure through which all the nerve passing to the orbit.
Yes.
Now, what is there about the superior orbital fissure? See carefully.
Right.
That is optic nerve.
Yes, yes.
That is a separate canal. Got my point?
Yes, yes.
That is separated from the superior orbital fissure below. See this. See, this is superior orbital fissure.
Yeah,
And
yeah.
this is again a bone. Can you see that bone?
Yeah.
See this bone?
Yeah. One more one is there.
That is optic strut.
Optic strut.
Try to understand what I am simplifying. You will never forget in life, and it has a lot of implications.
Very
The V2 is separated from the superior orbital fissure above by the maxillary strut. Clear?
Yep.
Through which the third, fourth, V1 and 6 now passes. And this superior orbital fissure is separated from above by this optic canal. See this optic canal above?
Yeah.
By this optic strut. Can you see this bone?
Yeah, very clear.
What is optic strut? This is a process which comes from the anterior clinoid process to the body of the sphenoid. See that very clear or not?
Yes.
So, now what I am doing, there are three separate foramens separated by two bony struts. That's what I want to convey. First of all, this area anatomy is very, very difficult to understand. I am simplifying. That's why if anybody has any doubt, feel free to interrupt me. So that you never forget in life. I really want to remove your fear. You can operate in this region, knowing this anatomy section.
Sir, will you also tell us then the annulus of Zinn and the orbital apex now?
Yeah, this is annulus of Jin.
Yes.
See, annulus of Jin is what? Let me open up the superior orbital fissure and then I will show. Okay? See this? See this bone, optic strut?
Yes, sir.
Can you see very clear?
Yes.
Yeah, very clear, very clear.
So above the optic strut is the optic nerve and the ophthalmic artery inferolaterally. Okay?
Yes, sir.
Below the optic nerve is optic strut. And below the optic strut is the superior orbital fissure containing all the contents of the cavernous sinus anteriorly, third, fourth, sixth, V1, and below that is a V2. Okay? This V2 is through the foramen rotundum and inferomedial to it, this is Vedian canal which runs in the floor of the sphenoid sinus. Now, having learnt this fact, okay, this is clear?
Yes, sir.
Now I will remove this bone and I will show you, open up the cavernous sinus over here to show the relationship of the carotid, all the cranial nerves, how they are entering the superior orbital fissure and how they are going to go to the orbit.
Yes, sir.
And what are the corridors in the orbit. At the same time, the relationship of this to the sella turcica and the clivus. Okay?
Yeah.
And I'll open up the cavernous sinus. So, many of the time, why I am showing this? All tumors arising in the vicinity of the pterygopalatine fossa, infratemporal fossa, the sphenoid sinus, or other paranasal sinuses have a tendency to invade this critical 1 square inch area. See how critical it is. All structures will terrify you. And if you understand this anatomy and correlate radiologically this, everything can be correlated radiology pre-op that what structure is involved. So that you address that. Involvement is not a contraindication to the treatment. That something should give you the...
Where is optic tubercle? Where is optic tubercle?
Optic tubercle is not this, boss. Optic tubercle is where this optic nerve enters the orbit.
So it is a thick bone where the optic nerve in the lateral wall of the sphenoid sinus.
Yes. See this? This is the superior orbital fissure. Can you see this?
Yeah.
This is the maxillary strut.
Yes,
above the maxillary strut and below the optic strut. See this? This is superior orbital fissure. Now I told you this superior orbital fissure is the continuation of what?
Cavernous sinus.
Cavernous sinus. This is cavernous sinus.
Cavernous sinus.
And through which the cavernous carotid is passing. And this cavernous carotid is related medially to what? Sella turcica. See the sella in the midline.
Yeah.
Yes, sir.
We'll keep a separate webinar on the tumors of the parotid. Pituitary. Pituitary. Pituitary is a huge subject. It requires discussion of days and days. It is never ending. See all this venous blood is still occupied in the cavernous sinus. Below you saw the venous bleeding in the pterygoid venous plexus, you know.
Yes, sir.
And now imagine how much it bothers in the live surgical situation. If this is bothering so much in the cadaver.
Just.
But don't frighten with the venous bleeding. Venous bleeding you can tackle. There are many ways to tackle this. I am removing this anterior wall of the sella to show you the relationship right up to the carotid, cavernous and the superior orbital fissure. So everything be clear in the linear fashion. Everything will be clear in 5 minutes. This dissection of the skull base, it requires 5 days actually. So our 5-day skull base course includes, let me tell you. See, I told you this is 360 degree. This is not endoscopic that everything is. The 1 day on the endoscopic, full 1 day only on endoscopic anatomy and approaches. 1 day lateral skull base anatomy and approaches. 1 day open transfacial anatomy and approaches. Maxillary swing, facial translocation, lateral rhinotomy, left foot, everything. 1 day transcranial anatomy. All basic transcranial approaches like bifrontal, pterional, retrosigmoid, FTOZ, all that. And 1 day radiological correlation of all. And the last day, the 6th one, is to correlate all. Like, what does that mean? You see the trigeminal now, I will show you, no time now. I will show you the Michel's cave from here. You see the Michel's cave from the lateral skull base. You see all the nerves coming in the pterygopalatine fossa. The last day is, from all sides you relate every anatomy from every side. That is 3-dimensional correlation. And that constitutes a complete complete skull base course. So it's almost a week to give orientation. That is only orientation. Now see, Pakar section. Now see again to orient you what I have opened. I hope you are oriented here.
Yeah, very much.
Again, this is V2. This is maxillary strut. This is your superior orbital fissure, okay? And this is optic strut and above is the optic canal. Fine? Now, this is the continuation of cavernous sinus which contains the carotid artery. It is here. And medial to the carotid is sella turcica. So first of all, I am opening the dura of the sella in the midline. See this.
You can see CSF also.
See the sella below. Can you see?
Yeah, very clear.
That is the pituitary gland.
Yeah.
Because of the time constraint, I am going fast. And see this, how this pituitary is attached to the lateral wall. This lateral wall is cavernous sinus through these fibers, dentate fibers. Can you see this?
Yeah.
The pituitary is connected to the cavernous sinus through these dentate fibers. See this, I am cutting those fibers and separating the gland. See this, I am separating the gland from the cavernous surface. Can you see this?
Yeah.
This is cavernous sinus. Now, this pituitary is supplied by 2 groups of vessels, the inferior and superior hypophyseal arteries. You know? The inferior hypophyseal, I will show you the branch where it is coming from when I go in the cavernous sinus. And superior hypophyseal from the main trunk of the carotid above, I will show. Now I am opening the cavernous sinus. Cavernous means trabeculated venous space. Can you see this?
Yeah, very good. You can see.
Because it is empty now. Can you see?
Yeah, very clear.
And see the prominent structure passing through it. The huge one, the biggest one, the tiger.
This is the medial compartment, sir?
Yes. Medial compartment is related to sella. That's why the carotid tumors, pituitary tumors enter into the sella. Mere laptop on karna. Into the sella. Can you see this?
Cavernous sinus.
Can you see this artery?
Yes.
The big one. Can you see this artery? This is big one. This is carotid artery. I'll open up the wall and show the lumen later. Now, this is the sella I have separated from the cavernous area. Can you see this? At this point, there are certain areas. There are certain areas through which this tumor has a predilection to go into the cavernous sinus. See the huge cavernous sinus? So cavernous sinus is a venous containing the venous blood. See this suprasellar cistern which has opened. See this area above the carotid artery into the cavernous sinus. Can you see this?
Yes.
This is space, posterior superior space to the carotid artery, into which these tumors tend to grow very easily. So the prime space, predilection, all pituitary tumors, they grow laterally. Which area? Posterior superior area of the cavernous sinus. Can you see this empty area?
Yeah, very clear.
This potential area, because of this vessel running in the horizontal part in the floor, this is the potential area. The tumors tend to grow in this region because this is the area of the least resistance. Any tumor arising into the pituitary anywhere in the body, it follows a path of least resistance. Got my point? This tumor in the pituitary arising here, it has a resistance below. Can you see this bone?
Yes.
And this bone, it goes away with time, and this tumor have a tendency to go down into the sphenoid. Okay? Now, above, they go through the diaphragm above, I will show you, and they go in the suprasellar area. We see the tumors, they go high up in the suprasellar and the third ventricle area. Third is the area where it can potentially grow easily is the area of the posterior superior region of the cavernous sinus. Can you see so easily how pituitary is related to it? I hope it is clear, scissors in a code.
Very clear.
Very clear? Yes. Though yes. I am not covering the pituitary today, but just a glimpse of some of the anatomy which is useful. We'll do a separate full day webinar on pituitary. Now see,
chiasm
you see the optic now going inside?
Yes.
See, this is carotid artery. See this? This is optic now. Can you see this?
Yeah.
Hello?
Yes.
This is optic now.
Yes, sir.
This is the band of the anterior band of the cavernous carotid. Can you see the band entirely?
Yeah, very clear, very clear, very clear.
Yeah. And this optic now going inside, see this? See this forming the chiasma?
Yes.
Can you see very clear? This is the optic chiasma formed by the optic now coming from both sides. This is the opposite side coming, this is this side coming. Give me the kerosene.
Yeah.
Any doubts, any questions, feel free to interrupt me.
I think you should explain all the cavernous sinus spaces better because
pardon?
When you say I think you should explain the cavernous sinus spaces in a better manner because the juniors will be confused. So what is posterior superior, what is
anterior,
inferior, what is posterior,
I will show all the areas of the cavernous sinus, don't worry. The infero-lateral, medial, lateral, infero-medial, I will show all. Okay? Now, this is see the optic chiasma. Very quick. This is the chiasma and this is the arachnoid layer I am separating. See that? And see the infrachiasmatic plexus of vessels. Can you see this?
Yeah.
This carotid artery, See this, the carotid is taking a bend here and it becomes the clinoidal portion because it in the relation with the clinoidal process. Now see the most important, we have been hearing about that since morning, the ophthalmic artery. Can you see how it is arising from the carotid and going along with the canal?
Inferior wall of the optic nerve, yes.
Yeah, wonderful.
See this. This is the subarachnoid portion of the carotid artery. And the first retrograde branch, see this branch from the carotid artery, it is going retrograde, coming anteriorly, and where? Along this optic nerve in the optic canal. And see where it is going? Inferolateral. Can you see?
Yeah.
Everyone, can you see the ophthalmic artery very clear?
Yes, sir, arising from carotid.
Wonderful.
Yes. Just beyond that is the superior hypophyseal artery. Below, I will show you the inferior hypophyseal runs around the pituitary below and superior hypophyseal above, and they form a sort of plexus around the pituitary, a sort of portal circulation through which the hormones are, they give signal to the hormonal stimulation and secretion. So there is a separate portal circulation by means of these vessels around the pituitary. Yes. Now
sir,
see,
can you show the proximal or distal dural ring for the carotid?
This is dural ring. Can you see this dura over the carotid?
Yes.
Can you see this ring?
Yes.
Let me tell you, for those who know the dural ring, this carotid is coming here as an anterior band and going up. Okay?
Yes.
As it covers the band, it comes in relation to the clinoid process. See this clinoid process?
Yes, as we.
Can you see this bony clinoid process? Above which is the optic nerve, and in relation to the carotid, this clinoid process. That's why it is known as clinoidal segment.
Clinoidal segment, yes.
Smallest of all the segments, and from the superior surface of the clinoid surface process, this dural covering over the carotid is superior dural ring, distal dural ring, and from inferior surface another dural ring covers. See this? This is proximal dural ring. Can you see this?
Okay.
This proximal is never complete dural ring, but the superior is, or distal is always a complete ring. After this clinoidal segment is over, this is the subarachnoid segment of the carotid starts. And this is the first branch of the intracranial subarachnoid segment of the carotid. This is ophthalmic artery. No one should forget this. How it goes retrograde along the optic nerve and goes, take the space, see this inferolateral?
Yes.
So when we do optic decompression, I showed you in the morning, we did the decompression from this side and see the artery going that side, laterally. Can you see very clear?
Yep. Yes, sir. And Dr. Vinod Felix pointed out that we should not be inferior when we incise the slit. We should be superior.
Yes. See this thick dural ring. After this artery, when it becomes subarachnoid, it gives the first branch. Let me show you. This branch, this is superior hypophyseal. Can you see this?
Yes.
And this forms a plexus. See the amazing plexus of vessels below the optic chiasma. Can you see the optic chiasma?
Yes.
Amazing plexus. That's why the tumor going in this region, you have to be very careful. Yes. Very careful not to disrupt these vessels to give the ischemia to the optic chiasma and blindness. Now, from the pituitary here, can you see something going up? See, this is anterior pituitary, this is posterior pituitary.
Yeah.
See the pituitary stalk going up?
Yes.
Let me clear all these branches. See this stalk?
Yes.
Yes. Both sides superior hypophyseal are visible. See, I am going this anatomy very fast. Every pituitary anatomy requires 2 hours. See this?
Satish cleanly seen.
Yeah. See, this is pituitary stalk. Prepa?
Yeah, very clear.
Slept?
Yeah, very clear. Ultimate. We can see very clearly.
Can you see the pituitary stalk very clear?
Wonderful, wonderful.
And see, it is passing. This is the chiasma. And see the horizontal chiasma behind completely. Can you see?
Yeah.
Okay. Now, at this point, I will elevate this this thing. Let me put down this chiasma below. Can you see the vessels above the chiasma?
Yeah.
These are two anterior cerebral arteries coming from both sides of the carotid. See, this is the anterior cerebral on this side.
Yes.
This is the anterior cerebral on this side, and they are forming the anterior communicating. Can you see? That's how is the anterior circulation. And see the membrane I am opening. Can you see this membrane I am opening?
Yes.
Above the chiasma and below the vessels. This is lamina terminalis. Can you see this membrane?
Yeah.
This is the membrane of the gray matter. And see through this membrane where I am entering.
Third ventricle.
This is the third ventricle of the brain.
You can see four.
And see the entire choroid plexus.
Choroid plexus.
Band kar, nice. Let me show you better. Though this was not the agenda, today's agenda, but since we have reached there, let me give you an overview. Yeah.
Also, so the A1, A2 and the ACOM.
Yeah. See this third ventricle. Can you see the walls around? That is thalamus.
Yes.
And see above there are two foramens.
Yes, let's go.
Can you see two foramens above?
Yeah.
Those are draining those are circulating the CSF from the above two ventricles. Those are lateral ventricle. Those are the cavities in the cerebrum. Can you see the four brain cavities?
Yeah.
Every brain part has a cavity known as ventricle. And see this tissue, this space-like tissue, this secretes the secretes the CSF, that is choroid plexus. So the CSF is secreted from the lateral ventricle above. Okay? Hello?
Yeah.
And comes through these two foramens, those are known as foramen of Monro, into the third ventricle. This is third ventricle. Can you see? Very clear now? The foramen of Monro, choroid plexus, third ventricle. And see, this is interthalamic area. And see where this is going to the aqueduct of Sylvius.
Yeah.
To the fourth ventricle. And from there it goes to the, where the CSF is absorbed to the arachnoid villi and the major dural sinuses. See the lateral ventricle above? Foramen of Monro.
We
the
can see
choroid
inside.
plexus. And this is the fourth ventricle. And either side, this is the cavity in the thalamus. Either side you see the thalamus, and in the below in the floor, can you see these two rounded structures? These are mammillary bodies. Is that clear?
Yes. Yeah.
And see where I am going through, this is lamina terminalis, below is the chiasma and above is the anterior cerebral artery complex.
Sir, why does snowman happen in pituitary tumor, sir? I mean, can you
because
just
it goes up.
area?
Now see. Yes. Now see the, can you see the stalk again?
Yes.
Is Kirtne sir there?
I think he's there.
I'm very much there.
Sir is there.
Amazing, absolutely amazing.
Sir, any suggestion?
No.
See this. This is the pituitary stalk. And this is behind the pituitary. This is dorsum sella. Can you see both sides, the two posterior clinoid process?
Yes, sir.
I can fracture them and see immediately lateral to that. I will show you the third nerve coming. That is the third nerve. Can you see the third nerve below?
Yes.
And see the biggest vessel in this region. Behind. That is the basilar artery. And see this basilar artery, and above the basilar tip, and this area is known as interpeduncular fossa.
Okay, sir.
That's a part of the midbrain, you can say here.
Sir, can you show Dandy's vein and Mickel's cave as well?
Yes, I will. We still see now. This area of this is the area of the interpeduncular fossa, and this is the basilar artery. This is giving two branches below. See on either side.
Superior and posterior.
Superior cerebellar.
Yes, sir.
And two terminal branches. Can you see? posterior cerebral, and from this posterior cerebral, can you see this artery? This artery which is arising from the posterior cerebral. This is posterior communicating, coming anteriorly to join the carotid to form the circle of Willis. So how the circle of Willis is formed between these two circulation, basilar and carotid circulation? Carotid is anterior circulation, basilar is posterior, formed by two vertebrals. So these two posterior cerebrals, they give rise to the two posterior communicating. And they join the carotid on either side. And from carotid, there are two anterior cerebral. See this. The one anterior cerebral this side, one anterior cerebral this side, and they form the anterior communicating. And that is how the entire circle of Willis is formed. That's why in the paraganglioma we discussed when we talk of the cross flow, these anterior and posterior communicating vessels should be adequately developed to maintain the flow from the opposite side in case the one side carotid is blocked.
So can you show us A1, A2 at this point? They are very clearly seen.
Yeah. This is A1 on both sides.
Yes.
This is communicating, and after that what emerges is A2.
A2, right.
So A1 is the previous segment, this is anastomosis, and then the A2. Okay? Now, coming to the region of the cavernous sinus. Okay, let me show you the 70 some more, if you want. This is amazing anatomy, this is never ending. See this?
Exactly.
Now with the 70 degree, see the A2.
Yes.
And see another vessel which is emerging from this anterior cerebral. Can you see this? This is artery of Hubner, recurrent artery of Hubner. This one. Emerging from A2. Can you see this?
Yes.
This is very important. Yes. It can lead to infarction otherwise. And now, leaving this, I will come back to the area. Interpedunculaire fossa. You wanted to see cranial nerves, all cranial nerves now?
Yeah, all the cranial nerves.
Let me show you with the 70 degree. Now, let me go below the chiasma. And then I will rotate it 70 degree, down and laterally. And see, this is the carotid artery. See the third nerve. Let me show the Michel's cave from this side. I will show from the other side.
So actually we need more central exposure to see laterally.
Let me come back to, not to disorient you, come back to again to the 1 square inch area. That is our focus today.
Lateral part of the...
Today's focus is 1 square inch area. Now coming back to that, orient yourself. We went too deep. Forget about it. This is pituitary and we went deeper. This is the stalk, the chiasma, and then we went further deeper. Okay? Forget this. This was our foramen rotundum. Come back to the same place. See this? Section.
Yes, V2.
Our area of interest in our practice is this more commonly in ENT practice. See, this is optic, the maxillary strut. This is the superior orbital fissure. This is optic strut, and above is the optic nerve. Okay? We have opened the carotid artery over here. Okay? Now, what is there lateral to the carotid artery in the cavernous sinus? There are a number of cranial nerves running in the lateral wall of the cavernous sinus. They actually do not pass through the cavernous sinus, but run through the two layers of dura in the lateral wall, the periosteal and meningeal layers of the dura, to the cavernous sinus. Okay? Now see. Let me push this carotid medially to open up this space laterally. See this? I am pushing this carotid medially. I am pushing this carotid medially to open up the space lateral to the carotid. Okay?
At this point, please explain what is anterior compartment, what is medial, what is lateral, what is posterior, sir?
Of the cavernous sinus?
Yes, sir, exactly.
See this? I am displacing the carotid medially. Can you see this? And this compartment lateral to this is cavernous sinus. This is lateral compartment. Let me show some vessel here. In the lateral compartment, it gives off a branch known as inferolateral trunk. And that is third nerve, I know.
Yeah, it's a third nerve. Yes, the big one's the third nerve up here. Yeah, there's a third nerve up there.
This carotid from the posterior band gives off a branch meningohypophyseal trunk, and from the lateral side it gives a, the inferolateral trunk. Now I have displaced the carotid medially. Can you see this? See this? Displace the carotid medially.
Yeah.
And now I am in the lateral wall. Suction kar. Now there are, wash. There are a number of nerves in the lateral wall which are ascending to the superior orbital fissure. This part of the anatomy of the skull base, I again remember that phenomenal person who revolutionized is Professor Albert Roten, who is no more. He left us last year. But that man is something. I have no words to express our gratitude to him.
So he made 360-degree skull base possible.
Yes, his anatomy is beyond anybody can think of.
Satish, but you have given a wonderful demonstration of the whole anatomy too.
Yes, sir. It is amazing.
Amazing.
Short ventricle.
Now let's see the cavernous sinus. Thank you, Narayan. Now see, I am separating this carotid completely medially. The nerve which is closely associated to the carotid below is the sixth one. Sixth is a very important anatomy. This is a longer course, but anyway, let me completely separate this carotid. Yes. Yes, now show. Now see the number of nerves in the lateral wall. See now. Yeah, यहाँ कर suction. Yes. See above. Yes. This is the third nerve.
Yep, the big
Can
one.
you see?
The big guy.
In the lateral wall of the cavernous. Below that is the fourth nerve. Can you see?
Small one, yes.
Tiny one. Below that, see this? Here,
You can see the
here
sixth already,
medially,
the free floating.
This is the sixth now, medially.
Yeah, it's the
See
free
the
floating
loop?
nerve. Yes.
I have looped it. Can you see in my instrument?
Yeah.
This is the sixth
Very
now,
nice.
and this truly passes through the cavernous sinus. The only nerve truly passes through the cavernous sinus. And lateral to the sixth is the V1. This is V1. This one. Immediately lateral to it in the floor. See that? That is V1.
Very nice. Very
So
nicely seen.
V1, all these four nerves are ascending through the superior orbital fissure to the orbit. This is orbit. And above them is the optic canal with the ophthalmic artery. Okay? Now this nerve, V2 is below here. V1 is going up. All the three branches from the trigeminal are diverging from each other. So V1 is going up there in the superior orbital fissure. Let me show you. See that? V2 is coming here down. See this? And V3 is far laterally and behind V3 coming out of the foramen ovale. The moment I drill this pterygoid process, behind and above the pterygoid process, I will completely drill away this pterygoid to show you the V3 coming out of the middle cranial fossa covering the carotid artery. That's a huge landmark to the petrous carotid from front. And that is used many a time by the lateral skull base surgeon as well in infratemporal fossa B approach. See all the four nerves in the cavernous sinus.
Beautiful. Very nicely seen.
Wonderful.
And see the carotid is medially displaced, and see this is the cavernous sinus. And now see what is there behind. That is the ganglion. Can you see the fibers of the ganglion?
Yes.
See behind.
Yeah.
Such a nice ganglion. See this?
Yeah,
This is trigeminal ganglion. Through which the V1 is going up, V2 is going here, and V3 is going here behind. I will show very soon. So all the three branches of the trigeminal they are coming out of it and they supply the sensation and a lot of motor things to the entire head and neck region. We'll see each and every branch of all the three nerves. Now, before that, I told you, because the time is not permitting, I told you I would show you the anatomy of the orbit. Now, I don't think the time will permit. It's already 5:45, but I am ready. So now.
Maybe how much I feel? Still we have half an hour, 45 minutes. No,
Boss, as long as you say, I have no issues. Because this is never ending. I told you this requires 6 days of dissection. So now, let me enumerate something about the orbit here. We know all the 6 muscles in the orbit. 4 recti and 2 oblique muscles. Okay? Now, yes. How these nerves are spread inside, let me tell you. This third nerve, as it goes inside the superior orbital fissure, here is the annular tendon. The moment it enters the superior orbital fissure, the periosteum forms the annular tendon from where all the muscles arise. All the these recti muscles arise. This third nerve, oculomotor, as it enters, it divides into 2 divisions. The superior division goes up to supply the superior rectus and levator palpebrae superioris, and this inferior division supplies the inferior rectus, medial rectus, and the inferior oblique. And out of them, the nerve to inferior oblique is the most important nerve. The reason is, this nerve to inferior oblique gives a branch to the ciliary ganglion, from which the ciliary nerves go to the eyeball. And it gives a special postganglionic fibers to the nerve for the accommodation to the ciliaris and constrictor pupillae. This is all from nerve to inferior oblique from the lower division of this oculomotor. The 4th nerve supplies the superior oblique, and that is the most medial part in the orbit. See, in the most medial part of the orbit superiorly, I told you I wanted to show the orbital dissection from the intracranial side. Most superior part of the orbit are 3 nerves. That is outside the annular tendon. One is the 4th cranial nerve. Another are the 2 branches from the V1. That is lacrimal and the frontal. So this 4th nerve comes most medially, superiorly in the medial most part of the orbit. So in all intraorbital approaches, this is most medial and superior, and this is not injured. Because the superior oblique has a pulley which is most medially above.
At which point we can enter into petrous apex here.
Yes, this is behind the petrous apex over this ganglion is. I will show the anatomy of the petrous apex, boss, in no time. This trigeminal ganglion is situated on the petrous apex only here.
Yeah.
The moment I drill this, I will drill this to show this carotid. See this carotid?
Yeah.
How this is coming out of the, see this is carotid. It is emerging here from below, here at the foramen lacerum.
Yeah.
And foramen lacerum is at the level of the petrous apex. I will show you the approaches to the petrous apex from lateral to it and from medial to it. Okay? Let me drill this clivus and this caroticoclival window to go to the petrous apex, and there are various approaches. I tell you, for tumors in this region, to address the petrous apex, there are a number of approaches. Suprapetrous approaches above the petrous carotid artery. Infrapetrous approaches below the petrous carotid artery. And then you have to drill this foramen lacerum. Entire pterygoid process, you have to remove the Eustachian tube, and then you reach to the petrous apex below. That is infrapetrous, and above that is suprapetrous approach. And there are many of the tumors invading in this region can be removed by endoscopic approach through this direct path.
Yes, sir. Sonomas of V1, V2, V3.
Yes. So now, we are coming to the nerves. So the lower one now, the nerve, the 6th nerve, it goes to the most lateral part of the orbit. See, the moment it passes through the annular tendon, it takes the extreme lateral course to supply the lateral rectus.
Through the canal.
Yes. The most important of all these nerves is the V1. It is a sensory branch of the trigeminal, only sensory branch. So the moment it goes inside the annular tendon, first of all it gives 2 branches which go outside the tendon above, that is lacrimal and I told you frontal. The frontal goes above anteriorly and divides into supraorbital and supratrochlear. We discussed during the time of trephination. The supraorbital and supratrochlear, those are the branches of frontal nerve, which is a branch of V1. So those two are the outside the annular tendon, and rest inside the annular tendon is the most important branch, nasociliary.
Yes.
Nasociliary goes inside and along with the ophthalmic artery, crosses the optic nerve from above and go medially. And this nasociliary gives sensory route to the ciliary ganglion. So that's how all these muscles are supplied and have an intimate relationship inside, which I wanted to show. And we'll take a dedicated session next time to see this anatomy in layers, one by one from above. Orbital anatomy. The reason is to enter inside the orbit to address the tumor. The endoscopy is the preferred approach. And for that, all tumors medial to the optic nerve are the preferred lesion to be taken by endoscopy. Lateral to the optic nerve is something contraindicated because you have to cross the nerve, you can damage. But yes, this nerve is high up in the orbit. So any lesions below the optic nerve laterally, still you can address them, staying or the inferior rectus muscle to go laterally. So orbital lesions, orbital apex lesion can be addressed endoscopically. So what I mean to say, this 1 square inch anatomy is everything to the ENT surgeon, endoscopic surgeon. All the cranial nerves in the pterygoids, in the superior orbital fissure, this V2, optic nerve, carotid artery, the cavernous sinus, sella, and the entire cranial nerves to the cavernous sinus. This 1 square inch is the key area. Now, I will drill away this pterygoid process, and then I will dissect this Eustachian tube to go to the parapharyngeal carotid artery, which is again one area, the parapharyngeal carotid, which again terrifies the surgeon when you operate in the parapharyngeal space. See, this is Eustachian tube. Can you see this Eustachian tube?
Yes, sir.
Yeah, very clear.
This is cartilage.
Torus,
This is the end of the medial pterygoid plate. The Eustachian tube is behind the medial pterygoid plate. See this? And similarly, laterally, the lateral pterygoid plate.
Yes, sir.
From the medial pterygoid plate, the carotid artery behind is exactly 2 centimeters behind, parapharyngeal.
Yes, sir.
And for that carotid artery, the Eustachian tube is like mother. It covers the entire course of the carotid, not only from here till the ear. Till the petrous carotid, we know how the in the ear, in the temporal bone dissection, we saw how this Eustachian tube was covering the carotid. The carotid was deep to it. In the ear, you see, where the Eustachian tube orifice, the carotid runs deep to it. So is the ear, so is the nose. In the nose, again, the entire parapharyngeal carotid, right from the, that will require a separate session. One session only for the course of carotid with all landmarks right from the parapharyngeal to the brain. At every level, so all fear of the carotid goes off. So this is the fossa of Rosenmuller behind it. This is the Eustachian tube cartilage, and it runs laterally and superiorly. And as it runs towards the middle ear, the carotid runs behind it. All the way. As long as your carotid is anterior to it, your carotid, this Eustachian tube is anterior to it, your carotid is protected. As simple as that. It is like mother's lap protecting the carotid artery. So now, anterior to carotid is the pterygoid process with lateral and medial plates. Lateral to the lateral plate is the infratemporal fossa. This is again a huge anatomy. This is again a huge source of, diseases in the infratemporal fossa, where there are a lot of muscles and neurovascular structures. And this is below the greater wing of the sphenoid, below the middle cranial fossa. And this is again a separate topic to be discussed again in the coming webinars. We'll see the 3D anatomy of the infratemporal fossa, and behind the infratemporal fossa is the parapharyngeal space, their relationship with the pterygoid process, Eustachian tube, then the petrous carotid above, the foramen lacerum, and all this carotid. So all this lateral anatomy is to be explored, and that requires time, because if I show quickly in 10 minutes, you will not grasp. So I think that will not be the justice, but I can give you an overview. This pterygoid process is the key. the carotid is behind there. Carotid is behind the eustachian tube. This is the posterior musculature of the nasopharynx. Carotid is 1 centimeter behind this level of the surface. If I go in the coronal plane lateral to it, every time my carotid is 1 centimeter behind this plane. So once you work laterally in the infratemporal fossa, parapharyngeal space, anywhere, keep taking the reference of this musculature, this surface. Yes, as long as you work parallel to this surface, your carotid is 1 centimeter behind. Because 1 centimeter behind is the anterior arch of atlas and carotid runs parallel to it. So this reference of the nasopharyngeal tissue, this surface mucosa, always go whenever you work laterally, don't get terrified. As long as you work in plane of this mucosa, your carotid is 1 centimeter behind. So there are certain landmarks which can make your life easier rather than to terrify you. Because now there are lots of surgeries you can do. I will keep in the coming times nasopharyngectomy for malignancy involving the eustachian tube, and then this entire region including the pterygoid process, eustachian tube right up to the carotid canal along with the nasopharynx will go en bloc, preserving the carotid artery. And that is the surgery of choice.
Professor does that a lot.
Pardon?
Professor Prepa does that a lot. The nasopharyngectomy.
Nasopharyngectomy, yes, that's amazing.
This is very common in
procedure
Malaysia.
for the recurrent nasopharyngeal cancers, post-RT, and for other non-radiosensitive cancers like adenocarcinoma and others. And this is the life-saving procedure, nasopharyngectomy. You know, I tell you in the next time what I had planned. I had planned all the open approaches also. What I believe, anybody who is doing endoscopic must be well versed with open approaches. This nasopharynx earlier, how it was approached before the advancement in endoscopic techniques? Through the lateral approaches. What were the lateral approaches? Facial translocation. You translocate the face. Facial translocation is the most massive approach. You can access the entire right from the middle cranial fossa till entire face, nasopharynx, right till neck, everything once you translocate the face. That's a simple approach, but there is a lot of morbidity associated with not only external scar. You give a lot of osteotomies, and that is not a, nowadays it is obsolete, but still we do for some indications in massive malignancies which are considered otherwise inoperable. Then the other approach which is very common and every ENT should know now in this era, that is maxillary swing. You swing the maxilla laterally, keeping this external flap attached with the facial artery supply, swing the entire thing laterally, and then you go right deep into the oropharynx and the nasopharynx, there, behind the maxilla and the pterygoid process. So we swing not only maxilla but the pterygoids also, and you're right on the nasopharynx. But again is an open approach which requires osteotomy and some mobility. Then Lefort one approach is amazing to the central skull base. So all these open approaches one should know. We'll discuss, maybe it may interest some people, but at least one should know. So a lot of things are left for the future because they cannot be covered in a day. And though I try to go faster, but still. So anybody, I can still show, anybody wants me to show something special right now, which I can show in the quickly, if you want.
So drill the pterygoid and sew a little deeper. And
okay, give the drill.
Next 10-15 minutes.
Okay.
Satish, both are amazing. Your dissection and your stamina is amazing. I don't know from where you
get
student. I am your student. I think this has been absolutely.
This is my biggest qualification, being your student.
I think
and once you are there, my energy level is double. Keithness sir is there.
Yeah, that we can see. But your energy level also is as amazing as your dissection and your knowledge of anatomy. Congratulations. Really fabulous job.
Just show the V3 also. The course
V3,
of V3.
Yes. Once I remove the pterygoid, I'll show you the V3. That is important, I have not shown. So what I am doing, I am finding the ways to remove this pterygoid faster. I told you because that my burr is ruined. It's not available today. So I broke with the, So something about the pterygoid here I would like to mention before I remove it. This lateral pterygoid plate is the medial wall of the infratemporal fossa. Okay? Now there are 3 compartments. I will make everyone very, very clear for your information in ENTs, because they are always confused. I have seen many people. Not to get confused, I will make it clear forever. Infratemporal fossa, masticator space and parapharyngeal space, pre-styloid, post-styloid. These are 3 different compartments, have different relationship, boundaries and different pathologies. Not to get confused, the infratemporal fossa with the masticator space. So infratemporal fossa is different. Masticator means the space containing the masticatory muscles, as simple as that. All the masticatory muscles. So like masseter is lateral to the mandible, it is in the masseteric space. But this infratemporal fossa is medial to the mandible, so it doesn't contain the masseteric muscle. So, and if you really want to refer to with a clear concept, because this is a huge subject, I will suggest you one person who has done massive work in this field and whose publication has a maximum citation, if you know, in Mumbai, Dr. Suprita Arya, the radiologist. Kisne sir must be knowing. Sir, do you know Suprita? Hello?
Yeah, I've heard of Suprita, but I have never had the occasion to know her personally.
Okay, so she, along with Dr. Anil D'Cruz, they published an article on these various spaces like infratemporal fossa, the 8 spaces. And I remember we met Narayan once, we met together with Suprita in Tata. You remember?
Yes, I remember that, yeah.
She's amazing. And that article is what radiologists should know and what surgeons should know. Simply on that. So these spaces, they were extremely important areas and amazing significance in our day-to-day practice. Some lesion is going to the masticatory space, some to the infratemporal fossa, pterygobeltine fossa, parapharyngeal space. And there is a lot of overlapping in understanding. So we have to be very clear about the understanding of these spaces. Like Amit said, show the parapharyngeal space, infratemporal fossa. We need to know what is parapharyngeal space, what is pre-styloid, post-styloid, what is infratemporal, what is buccal space, what is masticatory space, what is parotid space. There are 8 spaces in this region which have important significance. Now, give me the drill. I will drill away.
Sir, I think in Feb, Dr. Narayan did a course with Professor Peppa in Mumbai, sir.
We will do a course again once this COVID era is over with Dr. Prabhakaran Narayan. He has consented and we'll do a full skull-based course, 5-day course. As I told you, 5 different aspects of anatomy. See, why I'm telling you, what anatomy you see endoscopically, the same trigeminal you see from the lateral skull base is different perspective. Different relationship, different depth. Everything is different. The same thing you see with the open approach is altogether different. Same thing you see from the transcranial perspective, altogether different. And same thing when it comes to relate radiologically is extremely difficult. Unless and until you are thorough from all aspects, open, transcranial, endoscopic and lateral, 3D, and then radiologically, until then it is not complete. So any skull-based course should include all this, and final assessment is this 3D assessment. Every structure can be seen from every side, and then one can plan what is the best approach for particular lesion. Otherwise, whoever is knowing endoscopic, he will push in everywhere endoscopic. Whoever is knowing lateral skull base, he will push in lateral skull base. That is not something which can optimize the results. So we have to understand this fact.
I agree. When Satish is showing all this anatomy, it's so wonderful to correlate with the lateral approaches. Like if you correlate with infratemporal fossa B and C approaches, you see typically Vidian, you see V3, you see eustachian tube and carotid. So if you look at it from a lateral perspective, you see from anterior to posterior, this is exactly what you showed endoscopically. Vidian, V3 at a little deeper level, eustachian tube much deeper, and then carotid. So the same things we see from a lateral approach. So it's very good when we correlate lateral and endoscopic, and really wonderful.
Cold drink biscuit.
Sir, your book is ready, sir? 360 degree skull base.
It's almost ready. I think it should be ready within a month. Last bit is going on, and I think
I'm waiting for that, sir.
We have to pick up a good
now,
launch.
see, Narayan.
Yes, Satish.
As I am opening this pterygoid fossa, fossa means between the lateral and the medial pterygoid plates, there are two muscles inside the fossa. And very, very important anatomy they have in terms of relationship to the carotid artery. The medial pterygoid muscle is the inferior anatomy. Medial, see, in the infratemporal fossa, the upper part is mostly occupied by the lateral pterygoid, and medial pterygoid occupies mostly the medial part, lower part. So this is the medial pterygoid muscle which goes down from here. And the other muscle in this, between this pterygoid fossa is the tensor veli palleti, which has an important relationship with the, as a landmark to the carotid artery. So this levator and the tensor palleti I am showing you. See, this is eustachian tube, you can see. Can you see the eustachian tube?
Yes, very nicely seen.
Now, can you see this muscle below? Can you see this muscle?
Yes.
Can you see this muscle immediately lateral to it, running up?
Yes.
This is cartilage of the eustachian tube, can you see?
Yes.
And this is the muscle below. Can you see this? This comes in the palate and form the aponeurosis. This is levator palleti.
Right.
Okay? And this muscle in the fossa going up again, this is tensor veli palleti. Up. These two muscles are rising towards the carotid canal, where the carotid artery from the parapharyngeal segment runs up in the temporal bone carotid canal. So once you're operating in this region, these cool drink. These two muscles, you have to follow right up to the carotid canal as they stay anterior to the carotid. Or manga pani. Biscuit. Just a minute. Biscuit.
Almost 8,000 people are still watching you now.
Oh my God. Crazy.
Yes, and I'm getting messages from Chennai, from Dubai, from Malaysia, that you're doing an amazing work. You're an university, sir. Indeed, you're an university.
No. Exactly. We are all same. We are learning. See, every time I learn something. And we have so many experts with us. See, learning is never ending. This is your tensor palleti, vertical fibers going up. See this. Sometimes this medial pterygoid, this is medial pterygoid inferiorly. This is tensor palleti. Sometimes these fibers fuse like anything. You cannot differentiate, you cannot distinguish which is tensor palleti, which is medial pterygoid. So now, my task
sometimes
is
DNA, sometimes this in this area the DNA drop down to the nasopharynx area, sir. I mean below the nasopharynx area.
Pardon, Amit, can you repeat?
Sir, sometime when the JNA has destroyed the pterygoid and from inferior part of the pterygoid, inferior attachment of the pterygoid, it goes down. So do they follow these muscles, sir?
Yes, it goes in the fossa, pterygoid fossa. But it doesn't invade the muscles, you know.
Yes.
See, this JNA has a different characteristic where it invades, where it doesn't. In the pterygoid fossa, it invades the trabecular system, Haversian system. Chai mile?
Yes, sir.
Tea. And in the pterygoid fossa, it doesn't invade. It pushes the muscle, you know. So, and this JNA, which I am demonstrating on Thursday, has a classical destruction of the entire pterygoid fossa. Complete pterygoid fossa is eroded. And it is going towards the middle fossa base. See this. This pterygoid, where it is, you know, I forgot to tell you one important thing. Amit, Thank you, Amit, for discussing this. See this cavernous sinus and the walls you have seen?
Yes.
I forgot to tell you, include one thing in this 1 square inch. I'm really sorry. That is very important, Pakarna section. See these cranial nerves you saw in the lateral wall of the cavernous?
Yes.
Hello?
Yes, sir. Yes, you can see. Yeah.
What is immediately lateral to the cranial nerves? What is there immediately lateral to it? See, I'm opening. See, I'm opening. What is immediately lateral to them is the temporal lobe of the brain.
Yes, sir, middle pulse.
Okay, one more approach for temporal lobe. Okay.
Can you see the temporal lobe of the brain coming in the picture?
Yeah.
That is the temporal lobe of the brain, you can see. See this?
Yes.
CSF is coming.
Yes.
So, in the immediate vicinity of this cranial nerve, immediate laterally the temporal lobe of the brain. That is comes in the same 1 square inch. Now, why I'm saying this pterygoid process ascending up towards where it is going? To the middle fossa base. Middle fossa base means? अरे क्या हो गया इसकी लाइट को? Yes. See, this is going to the base of the middle cranial fossa. So when this pterygoid is involved by the tumors going up, just above that is the middle cranial fossa.
Exactly.
Just above the pterygoid is the middle cranial fossa. This V2, if I drill this maxillary strut, this is direct entry into the middle cranial fossa here. This V2 is running.
Yes.
This V2 is running in the floor of the middle cranial fossa.
Yes, the Meckel's cave. Yeah.
Yes. So that runs in the middle cranial fossa. The middle cranial fossa is in a close vicinity here. Many a times you will find GNAs extending into the middle cranial fossa. How they extend? They extend between certain triangles, through certain triangles. Let me tell you. This is V1 going to the superior orbital fissure. This is V2 going in the pterygopalatine fossa. By eroding this bone between V1 and V2, maxillary strut, see this thin bone?
Yes, sir.
They enter the middle cranial fossa. And now what is at the risk in this situation? See, this V1 is the most inferior anatomy in the superior orbital fissure as far as the nerves are concerned. Below that is maxillary strut and below that is V2. Yes. Above the maxillary strut and below the V1, there is another vein which runs, superior ophthalmic vein. See this? That is the inferior most anatomy of the superior orbital fissure. And these tumors keep pressing on the nerve as they go up in the superior orbital fissure. Sometimes they thrombose it. Thrombosis of the superior orbital vein is a common cause of blindness.
Superior ophthalmic vein.
Ophthalmic, sorry. Superior ophthalmic vein is a common cause of blindness. So
Satish, the triangle.
What, inferior ophthalmic vein then? It will be.
Pardon?
What about the inferior ophthalmic vein? It will be in the.
Yeah, this is inferior ophthalmic vein, sorry. The inferior most anatomy in the superior orbital fissure is inferior ophthalmic vein, which runs below the V1. What I said, superior.
Yes, sir,
this is inferior. Inferior. Yes, Narayan, the triangles.
Yeah, I was just talking.
Between the V1 and the V2 is antero-medial triangle. Between the V2 and the V3 behind here, which I am going to show you, it is anterolateral triangle. These are the two triangles through which this tumor ascends in the middle cranial fossa.
When the neurosurgeons come from the lateral approach, FTOZ and other stuff, they go between these triangles to actually.
There are so many triangles. Yeah, exactly. There are 10 triangles in the middle cranial fossa floor. You know, the posterolateral triangle, the Kawasaki triangle, the Glasgow triangle, there are so many triangles. But so many are the triangles in the, this thing, cavernous sinus, you know, between all the nerves forming triangles. Like Parkinson's triangle, oculomotor triangle, all these are different. There are 10 triangles in total in this region, which I am not going in the depth right now. When we'll do skull-based dissection, we'll go.
They are good enough.
Those are important to tell you. I will tell each and every triangle's boundary and what structure passing and how it is important for the sphenoid sinus and tumor spread. Yes. Yes, Narayan.
No, I said that's good enough to say that they are good. They are the entry into the cavernous sinus between V1, V2 and between V2 and V3.
Yes, that's how these triangles are formed.
Then what about the superior ophthalmic vein? That will also be in the
superior ophthalmic vein. I tell you, if I tell you the course, it drains the most of the blood of the orbit from the medial compartment of the orbit. This is the only structure after draining the blood. It crosses the optic nerve to go laterally. And you know, it comes out of the superior orbital fissure from the most lateral part. And then drains the cavernous sinus. That's why the orbital lesions very frequently have cavernous sinus thrombosis, particularly if there is inflammatory pathology in the orbit. Infection in the orbit can directly extend to the cavernous sinus and can lead to thrombosis, and that is a disaster. Can easily lead to blindness.
So these two structures are also outside the annular ring.
Yes. Again, inside the annular ring and outside the annular ring, I have already told you, the three structures which run outside the annular ring as far as the nerves are concerned are the trochlear nerve, the lacrimal and frontal. Rest now through the annular ring. Similarly, the superior and inferior ophthalmic vein, they run outside and join the cavernous sinus.
Yes, sir.
Okay? Section. Drill. Autology wali drill. हाँ ये दे. Robust. So I am using here, or not, ये तो पहुंची नहीं रही.
Gauss hammer will not work.
Pardon?
Gauss and hammer will not work.
That is saying if drill is not working, you can use Gauss.
That's okay.
See the marrow space in the pterygoid.
Yes, sir. It bleed a lot in usual practice.
And behind this, as I go, above the eustachian tube, there is foramen lacerum. The carotid artery doesn't pass through the foramen lacerum. It runs over the foramen lacerum and turns. So all this pterygoid, see how big, thick the bone it is.
Yes.
Yeah.
And if I drill it completely, above and behind would be the foramen ovale. But there's a thick process.
Yes. I think you should take out this bone, just show us the V1, then I think that's more than enough for today. Otherwise you will only almost, just show us the V1 only. Then after I think we can off for the day because almost more than 7 hours already been there.
And sir, Dr. M.V. Apparao has been requesting, he sent quite few messages that he wants to see the transorbital approach to the paracellar region.
Yes, that is,
next
recently it is coming up like anything. Not only the paracellar, but to the middle canal fossa, to the other areas around. The transorbital approach is coming up in a big way. And I can show that the simply is you have to go underneath the periosteum of the orbit and drill the bone and go in the middle canal fossa behind. Because behind orbit is the middle canal fossa. It's a good, safe approach. And in the next dissection, I will show all the transorbital approaches.
Yes.
That's a good question. Those are most direct approaches to the, sometimes to the cranial base.
But Dr. Prepa has to leave. You have also not taken any lunch or nothing. And Dr. Narayan is also. So I think just show us the V1 and then we can keep it for next.
Really, sir.
Yeah, I have taken a lot of time of Prabhakaran and Narayan.
Sir, hats off to Dr. Prepa.
Hats off to their patience.
Sir, good evening. Amit Kesari here, sir.
Hey, hello.
Yeah, your student is there. Your student is
nice
there.
beard you have. Happy Father's Day.
Thank you, sir.
Sir, Dr. Kirtani sir, Dr. Prepak and Dr. Narayan sir has been glued to the screen since the time you have started the dissection. They haven't gone anywhere.
Oh, great. See, this part of the plate is left. This is the eustachian tube. And as I go more and more behind and above, you see the cartilage of the eustachian tube. This is the cartilaginous eustachian tube.
Very clearly.
And these are the muscles of the eustachian tube. Keep going laterally and up. And still, the carotid artery is 2 centimeters behind. Parapharyngeal carotid is so deep.
If all that bone would have come out, you could have shown the foramen lacerum, the petrous part going under the
Yes. See, for that, Narayan,
Parapharyngeal
this area of the foramen lacerum is formed of 3 bones synchondrosis: the petrous, occipital, and the sphenoid bone. And there is a thick fibrocartilaginous tissue over there with a huge, thick synchondrosis. And that requires a lot of drilling and, a lot of cautery and through-cut forceps to remove that thick tissue to open up, because immediately behind is the inferior part of the petrous apex. That is the infra part of the infra-petrous approach. So let's see.
That's exactly what I said. That whole block
below
of
is the below is through the nasopharynx between the two eustachian tube is the transodontoid approach to the foramen magnum. If I start drilling a 3 centimeter thick bone, it will take 3 hours for this approach. That is transodontoid approach to the ventral aspect of the foramen magnum. To the lateral aspect of the foramen magnum, we discussed during the paraganglioma surgery, the far lateral approach. This is to the ventral aspect. Yeah, navigation is must there. Yes. Yeah. Suction. See, Narayan, my drill bit which was broken, had this been there, I would have finished the pterygoid drilling in 2 minutes.
That's why I'm suggesting maybe you
that
can
is the irrigation, suction, and that is so fast cutting. That is, I don't need to remove the drill again and again for that.
No, I can see the drill is cutting not cutting too well.
Yes.
So if you want to
the
quit
thick bone is still there. And
we can do it later.
For everyone, this is V2, and that is the level of the floor of the middle cranial fossa here. And this is behind that. Behind this posterior part of the upper part of the pterygoid is going to be the V3.
V3.
And for that, I may remove a little bit of the, give me the debrider, straight debrider. Let me show it from here quickly after removing the lateral pterygoid muscle. See, this is lateral pterygoid.
Yeah.
This is all maxillary artery. See the tortuous course of the maxillary and its branches.
Yes.
It comes from behind the neck of the mandible, anterior to the exoneratory canal. And see how it gives, and it gives 12 branches in its course. 12 named branches until it continues as a sphenopalatine. All are important. Section banda. So one of its branches, the middle meningeal going up behind the foramen ovale, is again a very good landmark for the carotid artery. Middle meningeal, and you remember in the lateral skull base approaches, we consider it crossing the carotid artery laterally, the petrous carotid. That's a landmark for petrous carotid. See, I am removing this part of the lateral pterygoid muscle. The branches, the V3 comes down from the middle fossa like a horse leg. It puts the leg over the carotid and comes down. It is like that. Something is jumping over the carotid to come down. And it divides immediately into 2 divisions. And out of which the posterior division is very important. And this runs behind the lateral pterygoid and over the medial pterygoids. All these branches going down. And it is here that chorda tympani now joins the lingual nerve, which is the branch of the posterior division. See how bulky this lateral pterygoid is. How bulky muscle it is. Oh, I don't know.
Yeah, I think we're coming close to ovale. That's ovale already.
Yes, that's what I'm coming to. Foramen
That's ovale
ovale.
already, yes. Yeah.
That's foramen ovale.
Yes.
See now. That is foramen ovale. See this?
Yeah, we can see
very well.
This is
So
V3.
the foramen.
This is the V3 which is coming out.
Yeah. So the foramen
Now my
rotundum is
petrous
in colon
carotid.
cut.
My petrous carotid is exactly 4 millimeter behind it, the horizontal petrous carotid. See this from foramen lacerum. From foramen lacerum, the petrous carotid is running posterolaterally. And from the posterior surface of foramen ovale, if I drill this bone is a centimeter thick bone. If I drill this, I will be right on the horizontal petrous carotid. And just behind it, if I follow, I can show you the middle meningeal and the foramen spinosum.
Sir, can you show the petrous carotid becoming the paraclival carotid?
Yes.
Sir, Palaniappan from Trichy has been requesting.
Oh, Dr. Palaniappan is always good questions, but showing that that will require drilling of this entire. I will start drilling. It may take 1 hour. See, this entire bone has to go. Entire carotid will come out.
Satish,
yeah.
Don't rush. There's a beautiful anatomy over here. I think you should keep it for a second session. There's a beautiful anatomy from.
And before that, Narayan, let me show something about this V3. This V3 here coming down, you know, it is a main trunk and it gives rise to a branch to the tensor tympani and through the nerve to medial pterygoid here from the main trunk, section there. And see what I'm showing laterally from the posterior trunk, very important branch. Inferior, see this auriculotemporal nerve. See the laterally. Let me show just a minute. Can you see this nerve going laterally?
Yeah.
Yeah.
From V3. This forms a loop around the middle meningeal. Yeah, divider there. See this now.
Yeah, very thick.
That is auriculotemporal. This from the posterior division. Other two branches from the posterior division are lingual and inferior alveolar.
Alveolar, yeah.
See this. Now this now going laterally. See this? This is auriculotemporal and this covers the middle meningeal in the loop, which is immediately behind this. Immediately behind is the middle meningeal with the foramen spinosum. This is auriculotemporal nerve. Can you see?
Yeah, very nicely seen.
Going out. And now the two nerves going down from here are the lingual medially and the inferior alveolar laterally. See that coming into the picture?
Yeah, very beautiful.
And behind the lingual here, is somewhere the chorda tympani joins the lingual, right here in the infratemporal fossa. See this lingual?
Yes, sir.
And this is chorda tympani joining the lingual. This is chorda tympani. This is chorda tympani joining the lingual nerve right over here. This is for Dr. Tarabichi. Chorda tympani. No, gosh, please.
How far is petrous apex from here?
Petrous apex is 1 hour drilling.
Yes.
In what context I tell you? In distances or drilling?
Thickest one, very thick one.
See, petrous apex is, let me show you, here, behind the carotid. So this huge chunk of bone, if I remove, every area will be clear. But that burr is not here, so this will take hours and hours. See the main trunk? Giving rise to the branches. So the lingual nerve joins the chorda tympani joins here the lingual, the inferior alveolar, that goes down laterally into the mandibular canal, the inferior alveolar canal of the mandible. See the lateral limit of the infratemporal fossa is mandible. Here I can feel the mandible here. The temporalis muscle and the mandible. See, this is temporalis muscle. This is temporalis. This muscle is temporalis, and laterally I can feel the mandible. Okay? And the deep lobe of the parotid behind. So, this inferior alveolar goes laterally here and enter the mandible into the inferior alveolar canal, and through which it comes out of the submental area as the nerve to mylohyoid, which supply the anterior valley of digastric as well. lingual nerve, inferior alveolar nerve. And see this muscle which I removed is the lateral pterygoid. And the muscle on which they are going, this one is medial pterygoid. See the direction of fibers of the medial pterygoid.
Yeah.
They are going down to the angle of mandible. It inserts on the angle of mandible from the pterygoid process to the pterygoid plate to the angle of mandible behind. This lateral pterygoid has a direction superiorly to the angle of the neck of the mandible. Okay? So see this box is infratemporal fossa. Still it requires dissection in
Satish, enough.
In detail. This is infratemporal fossa. Okay?
Yeah, wonderful.
Any questions?
Excellent dissection.
Rajeev, ask him to stop now. Enough. Be kind to him.
Yeah, already given instruction 20 minutes back.
No, but tell him now it's off.
Excellent, Satish. Well done.
Enough.
Excellent dissection, sir.
Brilliant, sir.
We don't need a textbook. All we need is you. Thank you very much. Beautiful dissection.
It cannot be finished.
Satish,
so
congratulations. Fabulous, fabulous
man.
dissection. Absolutely fabulous. Glued to the screen.
Beautiful dissection. Lovely.
Satish, Mr. Grey, blue, yellow, green, all colors, not only grey. It's of the Grey's Anatomy.
Satish, fantastic dissection, and I think we must all put our hands together and just for a second,
come on. I will put up hands together for you guys.
Well done.
Joined. I'm extremely grateful to Prabhakaran.
No, I'm saying
for believe me,
Satish,
for staying with us. Samir, Narayan, everyone. Vinod Felix, Dr. Omura, everyone who joined us, and of course Keetne sir, who is always is a father figure for us.
Satish, just one word of gratitude. This person who expired yesterday has taught us so much. I was telling to put together for that person.
I'm really grateful to these guys. You know, our communities, they have now, how many consents of people who will donate their body, 40,000.
Yes. That is the biggest.
40,000 people have consented to donate the body for teaching and training.
Amazing.
Great, sir. Great.
Amazing.
Satish, Stamberger is looking at you from there and smiling. Can you see that behind you?
Really, sir. Sure. Yeah, beautiful.
He is amazing, sir. He is phenomenal. Because of the Stamberger, today we are into this science of sinus surgery. Otherwise, see how many people, how could they have been benefited. The Stamberger created the phenomena, we just are following him.
But you probably don't know what a great phenomena you are already, Satish. And we are only worried what's going to happen to you 10 years and 20 years down the line.
Once again, sir.
Okay, guys.
Big thanks.
Bye for now. Satish,
All right, thank you, sir. Thank you, sir.
Thank you.
Thank you, Prabha. Thank you once again. Keep in touch.
Good night. Happy Father's Day, everyone. Good night.
Thank you, Prabha.
Bye.
Good night, Prabha, sir.
Night.
Thank you.
As regards to questions, sir, there are a few questions which have not been answered. I think we can take them in the next session.
Yeah, if you have their mail ID or number, we will send them answers.
Yeah, or else we can discuss these questions in the next session, and few of them are related to JNA. So anyways, we will...
We can keep in the next session.
That will cover on Thursday in detail in live surgical session.
So many questions are there.
Thursday is a live surgery and Sunday again is a cadaver and live surgery on facial nerve. And that will be everything dedicated to the facial nerve, right from origin till destination.
Satish, the timing for next week is the same, starting at 11 o'clock?
Yeah, 10
let's see, today 11, because we got the college, this dissection lab later, they had some ceremony in the college. So hopefully if we get earlier, like last time we got 10 o'clock. If we get 10 o'clock, half day will be cadaver and half day will be live surgery. So that we can show some nerve anastomosis like fasciomesenteric, in parotid and other things.
So guys, we need to thank the whole team of Satish Jain, people who are behind all that.
Yeah, I'm
very
grateful to
and all, everybody,
Sandeep and
thank
everyone.
Thank you very much. And there is a superstar lingering behind there, Dr. Sandeep Naidu.
Yeah, Naidu has been a great help.
From this man.
Idhar Aja.
Utterly sincere. Yes, that is
Naidu
Dr.
has
Naidu.
been
Ever smiling, ever smiling.
Ever smiling.
Yes.
You'll never see him crying.
He is the next superstar. Naidu, best of luck, man. You're doing great.
Superb job.
2025, look out
Without
for this
Naidu, such things are not possible without him. Believe me. He's been the backbone.
Brilliant. Brilliant.
But sir, hats off to you for the wonderful energy level you have, right from 11 o'clock till 6 o'clock now. Tirelessly, you have worked so hard. It's unbelievable.
Thank you, sir. Thank
I've
you.
got messages from all across the world, from
Yeah,
Nepal.
see you Thursday, 4 o'clock. GNA, carotid body tumor, some ossifying fibroma, and some other skull-based case. Something like that.
Wow.
But mainly vascular tumors.
Good job.
Okay, sir. Thank you. Thank you all.
For the day. Thank you, Mr. Varman.
Thank you, Sun Pharma, for all the help. Thank you for organizing this.
Thank you, sir.
Thanks, Rajiv and Paramita, for everything.
Thank you, Samir. Bye.
Thank you very much. It was just.
Thank you, Amit.
Just
Amit,
fantastic.
thank you.
I think
Okay, bye, sir.
those superlatives can describe today's session. Thank you.
Thank you.
The entire team